which is easy to use, and if it is a little bit more beneficial than Sentinel, it would be an outstanding achievement.
No, I agree with you. I think just last night I did a case and come back. Now I had a call saying he's had minor stroke-like symptoms. It's moving the limbs, but a little bit of speech disturbance. They're sending for imaging now. That's the problem we have, selecting the patient. Because this guy was 68, bicuspid, 1 predilatation, 1 balloon expanding valve, perfect result. So we will not be able to tell from the evidence what we have, which one, which will not. But I like the last slide you showed, the bicuspid and the AFs, and also the sort of valve-in-valves. And that contributes to more than 50% of the cases in India.
Right. And I think, as you said, this is such a, it stays in memory, right? That, I enrolled in a P3 a patient, and I could not use a Sentinel because at that time we were not allowing in the Partner 3 trial use of Sentinel, and the guy has stroke. I follow him. He's good, but he is slightly aphasic. And, when he comes, you feel bad, that he was completely like a professor. He was doing very well, and now you talk to him, he struggles. He's doing okay, but, it's just okay. It's not the reason we did this tower was just to improve his quality of life. And
I think the cost of the device has come down in India now, so it's become an affordable procedure. So adding cerebral protection is probably not going to cost much for them. So as the selected patients you showed, we should seriously think about using them in the Indian population because higher bicuspids, higher valve-in-valves.
Exactly.
I would like to ask a question the other way around. Has it happened that you have used Sentinel and despite that the patient developed a stroke? Has it happened anytime?
Yes. So that's why I presented the data also from the Sentinel trial, and in our Cleveland Clinic also we looked at all our Sentinel patients, and even the failure of Sentinel, because I'm very worried about it, that if we try very hard and if that caused the stroke or not. So we have not seen that the failure of Sentinel, or sometimes we put one filter and not the other one because it doesn't want to go in the carotid, or there is anomaly, or whatever the reasons are. So those patients have also done well, at least in our experience. But I would suggest that if you are having trouble putting a Sentinel device, if you are going to use contrast, if you are not comfortable, these are not the good signs, because the patient in Sentinel trial that had a stroke with the middle cerebral artery, the protected tower patient, there was some struggle putting the Sentinel device. And so I am concerned that one patient, I'm not 100% sure, there's no way to prove or disprove, but I try to look at all the case reports and try to understand that why this patient had it. So this is a possibility. So you're right, that there is and of course Sentinel doesn't cover everything. So this is an important part also. Yes, Ajay.
No, I was just going to say it's a very analogous situation to the intravascular imaging in the coronaries in a sense, but what's amazing to me is that there are very few interventionalists who, for their own mom, wouldn't use the device. Yeah. And, when you see that problem happening and you would insist on using it for your own parent, then you should kind of treat your patients the same way. And I think a lot of it is they use the cost and everything else and the data as an excuse not to use it.
And I think it's a good reason not to use it also because it simplifies the procedure. But I think we want to make sure that this is a big investment to do a TAVR, and you want to optimize the result. We do need better devices, and I think that's the point. Sentinel is not the ideal device. And we're out of time, but Juan, I want to ask you one question. You've been at the forefront of innovation, a lot of different devices. We're doing a 10,000 patient study to show a benefit of a device. How are any of these new devices, Samir showed 8 different startups. How is innovation going to occur in the field if the trial right now is 8,000 patients, I guess?
Very, very challenging. And that happens when you're, looking to show a difference of 1%, between a device and a control group. I think it's very challenging. That's the bottom line, and that's why big companies need to take over and do this type of trials because startups will not be able to do it. But one of the things about having a new device is running these trials actually is very challenging, and you know that. And it's difficult to determine the real time when actually a stroke event happened. especially in some cases in which you have imaging evidence of a stroke, but actually clinical absence or clinical symptoms of the stroke. So one of the things is I am optimistic that when new devices that are simpler to use and in a way safer to deploy and to retrieve could potentially actually give us a signal in these high-risk populations.
And MRI-related endpoints may become possible. Although, as you know, with Sushil and I, we had a hard time because many patients cannot get MRI in the trial after you do the TAVR, and those are the patients who probably may have an event. So, as you pointed out, it is difficult. Like Gusto trial, this is like doing a Gusto trial because 1% difference with the SK and TPA. So it's going to take a large number of patients to do the trial.
And we don't know the right endpoints. The VARC3 is now said it's 72-hour time frame. It may be relevant, but this is a great discussion. Thanks for a great overview and a great start to the meeting. So we'll move on to the next session. And Srinivas, you want to start?
Thank you again. I think we had a wonderful live case followed by live case TAVR and stroke keynote address by Samir. Thank you, Samir, for in spite of all the schedule you gave time. We now go into the imaging session. Before we go on to CRF and all of us believed strongly in collaboration, we made a brief video for 1 minute or 2 minutes it plays. Gary is coming on to welcome, sir. Can you just play that intro video because it didn't run before?
History is proof that great partnerships have sparked innovation and driven progress. Larry Page and Sergey Brin brought the internet to our fingertips. Leander Paes and Mahesh Bhupathi elevated India to global prominence in the world of tennis. James Watson and Francis Crick illuminated the structure of life. Together, the heart team of cardiac surgeons and cardiologists have brought brighter outcomes and results to patients. Cardiovascular Research Foundation, USA, and FACTS Foundation have forged an incredibly successful partnership in interventional cardiovascular medicine. This decade-long synergetic
Thank you. Hope you liked that video. And now we'll request Dr. Sridhar Kasturi, my good friend, to come on to the podium. Other panelists who are there, request to occupy the dais. Pankaj, Sanjay Sharma, Harish, Jawhar, and Ravi Teja, Harish Singh Tomar, and Priya Pamalkar. Whoever is here, I think they're joining. We'll go, we'll have this talks coming up with Dr. Gary Mitz, Dr. Dilip Kumar, and Dr. Deepak, and both IVUS and OCT will be covered. I request other panelists, whomever, feel free to come and join whoever is listed in the program. Thank you. With this, I request Dr. Gary Mitz, as particular that he should come along with Akiko because both of them are authorities in IVUS and imaging. So with this, I request Dr. Gary to talk about basics and fundamentals of imaging.
Thank you very much. Can you hear me? Yes, okay. So I'm going to talk about fundamentals of intravascular imaging. These are my disclosures. No one learns imaging from a lecture. There's only one way to learn and interpret IVUS or OCT, and that's by looking at images and using them in the cath lab. IVUS or OCT should never be evaluated in a vacuum. It is only one component of the clinical scenario that includes patient information, non-invasive information, coronary angiography, procedure characteristics, and so on. The marketing groups of Abbott and Boston Scientific have commissioned algorithms to aid the novice in performing IVUS-guided PCI. This is Abbott's MLD Max. Of course, you have to ignore the fact that apposition is not a predictor of events. This is Boston's IVUS 123. Again, get rid of malapposition. But these are really graphic marketing stunts. They don't really add much. You should always begin with pre-intervention imaging, where the important parameters are vessel size, lesion length, plaque composition, especially calcification, and minimum lumen area. People think that IVUS and OCT measure differently. Well, that was true in standard definition IVUS, which oversized compared to OCT. But when we now talk about HD IVUS, they measure almost the same. And in my opinion, standard definition IVUS should no longer be used. And when we're dealing with high definition IVUS and OCT, the measurements are effectively identical. When assessing an intermediate lesion that's in a non-left main location, the conventional wisdom is that you should use physiology. However, then came Forza and Flavor. Forza came first, compared FFR versus OCT in assessing intermediate lesions and guiding stent implantation, and the outcome, if anything, was better in the OCT group. Flavor was a similar study randomized to FFR versus IVUS with specific criteria. The outcomes were identical. So my takeaway is that today, when assessing an intermediate lesion with either IVUS or OCT, you can use IVUS or OCT to decide whether or not to stent the lesion, just recognizing that you will place more stents with imaging to decide whether or not to treat than with physiology to decide whether or not to treat, even though the outcomes will be identical. When sizing a stent, you have to understand that the angiogram is misleading. And in general, the angiogram shows that the lumen area is smaller than the IVUS measured lumen area, and the discrepancy is especially important in relatively small vessels. This is even more important when you realize that there is silent plaque in almost 100% of arteries that you are stenting. And so Greg Stone showed years and years ago in a study called the Clout study that you can safely size into the plaque midway into the vessel wall to use a larger stent size to get or larger balloon size to get a better acute result. Now, as I mentioned, you size midway into the vessel wall, but you also identify landing zones. The best landing zones have the largest lumen with the least plaque and the least amount of lipid, and avoiding calcium and muscle bridges. So here is an IVUS pullback. This is distal, this is proximal, largest lumen with the least plaque. Here's an OCT pullback. Again, largest lumen with the least amount of lipid. You don't want to end here, you want to end here. You obviously don't want to end here, you do want to end here. And that gives you length, and sizing mid-wall gives you size. So the next question becomes, can the EEL be identified and measured at the distal reference? If the answer is yes, you size to the EEL and then you downsize to the nearest stent. And if you can't see the EEL, you measure the distal reference lumen and you upsize. Those give you mid-wall stent sizing. And of course, we've already discussed length. Now, in terms of plaque composition, I will not go into these algorithms in detail. I assume that they will be available at least on TCT-MD, and it's a combination of saying, is the plaque within the lumen of the vessel wall? Is it protruding or not protruding? Does it shadow or does it not shadow? For example, if the plaque is in the vessel wall and you have attenuated plaque, it means that it's lipid. If the plaque is in the vessel wall and it shadows, particularly with reverberation, it means that it's calcium. If it doesn't shadow, it means that it's probably fibrotic. Protruding plaque, these are thrombi, and this is a calcified nodule, which I'll talk about later today. Similar algorithms with OCT based upon the presence of attenuation, high attenuation, red thrombus, low attenuation, white thrombus for plaque that's in the lumen, and high attenuation lipid, low attenuation calcium for plaque that's in the vessel wall. Here I've compared normal, lipidic, fibrotic, and calcified plaques by IVUS and OCT. This is normal IVUS, this is normal OCT. This is lipidic IVUS, this is lipidic OCT. This is fibrotic OCT, this is fibrotic IVUS, and this is calcified IVUS and calcified OCT. They both give you a good sense of plaque composition. The one circumstance in which OCT clearly has an advantage is in thrombus detection, this being red thrombus and this being white thrombus. Why do I mention that? Because especially in non-STEMI, at least half the time, you either have no clear culprit or you have multiple potential culprits. And this case example from one of our former fellows, Takashi Kubo, there's a potential culprit in the LAD and the circumflex, and you can see there's an old plaque rupture in the LAD, there's no thrombus, but there's thrombus in the circumflex, identifying this as the culprit lesion. This slide shows you 15 different devices, IVUS and OCT, looking at calcium. And they all have the same configuration. By IVUS, it's shadowing with reverberation and hyperechoic or very bright plaque. By OCT, you can measure calcium thickness, and you have clear demarcation in the interior and exterior border of what is calcified. And again, comparing IVUS and OCT, here is deep calcium by IVUS, deep calcium by OCT, that's kind of hard to tell, superficial calcium by both, concentric calcium by both, eccentric calcium by both, and a calcified nodule also by both. This is a paper that I wrote 25 years ago, and it showed that IVUS detects calcium twice as often as does angiography. There's a certain small false positive rate by angiography, and it isn't until you get 3 or 4 quadrants of calcium that the angiogram becomes even marginally reliable. Akiko and the team repeated this with IVUS, OCT, and angiography with almost the same results as we showed in 1995. There's a slight advantage to IVUS in detecting deep calcium because if there is lipidic on top of deep calcium, OCT will not penetrate to see the calcium, while IVUS does not have that disadvantage. Well, I've gone through the pre-intervention algorithm kind of quickly, but you always end with post-intervention imaging, where the important parameters are number 1, optimal final lumen dimensions, i.e. stent expansion, no geographic miss, no edge plaque burden, or large dissection or a lot of lipid, and no complications. So this is an example that I often show. Notice the Impella device. It was a high-risk PCI, not a bad angiographic result, but by IVUS, the minimal stent area is only slightly bigger than the IVUS catheter because of concentric calcification. This slide summarizes all the literature of predictors of events by IVUS and OCT. Number 1, number 2, and number 3 are under expansion. Number 4 is geographic miss. Everything else is irrelevant. What is a good target MSA? Well, by IVUS, roughly 5.5 is the minimal acceptable stent area that separates events from no events, and that number comes up in just about every study. But if you can go from 5.5 to about 7, you can effectively abolish restenosis in non-left main lesions, and that was also shown in Syntax 2. Most recently with Illumium-4, almost the exact same number by OCT and MSA of 5.2 and lower, the event rate then skyrockets. Larger than 5.2, almost no events. People worry about stent oversizing, overexpansion, causing adverse outcomes. This is a huge study from the Stanford University Core Laboratory of almost 3,000 lesions, showing that getting a stent area larger than the reference, i.e. stent expansion more than 1, does not increase events during follow-up. We get stents in a box that has a compliance chart. And I often show this and say, okay, assume this is a compliance chart. Assume that you are planting a 3 millimeter stent at 16 atmospheres. What is the minimal stent area that you can expect? And most people say, oh, it's 3, it's 3.24, but the truth is it's only 2.4. And we've done this experiment many times. You get 3/4 of the diameter and 2/3 of the area predicted by the manufacturer's compliance chart. And that's because expansion is not determined by the stent design, it's determined by the plaque into which you implant the stent. In terms of geographic miss, by IVUS we look for a plaque burden of less than 50%. By OCT we look for an arc of lipid less than 180 and a lumen area in the reference adjacent to the stent of more than 4 square millimeters. If you notice, I have not mentioned a word about malopposition. On the left, you see all the literature saying that malopposition has an adverse outcome. On the right, you see all the literature showing that malopposition has no adverse impact on outcomes. The literature overwhelmingly supports the idea that acute stent malopposition is irrelevant, with one exception. Here is the exception. At the proximal edge of a stent, if you have malopposition and you then want to rewire, it's easy to get the wire behind the stent and then deform the stent. So the approach is very simple. You identify the distance from intima to intima, in this case 5 millimeters. You then post-dilate a 5 millimeter balloon at nominal pressure, and you get rid of the malopposition. You don't need high pressures because there's no plaque behind here. I mentioned MSAs in non-stent intervention. This is the classic study from Sujin Kong, published in 2011, and this was based upon angiographic follow-up. Now, more recently, Excel has indicated that a minimal stent area when stenting the left main of 6 in the circumflex, 7 in the LAD, and 10 in the body of the left main. But then back to Assam Medical Center, 5-year clinical follow-up data comes up with an MSA of 12 in the left main, 8 in the LAD, and 6 in the circumflex, and presented at TCT last fall, similar numbers with single stent as opposed to deliberate 2-stent strategies. This is my interpretation of the editorial by Akiko and Sri Bangalore that accompanied the recent paper from Assam Medical Center. These are the historic Sujin Kong numbers, these are the Excel numbers, and if all possible, these are the optimal minimal stent areas when stenting a left main. If you can't achieve these, what do? You look for some measure of stent expansion. This is from ADAPT DES, and we look for expansion that's at least 40%. And in that study, if you can't achieve an adequate minimal stent area, your next best goal is to achieve a minimal stent area of 40% of the EM area at that particular location. Now, in this slide, I summarized all the literature of the studies with IVUS or OCT guidance and the criteria for post-PCI optimization and how often it is achieved. In general, it's achieved only 50% of the time. Most of the time, or half the time, you don't get the result that you really would like. But even so, if we look at the literature, this is all the literature on imaging guidance implantation of drug-eluting stents. IVUS in white, OCT in blue, and IVUS and OCT in yellow. I'm only going to share with you two of these studies, meta-analyses. This is by Greg Stone, published in The Lancet. And you can see that direct evidence shows that imaging guidance reduces target lesion failure, as well as cardiac death, target vessel MI, target lesion revascularization, stent thrombosis, all-cause mortality, all MI, and target vessel failure, with no real difference between IVUS and OCT. So we now have hard evidence that imaging guidance not only reduces restenosis, but cardiac death and all-cause mortality. And this is another meta-analysis from the UK, where they looked at the number of procedures imaging guided that are necessary to reduce one mortality. And as the syntax score goes up, the number needed to image to reduce mortality actually goes down. This is pooled data from IVUS XPL and Ultimate, showing that imaging guidance reduces cardiac death and cardiac death, MI, or stent thrombosis. And if you achieve optimal implantation criteria, you have an event rate, a mortality rate at 3 years of 0.5%. In a single study from Korea, Renovate Complex PCI, there was a reduction in mortality from 3.8% with angiographic guidance to 1.7% with IVUS guidance at 2 years of follow-up. In most cases, IVUS and OCT can be used interchangeably with equal effectiveness to optimize PCI results, but with a few exceptions. As I showed you, culprits in ACS favors OCT, suspected SCAD favors IVUS, aortoosteal lesions favors IVUS, left main PCI favors IVUS, CTOs favor IVUS, stent failures favor OCT, and chronic renal insufficiency, in order to eliminate contrast, favors IVUS. So this is my last slide. It takes the viewpoint that the most central imaging modality in the cath lab is not the angiogram, it's intravascular imaging, because it is useful in every aspect of a PCI procedure, from a diagnosis to pre-PCI planning to stent optimization to minimizing contrast and to assessing stent failure at follow-up. Thank you for your attention.
Thank you, Gary. Please join. I think after a great talk, Ajay was very particular to have interaction discussion after the end of each talk. So many of the labs in India now started acquiring new machines of imaging, be it by IVUS or OCT. I thought it's a good opportunity to interact with Gary, Akiko, and others. So now there's no more discussion, Gary, about whether it is beneficial or not. Now it's proven beyond doubt that imaging improves outcomes, not only in the form of events, but also mortality is reduced. And we also learned that new data has come up. The old criteria of Kang is now modified, and now it is improved to 7, 10, and 12. These points are well covered. Other thing is, after the stents, this is a surprise to me that after the stent implantation, though they say it has 3, but you told that it will be much less than what is recommended, what is actually told by the companies. That was a little, in the sense that a 3 mm stent, when you inflate up to a nominal atmosphere, you were telling it doesn't get into that when you imaging. A little confused. That's why I just wanted clarification on that.
The manufacturer's compliance charts are determined in air or in water. If you follow those charts, you get 3/4 of the diameter, 2/3 of the area, so that a 3 mm stent comes up with a minimal stent diameter of 2.4, and instead of being 7.5, it's maybe 5 square millimeters. So, you know, those charts only tell you that the stent won't get bigger than what's on the box, but don't expect to ever reach that. And we've done that experiment 4 or 5 times.
A wonderful overview. Particularly the imaging is very useful when the diffuse long lesions are there, where sometimes we underestimate the vessel size. Like it may looks like a 2.5, especially in patients with CTOs with long-standing reduction in the flow, distal flow, and very thrombotic lesions, very high thrombotic lesions. And these patients, when you do the balloon dilatation, there may be a layer of thrombus between the vessel wall and the lumen. That time when you implant the stent, there is a layer of thrombus between the vessel wall and stent. So angiographically, it may look normal. Many times, sometimes patients may develop stent thrombus the next day. But when you do the imaging, most of the time, the importance imaging, correct sizing. The diameter, choosing the landing zones, as sir mentioned very clearly, and that geographical miss should not be there. But definitely all the studies, the last year almost the Greg Stone's meta-analysis, IVUS study, Elimini 4 and October trials, consistently showed 50 to 60% reduction of stent thrombosis. And almost 30 to 40% reduction of the death rate. So there is a need of the hour is to use the more and more, particularly in complex PCA, where bifurcations are there, diffuse long lesions, CTOs, multivessel disease. So a right patient selection is very important, irrespective of the imaging. As sir mentioned very clearly, use OCT in a certain subset of patients where it's required, and IVUS also should be, IVUS can be used in any subset of patient, but OCT, LV dysfunction, renal dysfunction, we have to be very careful.
Madam, you want to say anything?
If I can make 2 or 3 comments. Number one, 90% of the time you can use IVUS or OCT. It may vary in your practice. If you're a primary PCI facility with lots of STEMI, OCT will be more beneficial. If you get if you're referral base for stent failure, OCT is more beneficial. If you have a high CTO practice, you should be using IVUS. That's number one. Number two, I didn't discuss it, but there are 4 or 5 studies now showing that imaging guidance is cost saving once you factor in long-term patient outcomes. So the cost argument no longer holds. And finally, I think what we learned by comparing Renovate and Aluminum 4 is that imaging is most beneficial in complex lesions. A complex patient, diabetic patient with a simple lesion does not benefit as much as a non-diabetic patient with complex anatomy.
I think the bell is ringing saying that it's time up. We'll have further discussions. Most of the talks are with imaging. And competition benefits both patients and the technology improves. Intravascular ultrasound, when Boston had, nothing was progressing much, but we have other companies who are also developing this technology. And that healthy competition gets us some of the important newer things like co-registration and all that which was there in OCT now is possible in IVUS. I think I requested a good friend Dr. Dilip Kumar from Kolkata to cover this IVUS co-registration tips and real-time guidance. I think after his presentation for 10 minutes, we'll have again some discussion after the talk. Over to you, Dilip.
So, good morning, everyone, and thanks, Dr. Srinivas Kumar, for inviting me and giving me this opportunity. So, I'll be talking on IVUS co-registration tips and real-time guidance. These are my disclosures. And before I get into my talk, let me show you some of the data which was gathered by NIC and presented, I think, a month ago. This was the use and utility of IVUS during PCI in India. It was 1.96% in 2022 to 6.3% in 2023. So really a massive jump, but still it's a far cry for IVUS penetrating into normal practices. And coming to physiology, it is less than 2%. And when we talk about the IVUS facilities, this is majority of the times it's the Boston's IVUS being used, 75 to 80%. And the rest 15%, the Philips and other IVUS are being used in India. So why I'm presenting this data? Because the co-registration, which is available with Philips, and that is commercially available, used in multiple places. But in India, the maximum penetration is of Boston's, and the AV-Vigo system of Boston for co-registration is still awaited. So, and that's why some of my slides will be from internet, and I'll be showing some of these slides from the internet. So to begin with, this is a patient of 62 years old, male, diabetic, hypertensive, presented with chest pain on minimal exertion for last 3 months. He had a bypass surgery done 11 years back. Lima was given to LED and SVG was given to PDA. And now he has refractory symptoms, and this is the angiogram, which we can see LED is CTO, and Lima is not working. And this sole, I think, surviving graft, which is filling the RCA as well as the LED. And then through wire escalation, LED, the disease was negotiated. And this was after the balloon dilatation. You can see here how diffuse the LED lesion is, LED vessel is. And when we go through the imaging, all these markers, red markers, are all approximation. These are not exactly co-registration, and there are chances of errors, and that could be 1 millimeter, 2 millimeter, and even can more. It can lead to geographic miss, and it requires more of injections and little approximation rather than precise landing zones and precise nailing the entire vessel with proper stenting. And that is where co-registration comes into the picture. We do this. We do get this kind of results with good MSAs, but still precision is a little bit compromised. And if we can get something like this, cursor moving down and up, and you're getting the IVUS image co-registered, then your results will be much better. So what all we can sync and co-register? We can do IVUS with fluorosyncing. We can do physiology with fluorosyncing. We can do imaging, and as well as physiologic with syncing with fluoro. And these are not only the kind of 1 or 2 studies on algorithms. It has been used, validated, improved, and now all the systems which are there, they have been thoroughly validated, and the margin of errors are really, really less. I will show you some of the data here. So let's look at this vessel. It's a diffusely reduced vessel with a mid-LED stent, and this is co-registered on IVUS. And how we exactly see that co-registration is perfect. You can see this yellow dot here, and you can see the septal, which is rising just proximal to, or at just the yellow dot, and you can see the septal rising here. And then you can also see the long axis view, and then you can get to know that your co-registration is good, and you can reconfirm it while getting this yellow dot here, pulling back, then the IVUS, looking at the IVUS and the fluoro, and you can see the yellow again corresponding to the side branch, and this side branch is looking up here. So this is how we kind of test and confirm the co-registration, so that our kind of interpretation and finally the treatment becomes more precise. So how do we do that? We give generous nitrates and vasodilatation agents, Fluoroscopy setting has to be at 30 frames per second, not at 15 or 10, which we used in CTOs, and sometimes when we try to go at lower radiation, it has to be 30 frames per second. Guiding catheter tip, entire wire inside the artery and the vessel to be seen without panning. And then these are the kind of views which we take for the LAD. It's mostly the epicranial for co-registering, epicaudal for circumflex, and LAD cranial, elocranial for RCAs. And then we do IVUS pullback at 1 millimeter per second till it reaches the guide. Then we can stop on IVUS, come off fluoro, and then we can co-register and look at the images. So this patient had mid-LAD stent, which was there, and which shows a MLA of 3.68, distal reference of 3.27, and the proximal, where you can see a large plaque there, is more than 70% plaque, and a MLA of 3.03. And then we can see with co-registration exactly matching up the IVUS measurements, as well as your co-registered fluoro measurements. Then we can deploy the stent, and then we can, since we have a common reference, ready reference with us, we can look at the MSAs, distal reference, and the proximal reference. And we all know the kind of the criteria which we, assume that our stent expansion is appropriate when we get a kind of, when we have a vessel of less than 9 millimeters square, and if we get an MSA, which is 90% of average proximal and distal reference lumen, or 100% of smallest, that is distal reference, or a vessel which is more than 9 millimeters square, we need to get a 80% of average proximal distal reference lumen, or 90% of the smallest or the distal reference. So we have a kind of a ready reference with MSAs available. We can quickly go through that and make an idea that our stenting is perfect or not. So this is how the co-registration helps us, and it helps us immensely in reducing the geographical misses. So this is again, we can see here the co-registered lens segment to IVUS and the fluoro, and they are matching up, and we have a kind of, we can also match our MSAs with this. If we have post-dilated with 3.5, we should get at least 8 millimeters square. If it is 4O balloon, it should be 10 millimeters square. It is 4.5 in, especially in left mains we do, and we should getting more than 12 millimeters square MSAs. What about adding up some of the another features, like having check on cherries, cherries on cake? So you can see if you co-register physiology as well as the IVUS, you can have a better precision and better understanding of entire problems. And you can see the dots, and when we talk about co-registering and tandem and diffuse lesions, there's always IFR which gets more kind of preference over FFR, because in FFR, two adjacent lesions can interfere when there is a stage of hyperemia. But IFRs are localized. These the resting flows, the adjacent lesions are not interfered, and you get precise, IFRs and step-ups where there is a maximum hindrance of the flow. And you can see here, there is in the diffuse lesions, the FFR goes down gradually and gradually as two lesions are, interacting amongst themselves. But in IFR, you can exactly pinpoint where it's exactly dropping the IFRs and the pressure drops. And that is where you can see the lesion 3, there is a drop in IFR is lesser, but when you go up 2, there is again a drop, but as lesion 1 and 2, the drops are maximum. Probably these are the lesions which needs to be fixed up. And this can be co-registered as well as with IVUS, and you get a kind of better interpretation and better kind of information. And finally, we are all looking at AV Vigo system of Boston to be available in India, so that maximum 70-80% of Indian cath labs are using Boston. And once this will be available, this co-registration and all will come into practice with, in the Indian scenario. And finally, this is my last slide. What does it offer? We can do a PCI, we can do IFR pullback, we can see exactly where is the problem, we can do an IVUS, which we do regularly. And what extra it is offering? It's offering us precision. It's offering us, it enables us to minimize the time, radiation, and the contrast. It minimizes the errors, and finally, it boosts the confidence of patients as well as the patient going home. Thank you so much for the patient hearing.
Thank you, Deep. Please join us here. I think I only wish that all these Boston existing machines will be upgraded to this software. Otherwise, you have to buy all the new things. Then it becomes very challenging for all the old hospitals which have this. I wish some of the Boston people are listening. Thanks for highlighting some of these advantages which we are comfortable in OCT, which are now coming into IVUS also. And then probably as many of us need to get exposed more to such technology. And we'll have any questions on the hall?
Can I?
Yeah, please.
I just want to make one point on co-registration that, you know, it's really nice when the software aligns and all of that, but the easiest way to co-register with an IVUS is to put the IVUS live view, you know, do your pullback first, but then put the IVUS with live view at the point of interest, distals of the lesion, for instance, and then just step on cine. And when you do that, I mean, in most cases, for osteal lesion location, for other lesion locations, you don't need a second wire. You don't need co-registration with another IVUS catheter alongside the stent or anything like that. If you just do it that way reproducibly, unless there's massive movement with the breath or something like that, you actually can do 90+% of cases very, very reproducibly. So for most people, you don't need these advanced systems. You can just use the technology you have, but use cine and use your brain with maybe a landmark of the spine or something else to identify exactly where something is.
Ajay is 100% correct, and I'll just add that factoring in side branches as well becomes very useful, because the side branches are there whether you're on an angiogram or an IVUS. So if you want to stop at a side branch, you know where the side branch is. Yes, the co-registration sounds like a sexy next tool for imaging, but we've been doing it for, since the early 1990s, using visual co-registration, just not software-based co-registration.
And just one follow-up comment on that. So in the sort of ultra-low contrast PCI realm, we concentrate on using all of these other fluoroscopic markers to be able to help us triangulate. But the reality is we're trying to push the optimal use of imaging into complex lesion subsets, whether they're ultra-low contrast or not. So it doesn't really matter if you take a 2 cc puff while your IVUS catheter is on live where you can see, and then actually cine that. So what you've actually got is true co-registration, where now you can see with contrast in the artery precisely where your lens is, and you simply land your stent there. Now you have multiple ways of ensuring you're in the right place. And that's probably the easiest way of doing it. Even in ultra-low contrast PCI, the cost of a 3 cc contrast injection is zero, nothing. And all it does is improves your accuracy and safety for your patient.
I think, Ajay, what we clinicians want this, rather than additional all these gimmicks, is the catheter should be more trackable, and you should be able to take these catheters in calcified lesions. That's where I think technology should improve in more miniaturization of the catheter, or some transducer should come on the wire. Those things are more clinically relevant, I feel, rather than this sort of additional things are okay to help us ease the process. But sometimes the real problems we clinicians face is you couldn't deliver the catheter there because of calcium. You though use various techniques like body wire and other things, taking the guide liner inside, all that, but this what is more requirement. Rather than that, actually, research is going on to incorporate OCT and IVUS together in one catheter. And the catheter is becoming more bulkier. I don't think we as clinicians need it, but what we want is the track. Sir, anything?
He's agreeing.
No, I'm disagreeing. There are hybrid IVUS OCT catheters that are the same dimension as the IVUS catheter and the same dimension as the OCT catheter. I heard this at NIC. That is simply not correct. You can have a hybrid catheter, the same size, the same dimension, the same handling as the current catheters. Now, are the current catheters great? No. They need to be better. But to say that, but to not acknowledge reality is just not acceptable.
But the point about the trackability and all of that is very important, because if you think about what's the most commonly used imaging, and first of all, the numbers that were shown for imaging show you how low it's used, but the most commonly used catheter rarely crosses severely calcified and tortuous vessels. So I think that it's a real problem, and there are also tips and tricks. And so for this meeting, one of the things to think about is that if your IVUS catheter is going but it doesn't go, don't keep pushing, because it's a very short monorail that can get stuck. But there are ways you can actually put an RX balloon on the wire behind the IVUS catheter to enable it to deliver a little bit better, as long as you're careful in terms of how you do that. So there's ways to address some of these issues too, but catheter design is an important one.
Thank you. I think we finished the discussion time. If there are no questions, we'll go on to the next talk. Another new modality addition which has happened in the IVUS is the assessment of fat burden. So this combination of NIRS in the IVUS. IVUS needs NIRS technology. I think Dr. Deepak Davidson has experience in that. We requested him to share his ideas about this new addition of this. We have now data which has come up showing that the regression of fat composition, plaque burdens changing, happening with high dose statin, also with inclisiran and other things happening. There's more relevance for this technology also, both not only in regular day-to-day use, but also as research and for further prevention of disease. Over to you, Deepak.
Good morning to all of you. Can I have the slides? Yeah. Good morning to all of you. At the outset, let me thank the organizers, especially Dr. Srinivas Kumar, for having given me this opportunity. Over the next 10 minutes, I'll share with you something on NIRS, the near-infrared spectroscopy. What exactly is NIRS? Near-infrared spectroscopy, it identifies the composition of the plaque. It scans the blood vessel. It looks for the lipids inside the blood vessels, and it gives us a yellow image on the monitor. That's how the display would look like. You could see the chemogram down there. In the chemogram, you could see red areas as well as yellow areas. Yellow areas, it's primarily the lipids inside the blood vessel. Well, what do we look for on the monitor? You look for these yellow areas. When you see a lot of yellow areas on the monitor, it makes us understand that this particular patient has got multiple areas of vulnerable plaques, and this particular patient is a vulnerable patient. Now, it also quantifies the lipids inside the blood vessel. You call it as the lipid co-burden index, that's LCBI. You could have two parameters monitored there. You have two values there, the blue value, the yellow value. The blue one is the LCBA of the entire vessel that's been scanned. The yellow value, it gives the maximum amount of lipids at a particular place. So looking at this LCBA max, you get to know where exactly you have the significant amount of lipids inside the blood vessel, where exactly you have the vulnerable plaque inside the blood vessel. And at this point of time, we do have enough of the data that makes us understand that when you have an LCBA max of more than 400, this particular patients, they correlate with a very high incidence of future MIS. That is, over the next 2 years, they are likely to have 4 times more events when you compare with somebody who's got a LCBA max of less than 400. Well, what exactly is NIRS and IVUS technology? It's a dual imaging technology wherein you have a single catheter which incorporates both the transducers. On one side of the screen, on the left side, you could see the IVUS images. On the right side, you could see the NIRS images. How exactly is this accomplished? In the tip of the imaging catheter, you have 2 transducers. One, it's the IVUS catheter. It looks at the structure of the vessel. And on the other side, you have a couple of mirrors that scans the spectroscoping, that gets the spectroscopic images, so that you have on the screen, you have on the left side, you have the IVUS images, and you have on the right side, the NIRS images. And again, when you look at the NIRS images, you could see here that this actually correlates with the longitudinal pullback of the IVUS images, so that you can clearly understand where exactly in the vessel you have vulnerable plaques, and you could probably extend the stent proximally or distally so that you can cover these vulnerable plaques also. Now, what is the clinical usefulness of NIRS IVUS in our regular practice? Now, you could identify procedural risk during PCA with the help of NIRS. This was an elderly patient, 83 years old, who presented with recurrent rest angina. You could see that he's got a very critical stenosis in the proximal left-handed descending artery. When we look at the IVUS NIRS images, the IVUS shows us that there is a significant lipid pool. You could see that it's an attenuated plaque over there. When you look at the NIRS images, you could see that the LCBA max is almost 722. When you have a huge LCBA max of more than 500, it would correlate with a distal slow flow during the procedure, so that you can be prepared to manage the slow flow in this particular patient. So when we went ahead with stent implantation, despite not doing a post-dilatation, just after stent implantation, you could see that there was a significant slow flow inside this particular vessel, and we prepared to manage that slow flow, managed with intercoronary vasodilators. You could see that that's the final result. Still, you could see that the diagonal is not really flowing well. So just to highlight the fact that when you have a huge amount of lipid pool inside the vessel, this correlates with slow flow inside the blood vessel during the intervention. This is a very similar lesion in a lady in a different person. You could see here that in the IVUS, you could see that there is significant amount of lipids. You could also see that it's an attenuated plaque. On the lower frame, you could see that the NIRS imaging shows us that the LCBA max is significantly less than 400, which means that the lipid pool is not huge, so then the chance of slow flow is less likely. Went ahead with stent implantation, post-dilatation, you could see that there was no significant slow flow during the procedure. So NIRS gives us an idea whether you would have a high-risk procedure. Are you likely to have a slow flow during the event? If you have a huge LCBA that's more than 500 or so, then you need to be prepared to manage the slow flow during the interventions. Now, NIRS also identifies high-risk vein grafts. This was a patient who had undergone a bypass surgery almost 10 years ago, now an acute coronary syndrome. You could see that in the distal right coronary artery, there is a critical stenosis there. We evaluated with NIRS IVUS system. In the IVUS, you could see that there is no degenerated tissue over there. It's more of a fibrotic plaque. In evaluating the NIRS, we made out that the LCBA max was less than 400. You could see that it's 233. So we understood that it was not a very degenerated plaque over there in the distal vein graft. So we didn't want to go in for a distal protection device. We went ahead straight away, direct stenting, post-dilatation, and you could see that despite not having a distal protection device, the flow is good in this particular vessel. There's another patient who had undergone bypass surgery almost 20 years prior, 10 years prior, angioplasty to the vein graft, now comes with recurrent rest engine. You could see that there is no flow inside that particular vein graft. The distal vessel is not seen at all, and you could see a very critical stenosis over there that was actually inside the stented segment. That particular critical stenosis was there. When we evaluated NIRS IVUS, you could see that the vessel is almost 4.5 millimeter in size. The stent implanted there was 2.75, and you could also see on the NIRS system that the LCBA was more than 500. It was 611, which makes us understand that it's likely to have a distal embolization in this particular patient. So we went ahead with a distal protection device in this particular patient, and you could see in the final image that all the vessels distally is very clearly seen. The right coronary artery, the OM branch, everything is well filled up following the intervention. So NIRS makes us understand that when you have a degenerated graft, when you have a huge amount of lipid pool inside the vessel, you need to have a distal protection device and be careful while managing this particular patient compared to someone who's got a very low level of lipids inside the vessel. Now, again, you could also identify the low risk subset of patients during a coronary intervention. This is a patient who had a primary angioplasty to the right coronary artery. You could see on the left system, left main bifurcation has got a very an intermediate stenosis and ulcerated plaque in the left main bifurcation. We're not sure what exactly to be done for this, whether we should be stenting this particular lesion or not. We evaluated with NIRS IVUS. On IVUS, you could see that it's an ulcerated plaque. However, the luminal area there is more than 10 millimeters square. So a huge luminal area with an ulcerated flap over there. We're not very sure whether to stent it or not. When you looked at the NIRS images, you could see that the LCBA is less than 400, which makes us understand that there is no huge lipid pool over there. So a good luminal area, less of lipids over there, we decided that we'll manage him medically in this particular patient. Now, we could also identify the stent length while managing the patients for interventions. This is a patient who had an acute coronary syndrome. You could see that there is a very critical stenosis in the distal left antidescending artery. However, in the proximal antidescending artery, you could see that there is an intermediate stenosis over there. Is this not stenotic plaque dangerous? We evaluated that particular area with NIRS IVUS. You could see 3 images over there. In the first image, you could see that the plaque burden there is almost 70%. In the second image, you could see that it's more of lipid pool on IVUS. It's more of an attenuated plaque. And in the third image, you could see that there is a huge LCBA. The lipid is huge. It's more than 600, which makes us understand that this is a vulnerable place. This is likely to create problems for this particular patient in future. So we decided that in addition to stenting the distal critical lesion, we'll extend the stent more proximally. So we had a couple of stents implanted there, and we were able to achieve good results. Now, we could also, while doing bifurcation intervention, you could also understand which vessel has to be given huge amount of importance. This was a patient who presented with an infused myocardial infarction. You could see that the right coronary artery is totally occluded. Once we opened up the vessel, you could see that the vessel is entirely diffusely diseased. The PLV branch is diffusely diseased. The PDA branch is diffusely diseased. The proximal right coronary artery has got an intermediate stenosis. What do we do for this particular patient? We didn't want to deploy multiple stents in this particular patient. We evaluated all the vessels. You could see distally that in the PLV, the LCBA is more than 400. In the PDA, the LCBA is significantly less, and in the proximal right coronary artery, the LCBA is quite huge. So ultimately, we decided that probably we should leave that PDA branch because there is no significant amount of lipids in that vessel. So we decided that we'll do a depth to the drug-eluting balloon to the PDA. Then we went ahead with stent implantation to the proximal right coronary artery and the PLV branch. So a couple of stents and a depth to the PDA, and that was the final result that we could achieve in this particular patient. Well, you could also identify the likelihood of developing slow flow during intervention in acute myocardial infarction. Somebody who gets admitted with acute myocardial infarction, if you evaluate NIRS, if you have a huge amount of LCBA, then you are likely to know that this particular patient is likely to have more and more of slow flow during the intervention. You could see that this is an inferior myocardial infarction. LCBA was huge, and following stent implantation itself, you could see that the slow flow is developed. We had to give a lot of intracoronary vasodilators and settle down with that. A very similar lesion, another patient, inferior myocardial infarction, you could see that the LCBA is significantly less. So we were sure that this particular patient, the chance of distal embolization is going to be significantly less. Went ahead with stent implantation, post-dilatation, and you can see that the flow is quite good in this particular patient. Now you could also assess the adequacy of the results while doing interventions with the help of NIRS. See that this was a patient with acute coronary syndrome, a large PDA, 2.75 millimeter PDA. Stent implantation to the PDA was done. Following the stent implantation to the PDA, we missed the ostium of the PDA. So it was looking 50% stenosis following the stent implantation. We missed the PDA. We thought that probably we would leave that particular area for medical management. However, when we did the LCBI, we found out that at the ostium of the PDA, the lipid pool was quite good, quite high. It was 529. So we decided that we'll deploy another small stent at the ostium of the PDA, and then we got away with that. That's my last set of slides. Sir, can I take one more minute? Just one more minute. So you could also decide on the balloon-based strategy while doing calcified lesion interventions. This was a patient who presented with effort angina. You could see that he's got a very critical calcified stenosis in the proximal left-handed descending artery. Rota was a little bit difficult, 1.5 millimeter burr, and there was slow flow inside the vessel following the rotablation. We evaluated that particular vessel. It was very interesting. You could see that there is 360-degree arc of calcification. However, at that particular area of calcification, you could see that there is a huge amount of lipid pool, which makes us understand that you needn't be very aggressive at that particular area. If you're very aggressive with post-dilatation, you're likely to distally embolize. Second thing is when you have huge amount of lipid, probably the calcium, it's not a very thick calcium. You don't have to be very aggressive while doing the pre-dilatation and post-dilatation. We went ahead with the non-compliant balloon dilatation. Stent implantation was done. We didn't have to go at very high pressures, and that was the final results that we could achieve. So dear friends, in closing, NIRS IVUS system, it identifies the vessel structure and plaque composition. The IVUS identifies the vessel structure. The plaque composition is identified by NIRS technology, which helps us to identify the high-risk patients, the vulnerable lesions, so that we can modify a management plan so that the long-term outcomes are going to be good for these patients. Thank you so much for your patience here.
Good, wonderful presentation. You highlighted all the important aspects of the NIRS IVUS. This is very important intravascular imaging. Mainly it detects the lipid behind the calcium. That is one of the disadvantages with the OCT and IVUS. It may not detect. So it identifies the high-risk patient and a high-risk plaque, the plaque burden. So when the plaque burden is more, sometimes my strategy would be different when the PLV ostium is involved. If borderline lesion is there if you give a more aggressive lipid therapy, most of the time plaque gets regressed. The yellow study series have shown very clearly, like when patient is having a large lipid plaques, particularly in younger patients, if you give a more lipid therapy, like not only statin, bempedoic, but we are also giving amlacomab and inclisiran. When you use and when you follow up these patients, most of the time plaque gets regressed. But in elderly patient, that's a different picture. Elderly patients, most of the time they have a calcified plaques. But younger patient, diffuse atheromas, most of the time, like proximally do the DES and distally cutting balloon, DEB, and followed by more aggressive lipid therapy. That's what we are following. But the presentation is good. You have shown all the different subsets of NIRS IVUS indications. Thank you.
You can join Deepak here. Other thing as relevance, as I mentioned, is when the LDL cholesterols are coming down below 40, that's where we are noticing the regression of plaques and gradually becoming free from CAD. Eugene Brownwald mentioned that the new inclisiran molecule which is come out could be acting as a vaccine, and how to live without CAD for 100 years. That's what is the talk we designed later. But I just wanted to pass on this information and benefit to all the attendees. Whoever wants to take that molecule, whatever money is given, also we're spending for that. All of the doctors can have it at 30% less cost of that compared to what is available in the market. If many of you can note it down, register, and then take it later also. But I assure you that we have seen in both in the early clinical trials and the whatever little experience post-marketing, the drug is quite safe and very effective. I think that's how I wanted prevention and intervention on both sides for the entry. One side you have the inclisiran injection, other side the stent. Both are important, and I wish many of us would check your lipids. There is also a facility to check your lipids if you want on the stat, and then probably take it. And any other comments on this NIRS IVUS? Dr. Gary, he wants to know about future of NIRS, your thoughts.
Well, sir, do you foresee the NIRS IVUS replacing the conventional IVUS?
It's a nice add-on. The grayscale IVUS that's part of NIRS IVUS is actually quite good. The clinical utility is probably not as broad as the speaker suggested. So do I see that replacing IVUS internationally? Not really. Ajay?
No, the only thing I was going to say is that, Akiko actually who's here has put together some nice data. That last calcium case that you showed, which was the calcium with lipids, and intuitively you would think that if you have more lipid, the calcium will crack easier, like you said, and that's she can talk more about it, but that's some of the data that she's put together as well. So it's kind of interesting.
Basically, NIRS IVUS, even IVUS images are very high quality, high definition images. It's a very good image, and additional benefit you can see the lipid content also. I think that is also additional because it almost like IVUS, high resolution images,
Yeah,
and additionally plaque burden.
Yeah, very, very true. It's a very, very sturdy catheter. You could cross even the calcified lesions, and you have IVUS images as good as the best in the market available IVUS catheters. It's HD images, 65 megahertz frequency. So you have huge, good-looking images. In addition to that, you get an idea regarding the lipids also.
I think overall HD quality images of IVUS have improved compared to non-HD ones before. I think we'll have further discussion with more talks coming up. And many of us are interested now. Sanjog is an authority, and Ajay also has contributions to it. The minimal contrast PCI with IVUS, because nowadays we see a lot of patients where increased creatinine they come. So what are the precautions we take, and how to do that also will be covered. My good friend Dr. Rajshekhar has experience on this. So we requested him. Rajshekhar is a senior consultant cardiologist in Yashoda Hospitals, Hyderabad. And all of you have now seeing more and more cases of CKD patients coming to our day-to-day practice. I think this is very important nowadays. Value addition, I would say, we call very few things as game changers, but one of the things which is very important in interventional cardiology is even if you can deliver these goods even in patients who have higher serum creatinine levels by using IVUS or whatever type of modalities. Some people also described some wiring techniques, other things before, but I think we'll hear more about it from Dr. Rajshekhar. Over to you.
Thank you, Dr. Srinivas, and good morning to everybody. And I think it's a very interesting topic that I've been asked to present about today, is the evolving role of intravascular ultrasound in minimizing use of contrast, especially in patients with borderline or threatened renal function, so that we can avoid renal complications. I will use two illustrative cases to drive home the message in this particular topic. My first case is a 54-year-old male who presented with symptoms of LVF, and he was a known CKD, though he was never dialyzed. He was hypertensive and diabetic, and the ECG showed an evolved inferior wall infarction. And the angiogram showed that there is a moderate to severe stenosis in the proximal right coronary artery, and he also had a long tubular lesion in the mid-LAD. So the RCA was engaged with 6 French Judkins right catheter, a guiding catheter. Lesion was crossed with a run-through, and the IVUS was done. And the IVUS showed a fatty plaque with a lot of lipid burden and with the presence of a thrombus. And after pre-dilatation, a long stent 4 into 33 DES was implanted and was post-dilated with a 4.5 non-compliant balloon. And this is the final angiogram, and which showed TIMI-3 flow and a good result. And the final IVUS pictures also showed a nice MSA. The case 2 is a 74-year-old man who presented with recurrent episodes of rest angina with dynamic EKG changes. He had an eGFR of 40. He was a diabetic and a hypertensive. Though the echocardiogram was normal, he didn't have a resting regional wall motion abnormality. An angio was done which showed triple vessel disease, and he was given the options of a cabbage as well as a staged PCI. And this is the angiogram. The angiogram shows diffuse long segment disease of the LAD with a very critical block in the mid segment. And you can also see that even angiographically there is significant calcium in the lesion. The RCA was non-dominant and small. During the course of the hospital after the angiogram, the patient's creatinine started increasing, and a nephrology consultation was taken. Despite optimal management, his creatinine levels were rising steadily. So the PCI was deferred and the patient was discharged with medical management. But he was readmitted through the emergency room with LVF, and he had chest pain on the previous night. Though his troponin was negative, he had dynamic EKG changes. He was stabilized, and his creatinine was around 3.3 to 3.5. So, in view of his unstable coronary symptoms, and in the view of the rising creatinine, he was offered the option of an IVUS-guided minimal contrast or a no contrast PCI. And the interesting challenge in this particular case is that it's a calcified lesion and he would need a rotablation. So it would be a minimal contrast or a zero contrast PCI with rotablation. So because the lesion, the mid-segment lesion was very critical, it was pre-dilated. It's a very delicate conservative pre-dilatation was done with a 2 millimeter balloon. And then the IVUS was done, and the IVUS showed a significant, more than 270 degrees thick, diffusely calcified lesion, more than 10 millimeter in length. So it was decided that we should do a rotablation for this case and a 1.5 bar at 160,000 RPM. And there was a significant drop of more than 10 RPM when it was traversing the critical lesion. And after the rotablation, a repeat IVUS was done. It showed that there were significant cracks, multiple cracks in the calcium. And then the proper assessment of the vessel size was made, and the pre-dilatation with a 2.5 and 2.75 non-compliant balloons were done, followed by a scoring balloon of 3 into 10 millimeters. Then post the scoring balloon, again an IVUS was done, and we could see that we achieved a significant lumen gain, and with multiple cracks in the calcium. So the vessel bed was adequately prepared, and we seem to be ready for stent implantation. So basically in this particular, at this step we mark the distal landing zone and the proximal landing zone by the position of the radio-opaque marker on the IVUS catheter. And these will serve as landmarks for us for the final stent implantation. And then we fix the table and fix the view, and we go ahead and do the stent implantation in this particular view. So it was decided that it's a long lesion and required 2 stents. Middle LAD was stented with 3 into 33 DES and post-dilated with 3 into 12 non-compliant balloon. And a proximal 3.5 into 15 millimeter DES was taken. However, during stent inflation, because of the calcium, there was a proximal pushback of the stent, and the stent got implanted right from the ostium of the LAD. So we obviously had a small area of geographic miss, and it was checked on IVUS examination, and there was a small area of 4 to 5 millimeter area of geographical miss between both the stents. So these stents seem to be reasonably well deployed, reasonably well opposed, and expanded well. And so the geographical miss of about 4 millimeters between the proximal and distal stent was covered with a third stent. It's a 3.5 into 8 des deployed, overlapping both the stents. And ostial stent proximal portion was optimized with a 4 into 6 non-compliant balloon. And this is the final HD IVUS run, and it shows all the 3 stents are well expanded, well opposed, with very good minimal stent area, and looks like an optimal result. So to cut the long story short, it was we had a proximal MSA of 11.2, mid MSA of 8.9, and distal of 7 millimeters square. And there was no edge dissection, there was no malapposition, and it was well expanded. So we did a final contrast shoot we did 2 final contrast shoot, one in the caudal and one in the cranial view. Only 6 ml contrast was used during the entire procedure. And post-procedure serum creatinine levels decreased, and patient was discharged in good condition. So this is the final angio. This is the reference, this is the baseline, and this is the final angio. And this is again the final result. So what is the need for minimal contrast PCI? We all know that CIN is an important problem in patients with borderline or compromised renal function when we do therapeutic interventions. And the incidence is quite high, and there are several risk factors, including old age and heart failure, and the most important thing is the volume of contrast injected. So this is for the benefit of young cardiologists. This is the Mehran score that we typically use to predict the risk of renal failure post-intervention. And thereby we have the role of intravascular ultrasound to help us in minimal contrast or zero contrast PCI. It helps us in lesion recognition, characterization, and stent implantation, and where the proximal landing zone of the stent and the distal landing zone of the stent, and also to obtain an optimal result. So how do we do step by step is we need a pre-procedure planning and preparation. We need to hydrate the patient, and I typically engage the catheter without contrast administration. One little help is that we can inject a small amount of saline once we engage the catheter. If you're engaged, you can see T-wave inversions on the ECG. That shows that the catheter has been engaged. And then, if possible, the angiography should be done a few days before, and limiting the contrast to medium. And then we need to have that as reference when we're doing the procedure. Thereby, we don't need to do repeated shoots. And there are several techniques of procedure navigation. We can have anatomical landmarks, especially with the presence of calcification, and we can use the IVUS guidance. We can have a marking wire technique, which we can put a second wire as a marking wire, which will serve as a hard landmark. We can also have side branches on the IVUS as a soft landmark. We can create a metallic silhouette of the segment of interest by by positioning wires in the proximal and distal side branches. And to begin with, we pass the wire across the lesion, and we can have supplementary guide wires to serve as hard landmarks. And this is how we can create a metallic silhouette. We know that by putting a wire in the first OM branch, we know where is the proximal landing zone. And this also helps in most situations. So another technique is to have a marker guide wire in this fashion. You can put a marker guide wire, and then that is left in place till the point of stent implantation. And the IVUS probe, we can use the radiopaque markers of the IVUS probe, and we can actually save the fluoro to decide the distal landing zone and the proximal landing zone. And by freezing the table, by not changing the position of the table and the image, we can position the stents precisely. So the algorithm is that once we put in the guide wire, we can have a metallic silhouette, or we can use an IVUS catheter used marking, or we can use a marking wire technique. Then we do the IVUS pullback, we do the stenting, and we do a post-stenting IVUS pullback to make sure that the result is optimized. So, of course, adequate hydration of the patient is very important in all zero contrast interventions. The take-home message is that minimal contrast PCI with the aid of IVUS imaging has significantly reduced the contrast, the incidence of contrast-induced nephropathy. And however, there are some pitfalls of IVUS. Is that how do we position the stents in an ostial location? This can be done by using an 8 French guiding catheter and having IVUS in the side branch. And we can have a wire as a marker in the side branch, or you can use a calcium, fluoroscopically visible calcium as a marker. And some of the things that we cannot detect with IVUS is a distal flow or a side branch occlusion, or a distal vessel perforation. And that is exactly why we do a final injection, which will not only help us see the optimal result also, but we can also identify if there's any slow flow or an impaired distal runoff. And most importantly, we can rule out a perforation. So therefore, to conclude, ultra-low contrast PCI is a feasible and doable option with intravascular ultrasound imaging guidance. Meticulous planning is required, and fluoroscopy and IVUS integration will help when available. And most of the things like stent sizing, positioning, length, and calcium assessment can be successfully accomplished with IVUS imaging. There are some situations such as ostial positioning, which can be a challenge, and there are ways to overcome this challenge. And the final shoot with a very little amount of contrast is required to detect flow, disturbances, and distal wire perforation. Thank you very much.
Thank you, Rajshekhar. I think it's an interesting one, important one, but exceeded time. We'll have the next talk also similar to that, and how OCT also is being used of late with Saline OCT step by step. Dr. Mahesh, he has publication with Saline contrast OCT, and let us hear to him and then have discussion combinedly on both talks which are relevant to renal failure.
Morning, everybody. Thank you, TCT Foundation, for this opportunity. I'll straight away go to the crux of my presentation. It's a case in box I've recorded, because there's no other way to explain to you how to do Saline OCT. This is just a normal way of introducing the OCT catheter.
We just introduce a catheter just beyond the area of interest. Just make sure that your thing is coaxial. Confirm it by a small whiff of contrast. Please. Okay, you're coaxial, that's good. So after that, you change from this to a 20 cc syringe. I use 20 cc for this. Okay. There will be some contrast which is already there in the guide, which will be injected. So that will be there. Let that be there. That helps you to initiate the run. This is how you hold the 20 cc syringe. Then you talk to your gentleman there and tell him ready. Cine, inject. Stop. Okay. I think we got a reasonably good image.
So this is the quality of the image that you get with just about 1.5 ml of contrast, which is there in the guiding catheter. So that's the ideal way to do things. Just make sure that you're coaxial.
We had engaged, there was a little bit of contrast in the system, so that we use that. This time I'm doing with absolutely only saline. Ready?
Finish, sir. Inject.
Telugu pictures.
So even that 1.5 ml of contrast need not be there, and with that without that 1.5 ml of contrast also, I got the images as good as it can be. Now, second option is once you're finished with the case. Now, once you're finished with the case, in this case, I've done a left main. So you can see that the catheter is very close to the stent in the, sorry, I'll just pause this. So when the catheter is very close to the left main and you have a contrast, you have to take a shoot, that is the time when you have to be careful. You should not deep engage the catheter at this stage. So in which case you may not get a beautiful OCT run with the saline, in which case what you should do is simply have a combination, say 30-70, 30% of contrast with 70% of saline. Even then your total output of contrast becomes extremely minimal. And so that way, two things can be achieved. One, as the previous speaker said, a last shot which will tell you whether you have placed your catheter well and you're not damaged any of the distal vessels, any perforation, slow flow, all those things can be done. But however, the contrast use will be about, I use a 20 cc syringe in which about 5 cc would be contrast, 15 cc would be saline, and in that I will only inject about 12 cc. So in short, I'm injecting about 2 cc of contrast for my whole final shoot. So this is the way you do the practical way of doing it. This is from the RCA side. RCA, invariably, I do only with saline. You may not get perfect images all the time, but the area of interest, if it can be seen, then that should be adequate enough for you to do this thing.
So I just try and demonstrate the concept of a saline OCT for you.
This is the second.
So what I'm doing is
recording.
Nothing unusual about it. We're just introducing the OCT catheter. Joel is holding the other side. I go in. The crux of the situation or the solution or the success story depends on how coaxial you are to the left main ostium. It goes in smoothly despite the dissections. Okay. I've deep engaged so that thing's all right. Give NTG, please. Good. Now I'm taking. So what we have done is we have already not required. We have some sort of a contrast inside the 1.5 ml of contrast would be there inside the guide, which also I'm using for my directions. Go ahead, please. Good shot, no? So we don't require another thing.
So all the
we'll
parameters.
Because there is too much of dissections there.
Yeah.
Predominantly, it was done with the saline with a little bit of contrast that was there in the. Please get the wires out properly.
Just shows the analysis. Analysis tells you that you are comfortable. So for the saline contrast, all that you require is that you have to be coaxial. I do predominantly hand injections. Now there is an option of doing it with the pressure injector. The issue there is various vessels, depending on the dimensions and size, you have to have a different PSI setting from 300 to 400 PSI. If you go 400 PSI in a small vessel, you're bound to dissect it. If you go at 350 PSI in a large vessel, you're not going to get an image, and you require about 20 to 25 ml of saline per injection, depending on the size of the vessel. I'm working on it to get a statistically reliable source, reliable data, so that I can tell you next time that, okay, if you're using a power injector, this should be your way of doing it. So this is another example of, just one more point I would like to stress. This is another injection of recanalized, restenosed coronary artery disease. So you can see the stents there. Distal dilatation is done just to get the stent OCT catheter across. Here we do the OCT in two different stages. The distal 75 millimeters, then the proximal 75 millimeters, because one OCT can't get you the whole thing. This is done with pure saline only. You can see that the catheter is being drawn back. After the saline first half is done, then you do the second half. Again, you get, okay, once that is done, you have to have certain landmarks. Then in about 80% of the cases, you can get an angio co-registration. So this is how the angio co-registration gets done. So you click on angio co-registration, co-register, just put the markers, distal, multiple number of markers. And if you're not getting it first time, the co-registration, you may attempt with the 30 frames per second angio run. You may get a better options of getting a angio co-registration. In this case, probably because of the extensive stented segments that were in between, we could easily co-register, and this is also possible. So you can do it, you can co-register, you can also get excellent images by doing this method. So I've been for all the RCAs in my practice, I've been doing only with angio with saline. However, the last shot is always invariably done with 1:1 or 30-70 or 60-40. Usually 30-70 is adequate, 30% of contrast and 70% of saline. That helps you to do two things. One, if the vessel is too large and cannot be imaged with the saline, then you get a better image with this. Plus, you can look for perforations and be happy with the last shot. Again, you use about 3 to 4 ml of contrast only for this combination shots. This is the final shot that I usually do so that I can get the co-registration, I can get the distal vessels, I can rule out any perforation and or slow flow. This is an example of a MERS. MERS is a biovascular scaffold in the RCA. You can see that the pullback is excellent. You can see that the struts of the stent can be seen very well, and the RCA is a huge vessel with an area of 11.13 millimeters squared. As you can see, you get excellent results. And this is the post pullback cross section. Just you can see the speckles. If you see so much of speckles inside, you have not used contrast. You use saline. That's the only difference. You can do all your reconstructions. You can do a fly through. Whatever is possible can be done. So finally, the last two slides is the first article which we published in 2018 when we had study. We did a saline coherence tomography guided percutaneous inversion, a pilot study, and then we have a lot of questions came on what is the vessel size, how much does it change when you do saline versus contrast. So we did the second study on 113 cases of saline and OCT done in the same sitting, in the same patient, and came to a conclusion that the changes of the vessel size are not statistically significant. Thank you.
Thank you, Mahesh, for sharing your experience of this saline OCT. Why did you think that when you have a IVUS, which shows good, just for discussion I'm saying, why do you promote usage of the saline OCT? Because if you don't have a machine, you have only OCT
What movies
machine.
do you watch? You watch black and white movies, or you watch color movies?
You feel the
clarity is impeccably
so clarity
different.
is good one.
Impeccably
and
different.
availability is another challenge. Suppose a hospital doesn't have a IVUS machine, you have only OCT machine. Some of the hospitals, that is another thing where it can be used. But one thing is the whatever you are getting images should be comfortable. You should do it well. Otherwise, the exact idea of doing things.
So there is a saying in the army which says, "You sweat during peace, you will not bleed during war." Just keep practicing, you'll come to it.
Think any.
So how often you use guide extensions to give injection? How often you use guide extension, especially on left system, for
Actually,
contrasting?
I had only 10 minutes, so I had to stop here. I use guide extensions in LADs, which have got large left main and large circumflex branches. I use guide extensions. It works.
Any comments, Sanjog or Rajay?
I want to hear from Gary, sir.
No, I mean, the only thing I was going to say is that there are newer systems that have faster pullbacks that allow you to do saline OCT in a much, without giving 25 cc's, without necessarily having to use a guide extension. So SpectraWave is an example of that. And it'll be iterated over time, but there are other solutions, just speeding up the pullback, that would help a lot, frankly. Gary, any thoughts, comments?
Well, I mean, for the right, there's really no argument. For the left, sometimes it works, sometimes it doesn't.
Yes, sir.
And that's entirely based upon flow, because the flow in the left system is 2 to 3 times greater than the flow in the right.
Agreed.
And that's what you're fighting.
Yes.
You have to be also just on the, you can get VT. We've definitely seen VT.
Yeah.
You know, it's rare, but like anything in the cath lab, you have to be prepared.
That will not work, especially if the left main is very big and the LED L6 is very big. Saline will not produce that much effect. Very like assume that LMCA is about 5.5.
So use a guide extension in such cases
Guide extension
and do a selective injection.
But most of the time now we are operating on very elderly population, very triple well disease, high risk patients, like plaque modifications, all these patients. When we are using more of plaque multiple runs, so triple well disease, we are more comfortable with the HGIVUS. So like if you want, you can manually pull back fast instead of waiting for that one. Good. Tri-layer structure, you can see plaque burden. Of course, OCT is also very useful. But what AK, when fluid balance is very important, fluid volume overload, in such cases, it's ideal to go ahead with the HDIVUS and take always the side branches, guide wires, and osteal lesions, when you do it, the side branch, osteum you can locate. Otherwise, you have so always take the fluoro evidence of the calcium markers.
There's something wrong with his microphone.
Not to give injection. See the fluoro and place.
Dr. Sanju, you want to?
Sorry, we were just trying to get his microphone replaced because we couldn't hear him. No, just to follow up on Ajay's comment. So the VT with this is a temperature problem. And so it's worthwhile ensuring that if you're going to do saline OCT, one tip and trick is to make sure that the saline is not cold. That's very easy to end up in, right? Where things are sitting at the back and you're the patient's losing heat while on the table, particularly in long procedures, where the saline on the body is sucking heat out. They're already sensitized. The other thing you can do to improve picture quality is slow the heart down. So sometimes when doing saline OCT, particularly in these large flow vessels, where I'm a little bit uncomfortable putting a guide extension into the proximal part of the vessel, given the nature of the plaque that's there, I'll slow the heart down with a small dose of beta blocker. As long as the LV function isn't poor, that does improve image quality because it reduces the amount of systolic flow reversal.
Thank you.
I think as a broad caution for people who don't have IVUS and other facilities in zero contrast or patients with CKD, what is generally we practice is one is the placement of wires as I described. The other thing is the stents sizing which you are taking. Probably you can undersize quarter and take 2-3 millimeters longer stent so that exact positioning you don't waste injections with too much of contrast. And always with these later generation stents, you can post dilate with a bigger sized balloon, leaving the edges. That's why you're not too much worried about the edge dissections happening. And not to have this geographical miss as shown by Dashek and other things. I think time is up. Thank you, Mahesh.
I want to make one quick comment about minimal contrast PCI. If a patient has chronic kidney disease and you're going to stage the diagnostic versus the PCI or stage the PCI, wait a week.
Yes.
Don't wait 48 hours. Wait a week, because the reaction of a kidney in a patient with CKD is very different from the reaction of a patient without CKD.
Okay. Thank you, sir. I think what we can assure is people are worried, think that bypass surgery could be better, but patient going on to that also they go into dialysis and things like that. And we have done patients of up to serum creatinines of 6 with these techniques, and there is no worsening provided you follow some basic precautions as mentioned, adequate hydration and other things. So the real game changer which has happened in interventional cardiology with the advent of this. A lot of sick patients who are surgery is non-fit patients now are being referred to us for this procedure. And we could deliver goods without much of problems actually. We were initially worried in the early part, a year and a half or so before, where creatinines would rise, but we have seen there is 0.2, 0.3 mm fall only because of hydration and other things, but it didn't rise, provided you follow all the precautions. Thank you, Mahesh. Then we'll go to another interesting thing. That's how I feel competition is always good everywhere. And the imaging also, this is happening. that IVUS technology comes with something new, and OCT also adds up something new. And recently, Abbott has launched this Ultron 2, and some of the newer advantages of artificial intelligence, other things coming up in this modality. Requested Dr. Jabir to deliver this talk. Thank you, Jabir, for your time. Over to you.
Thank you, Dr. Srinivas Kumar, for this great opportunity. Excuse me, how to move this? Right. So PCI had an incredible journey over last almost half a century. It's close to 47 years. We started from the plain old balloon angioplasty and now reached the era of precision PCI, where imaging seems to be mandatory in some of the cases, and its imaging-guided PCI is the state-of-the-art PCI. So optical coherence tomography, it helps to perform a precision PCI with probably better short and long-term outcome. I may use the term probably because of the lack of definite data. So currently, worldwide, the OCT has a workflow which is the MLD max. So we have great experience in OCT. The benefits of OCT everybody knows, but the take-up of imaging-guided PCI much less across the world. There is some reluctance or a physician inertia. Basically, in a lab, it takes a too long time. So the lab time is a problem. So a busy lab, the operator may find it's too long, so I may avoid. I have great experience with imaging-guided PCI, with either angiography-guided PCI, so I'll go without imaging. And also, for a beginner, it is an expertise which is required for the interpretation. So there are problems, and that's why there is a reluctance or a physician inertia in going for an OCT-guided PCI. Can we make the life simple for an operator? That is what the Ultron 2 new software, which is compatible with the MLD Max. So we can strategize with the first, that is the planning part, and then the post-PCI optimization, that is a review part. So we can have a look at the AI, the artificial intelligence guided software, can tell immediately what is the morphology, what is the sizing, and post-deployment and review can tell us whether it is optimal and what else optimization technique is required in this particular case. So the morphology, length, and diameter, that is the pre-plan or the pre-procedural planning. You can see in a normal AptiView system. It's not the Octreon one which is available right now. It is the current system of AptiView in most of the labs. You can see what is happening. We are doing this thing. We look at the morphology, look for the calcium, see the calcium, assess the depth, look at the length. We have to place the cursor, the proximal part, distal part. We look for the EL. It takes a long time. Even for an experienced operator, it may take close to 2 minutes for all these, to get all these data, the morphology, length, and the diameter. So, if you go with the new Ultron platform, the Ultron platform can do it very quickly, close to 30 seconds. In 30 seconds of time, it can tell you what exactly you are going to do, what exactly you should do in this case, what should be the calcium modification, what should be the length of the stent, what should be the diameter of the stent, and then go to the review. So the morphology, AI-enabled calcium detection, it can immediately tell the arc of the calcium, where exactly is the most dense part of the calcium, what is the thickness of the calcium, and the length of the calcium. And at the same time, it can tell us where exactly you can see the EL in the proximal and the distal part, these white dots. So you can see the white dots. These white dots are basically the, it is identifying the EL, which is sometimes pretty difficult for the operator. So the EL is measured, and if you have a more than 180 degree arc of the EL, that means that is an area where, which is a suitable landing zone. So it tells it the morphology, length, and diameter in less than 30 seconds time. We have two modes in Ultron 2, the guided mode and the flexible mode. Guided mode may be for a beginner. It will take you through the entire MLD Max algorithm, the MLD in the planning part
and the max in the post-procedural part or the post-tending part for the optimization. The flexibility mode, you have two. One is the planning and the review. That is for an experienced operator. So the flexible mode, it can tell us the planning, then following the planning, the review. In the review, we can see the stent, the expansion, the apposition. The color coding has changed. I'll tell you, the color coding has changed. The color coding for expansion is orange. If there is under expansion, it is orange in the review part. And instead of the previous red, here it is the yellow for malposition. And another new thing that has added is the dynamic angio synchronization. You can see running angio as well as your coregistration. So it gives an idea about, and it can be marked even in the angio itself, expansion and apposition. So the flexible mode, you can have a review at a glance, everything. You can see the, following the stent deployment, you can see the tapered expansion. The orange line can tell you how much expansion it is. That depends upon what is the threshold you have put. If the threshold is put at 90, anything below 90 will be marked in orange. So here you can see where exactly is the maximum under expansion. It is 76%. And at one part it is 73%. And if there is some malposition, it can be marked as yellow. That also depends upon the threshold you are keeping. And there is a 3D bifurcation view. This was not available in the Ultron 1, and here it is there in the Ultron 2. You have the 3D bifurcation view. And one problem you can see, in all the first generation OCTs or the currently available software, what we are looking at is the distal part, and it comes to the proximal part. Here, what we are seeing in the proximal part is really the distal part. It is a reversal. And the 3D bifurcation, simultaneously in the same frame, you can see the stent also without the wire. So expansion, apposition, easily checked. And whether it is a an optimization or the post-tending optimization is required, that can be immediately decided. So the yellow particles, you can see the yellow markers, that shows the malposition. So what are the feature comparisons between it? So this is very quickly, you can get the morphology, length, and the diameter, which is automatically measured. A 3D bifurcation is available, a fly-through is available, but you cannot make out what type of stent it is in the Ultron 2. In the currently available software, the AppTV, you can find what is the morphology of the stent. You can tell what exactly is the make of the stent. That is not available, and the orientation is different. The orientation, the proximal on the left and the distal on the right. The current software we are using the distal on the left and the proximal on the right. So that makes a little confusion, which we have to use and get acquainted into it. Automatic EL data and the lumen diameter values will give us an advantage in this thing. And also the color coding has changed for the apposition and expansion. So this is one of our case of a OCT-guided PCA in a calcified lesion. Can see the pre-procedural angiography and after the rotablation and final after stenting. So this is the AppTView platform pre-PCI assessment. Can see the entire run of the OCT, the time it takes. That's where operators find Achilles heel. If you look at the proper or a meticulous OCT assessment, it takes a little longer time, close to 2 minutes or even 2.5 minutes for an experienced operator to look at the morphology, assess the calcium, look at the thickness, look at the arc, look at the length of the calcium, then decide on what should be your calcium modification strategy. Then the landing zone, you look at the EEL, look at the landing zone, what is the proximal diameter, distal diameter of the stent, and the total length of the stent. So that's where we find it a problem. And the post-PCI also, but at the same time, if it is the, if it is the Ultron, it's so quick. You can see the massive malposition in the proximal part in the left main, and the MLD max also quickly calculated. the diameter it gives, the lumen diameter it gives the EL diameter, everything. That's at a glance itself, even a beginner can make out what it is, what exactly we should do. So the final questions to me regarding this software is, are you really impressed with the Ultreon 2? Of course, I am impressed with the Ultreon 2. Will it help to do more OCT guided PCI? Of course, because it is not cumbersome, it is not that time consuming. And will this application improve the patient care? Of course, if it is a precision PCI, it must improve the patient outcome. And will it be of real help to a beginner in the OCT? Yes, that's the answer. It will be more friendly, it will be a more operator-friendly procedure. Thank you so much.
Thank you, Japit. Gary, you want to comment?
No, I mean, Ultron 2 was a significant step forward from the Abbott engineers. But I also think you have to be not cautious, but you can't totally rely on the software. You have to provide oversight because sometimes the software is wrong. And again, the emphasis on malapposition is misplaced because it's really expansion and what happens at the edges of the stent. And sometimes having all these dots can obscure the actual struts. But you can't just close your eyes and let the computer do it for you.
And at any time, you can click and go back to our own interpretation. So either AI interpretation or if we think the operator's interpretation is required, you can immediately shift.
Yeah, how do you foresee, suppose if you are using a NIRS IVUS, there's a calcium, behind the calcium lipid is there. But Ultreon is showing the calcium arc. But in such cases, definitely it's very difficult to distinguish whether patient is having a behind the calcium lipid.
What is the underlying lipid content? Yeah, I think these two investigations are complementary. They are not competitive.
Yeah, we have to, I think by that, if you do the both, you can see any lipid content is more behind or only calcium arc is detecting. What component is picking up, that is very important.
If the lipid core is more behind a calcium, that calcium which can be easily cracked.
Yeah.
I think we have a very important lecture come. Thank you, Jabit. Okay. I think we have Dr. Akiko with us and very practical relevant topics will be covered. So I requested her to tell us about my top 5 learning imaging pearls from complex PCI. So she requested us that she wants to involve for more of teaching to all of us. So I think you should take this opportunity to interact with her or clear whatever doubts apart from what she's presenting. Over to you.
Okay, so those are a little bit advanced, but which I really learned in the past half year. So I'm picking up most important case to explain what is important. So let's start with the basic, which already Gary Mint showed. And when we look into the plaque, importance is calcified plaque. And by IVUS, you see the hyperintensity and acoustic shadow. And by OCT, you can see the thickness. That's very important. And then when we look into the lipidic plaque, you have to see the very strong attenuation. That's lipidic plaque. And then everything else, we consider this is fibrotic. And for a long time ago, when I learned of IVUS at the first time, I was taught this is soft plaque, and it is true. So this is a patient, is 23 years old, male, and the patient had transplant 9 years ago because patient had hypoplastic heart. And you see the very simple type A lesion in the LED. And we did IVUS, and we see very concentric kind of soft plaque. And proximal portion was big and normal, and this is in the myocardial bridge. And many people thought this is really soft plaque. And this operator was so careful person, he never do the direct stent, but because of this soft plaque, he did the direct stent. And that's really starting the nightmare. And you see the stent was never expand, and we did a lot of balloon, nothing happened. And finally, we decided to ablate of the stent, and then using up to 2O, and then finally ablate. But even after ablation of the stent, never open up, and finally cutting balloon open this very fibrotic concentric plaque. So this is IVUS. At the very beginning, you remember this is very concentric fibrotic plaque. After stent, no change at all. You see the stent size is exactly the same compared to the first. And then after Rota, stent has gone, and still we couldn't open, but because of the stent gone, and we could open finally by cutting balloon, at the end we have to put one more stent. So I think it's important, yes, calcium is important, but this type of the very rare, concentric, very matured fibrotic plaque is sometimes making such an issue. So those things we really have to remember, number one. Number two, this is very important case for me. I learn a lot. This is very, very long LED region. I have no idea where to wear. And there is a bunch of the branch. But I think once you see this type of the region, actually it's very predictable, which I learned. So starting with IVUS, and I measure, I explain very carefully. So this is a very proximal LED, medial to media is 4.9. And after the big diag, the media to media is 4.1. And after the big second diag, is media to media is 3.4. And after the big third diag, is media to media is 3.0. So now you really understand this is very predictable. It's not like I have no idea. You see the 4.9, 4.1, 3.4, 3.0. And where vessel small, getting small is where the big side branch merge. So this type of the logic is very predictable. And actually Gary Mintz, he showed this kind of concept already 30 years ago. So analyzing the bunch of the artery every 2.5 millimeter. And LED taper is the largest compared to the circle and the right coronary artery. It's almost 2 times. When you consider 10 millimeter in length, the vessel taper is about 0.33 in LED, but circle and the right coronary is half. So let's consider you have the big artery and you have to put 30 millimeter stent. And the proximal measurement is you indicating I need a 4 stent. But when we put the 30 millimeter stent, automatically you have to imagine your distal end of the stent has to be 0.33 times 3 has to be 3. So those kind of logic is very important. We are considering the long diffuse region. That's number 2. Number 3 is this case. This is 67-year-old male and stable angina. You see the proximal LED in distal portion, there is a diffuse disease. And we start treating, and this is a picture. And OCT, you see the circumferential calcium, but it's okay. This is very focal. So we did the balloon, and we stent. And this is a whole treatment, and nice ballooning, and long stent, and non-compliant balloon based on the sizing of each segment. So we use a different size of the balloon because we know the LED is a vessel taper. So 2.75 and 3 proximally. This is afterwards, what do you think? So long stent looks okay, but doesn't look okay in the distal portion of the stent. So you have imagination what's happening here already. And I will show the answer. This is IVUS picture. Starting the distal looks normal. Coming back, what is this? And stent. And you have idea. This is very clear answer what's happening. So would you like to stent? I will show one more time. Starting distal, and you see the nice intramural hematoma, and stent. Would you like to stent? That's a question you have to answer. We didn't. Why? And we measure the area, and this is large, and at the site of the hematoma is not large, and stent. At the same time, we have to treat other segments. So I said, let's leave it alone and go next. At the same time, we start treating the other segment. And the mid-LED was underexpanded, additional balloon, and we have to treat the proximal portion. And then this is a final angio after treating the other segment. We didn't touch at all for the distal segment. It's very different compared to before. Looks like very narrowing because of the hematoma, but now we didn't touch at all, but looks much, much better. And we have the answer by IVUS. This IVUS, right after the stent, you see the very narrowing. This is now. And we give the nitro, that's one answer. You see the distal reference is much larger. At the site of the hematoma is also larger. And the hematoma looks smaller. And the whole answer why this happened is because of the entry site of the hematoma. This is at the time of the stent, we see the big dissection. That's medial dissection, longitudinally extend, and we see the big hematoma. However, this case, remember that picture, actually the stent was covered the entry side of the hematoma. We saw that. And we confidently leave it alone because entry side was covered. But at the end, we come back to confirm that actually hematoma did not worse, and we finally leave it alone. So all hematoma, even such big, doesn't have to be treated. And the importance is checking the entry site was covered or not. And that's the answer. Then let's move to the next one. This is a very, very teaching case. So this patient having the already previous angio and FFR was positive in the LAD and diag. And we decided to treat LAD diag as well as a distal circ. And first we go to the circ, and this is IVUS after the treatment. Distal is normal. You see something here, and big dissection, and stent. One more time. Normal, and you see some stagnant flow, and dissection, and stent edge. I was there, and I am explaining, this is okay. This is not big dissection, and lumen looks large. Leave it. I said so. But we put a wire, and then to see what's happening during the LAD treatment. But please remember this picture carefully. I did a big mistake. If you go to the distal, it's normal. This is actually bad sign of the hematoma, and the big, big entry site that's opening right distal to the stent. And we move to the LAD treatment, and then after LAD treatment, we see the circumflex, which actually occluded. Oh my goodness. And then operator putting the wire into the circumflex, and then I saw the wire is actually the fourth lumen. But considering the whole picture, this is a very important aspect. We see the big entry site, but we know that entry site was just distal to the stent. So that's good landmark. And the second, there is a side branch. I see the side branch in the IVUS. So if you look into the wire, into the just distal to the stent, and going to the side branch side, you should be able to taking the true lumen. And this is after the wire into the true lumen. It's a little bit difficult because of the wall is very normal, but it was into the true lumen, and we just cover at the entry site. After cover the entry site, it's fine, and then there is a hematoma, but that's no longer extended distally. And this is the final picture. This is actually unfortunate. We have to put such a long stent, but we really opened the artery at the end of the procedure. So considering two different cases, what's the difference is first case was entry site was already closed, but second case was not. That should be determined what we should do. That's a fourth important point. And this is actually one more case. And compared to the previous case, what's the difference? Yes, there is a big dissection after the ballooning, and you see the hematoma. But what's the difference compared to the last one is this is actually perforation. You see the vessel wall is no longer is present. And this is what we call the impeding perforation. And sometimes you see this type of picture. This is very, very important. And we recognize, and I expect that's going to be perf. And after stent, we see the perf, but that's a small. So once you this type of the picture, you have to be careful because you are going to be making worse, and you have to be more conservative way. But this type of the phenomena is a little bit difficult by us. We can recognize by OCT much easier. So this is a case, LAD diag bifurcation. And after the cutting balloon, we see this type of the dissection. Is this dissection, it is something else. And we did OCT. Starting from the distal, you see the big dissection. This is perfectly fine. This is just treatment. But coming back more, what we see is really correlated to angiographic appearance. Coming soon, somewhere here, it's a very strange picture. And what is this? And we come to the LAD. And actually, I do think this is type 1 perforation. And typical 3 layers appearance of the coronary artery is you see the low intensity, which is medial, and you see the adventitia, which is hyperintensity. But this picture is you see nothing, meaning no adventitia at all, and you see the perivascular tissue adjacent to the lumen. This is really the perforation. We can detect impending perforation by OCT very accurately. So this case, however, nothing happened. We go ahead conservatively, and finally, this is after the stent, and that segment was already starting the thrombosis. I see there is no adventitia, but you see the hyperintensity of the perivascular tissue already. So those very important findings we should learn for the complex PCI. This is a final picture. So the last one, this is my 5th important message to you. This is a patient, 81 years old male, and there is a bypass in the left side and right coronary artery, which was stented about 1 or 2 years ago. And you see the very focal stenosis. And this case, when we did IVUS, we see the very typical picture. So come to the proximus, all the stent was well expanded, opening. Distal segment is well expanded, good opening. At the site of the stenosis, what's happening? There is an ointium aplasia, but there is no stent slot here. This is really clearly partial stent fracture like this. And because of this picture, we recognize there is no stent anymore here. We have to put one more stent. So we put the megatron because we thought that was fracture, and then we see nice stent expansion at the end. However, the patient coming back later, 9 months later, we see almost same picture in the posterior right coronary artery, and then we did IVUS again, and we are so surprised. That's very different picture. So go to the proximal 2-layer, nice expansion. This time is 2-layer, nice expansion. But at the site of the stenosis, it's not like the fracture, different type of the fracture. You see, this is like the multiple layer inside of stent. This is so-called overlap type of the stent fracture, the partial fracture overlapping chronic stage. And because of this, we thought we don't need to stent, but we just have to open the stent well, and we did. And this is after the opening by very big non-compliant balloon. Finally, we got the good lumen, and finally, drug coating balloon. This is final answer. Okay, to summarize, if we are talking the very complex PCI, we have to be more advanced. We have to look for the more detail. Number one, don't say soft plaque anymore. In the coronary artery, concentric plaque is very rare. However, if it seems to be a matured fibrotic concentric plaque, pre-dilatation is recommended. Be careful. Number two, vessel taper when the side branch is present, and LAD is 2 times more tapering than non-LAD. Keep in mind, and it's very logical. Number three, hematoma is the most important complication, but check the entry site. I showed the 2 different types of the hematoma. Their outcome is very different. Number three, actually, intravascular imaging can predict impending perforation. And actually, I do think the OCT could be better. And finally, mechanism of the stent failure dictates what is the best treatment. Thank you very much.
Great cases, madam. A lot of learning, and very important to clear the dilemmas and learn from those cases. I think any of the audience sitting here have any questions for her, any thoughts? Okay.
That's a very informative talk. Just wanted to know regarding the entry site of this hematoma.
We can't hear you.
Can talk a little louder.
No, the microphone cut out. He needs a new microphone.
Can increase the voice?
That was a very informative talk. Well, for an experienced immunologist like you, you found it difficult to find the entry site. So how exactly would you, that intramural hematomas, both the situations, the distal hematoma that you showed, you showed couple of cases of hematomas, right? Distal hematoma. The entry site, I feel that it's extremely difficult for us to really make it out. Would you always take a 0.5 millimeter pullback or a 1 millimeter pullback? Can you really identify it in a 1 millimeter pullback?
Yeah, we do the 1 millimeter pullback, but I don't think that's the issue of the pullback. And as Gary mentioned, after the finishing stent, what is important is just stent expansion and the edge. So edge is only like 5 millimeter, a few seconds. So you just concentrate H. And once you concentrate H, you see something or no. That's all. And then once you see hematoma, just check one more time, entry site yes or no. It's not super difficult. And how to find entry site, you just have to see the flow. That's it.
And again, differentiating between a very mature fibrotic plaque versus a regular fibro, it's again, is it going to be extremely difficult, or what tips do you have to differentiate between a mature fibrotic plaque?
Okay, that's actually very good question and very difficult question, to be honest. Very, very difficult. But I was thinking same question. And actually the answer is adjacent plaque, meaning if you see the very soft plaque together with a calcified plaque, those soft plaque has to be fibrotic. And if you see the fibrotic plaque without any calcium, I do think that should be soft plaque. And our case was very unique because of the transplant patient is something different. And that kind of adjacent information is actually most important in the instant restenosis. Because instant restenosis, neointima aplasia soft plaque, but very matured fibrotic neointima is very different. And then once you start seeing the neoatherocalcium somewhere together with the neointima, that has to be very fibrotic plaque.
If I can just comment, the first case is fascinating, the transplant vasculopathy. First of all, it's concentric. It's not eccentric. Secondly, there was negative remodeling as well as a large plaque burden. And third, when you expand a lesion with a balloon or a stent, not only the plaque has to dilate, but the vessel wall has to dilate as well. So this is not to be extrapolated into standard atherosclerosis, but it's a fascinating case.
Madam, you showed one overlapping fracture.
Yeah.
That overlapping fracture. How do you distinguish? Suppose if the patient is having a LSD, assume that a two-layer of stent struts are there.
Sure.
Is it only at the stent edge, or it's in the center of the, is it the way to differentiate?
That's super easy. So if you have the two stent and the overlap segment is always something in between, right? But that case, we know we put only one stent. And then within one stent, we see the overlap in the middle of the stent. That has to be something different. That's it.
Sometimes jailed wire is there. If they are pulling forcibly, that also lead to LSD in the mid portion of the stent, jailed wire. But how do you distinguish? Is it fracture or because the LSD it's difficult?
Well, I mean, it's hard to distinguish fracture that overlaps from LSD that overlaps. And probably it doesn't really matter.
Yeah.
Acutely, it's most likely to be LSD with overlap, but chronically, it's most likely to be fracture with overlap.
And also, our case, overlap type, you see the structure is almost like disappear. Like the stent has to be there, all three-dimensional structure. But that's almost like the deformation. So if you start seeing the very funny shape of the stent, that seems to be something not correct.
Ajay?
No, I was just going to give the follow-up on that last case, is that even with the DCB, 3 weeks later, came back with restenosis, and then he had a single vessel cabbage redo and is actually doing great. So, you know, sometimes when the stent fractures, there's not much you can do despite that. And then the other case before it, with the perforation waiting to happen, I think it was really important during the case that when Akiko recognized it, we were very, very careful with stent sizing, and we didn't have to put a covered stent, but we were really, really conservative with what we put in to be sure that we didn't exacerbate the perforation further. And that point of being able to start recognizing it's important. And even the case of the hematoma, if you see enough of them, the second one, which ended up shutting down, you could see the intima was all disrupted. Whereas the first one, it was literally just clean hematoma with no disruption of the intima.
And by the way, the hematoma that shut down also had a small perforation.
Yeah.
Can I ask a question about the LS class 1 perfs? So I had one of these a couple of weeks ago where I saw the perforation on the IVUS. It was after a cutting balloon angioplasty, and it was evident with an LS class 1 appearance on the angiogram. So we knew we were going to be conservative with stent sizing. The guidelines show that you treat those with a single DES and it should be fine. They very rarely fully rupture, so I did exactly that. And it looked just fine at the end of the case, conservative on post-DIL. And then 45 minutes later, the patient tanks with tamponade, and I take him back to the cath lab, and there's a huge perf. So is there any other predictive feature that tells you in these class 1 perforations, maybe distance of tracking of blood outside of the adventitial wall, that this is likely to become a full-out perf with emptying, or is it just that you recognize it and so be conservative with your post-DIL, which I think the angiogram helps you do anyway?
I hope I hear everything. But
So the question is there any hint that a simple perforation is going to turn into the patient crashing?
A fountain, yeah, drainage.
Patient having a cardiac arrest with a large perforation. Is there
any way by imaging can we make out a small perforation which is likely to get sealed, or versus to those which will progress faster to tamponade?
Yeah, yeah. Actually, we have two different types of the perforation, impending perforation by imaging. Number one, I show already, like the hematoma and some entry side. That's number one. And the other pattern is I call the shield aneurysm type, meaning you have no idea. But when we look into the pre and post, artery is almost 2 times large, and already you are shield aneurysm. And the Dr. Colombo sent me that type of the cases, and after looking at the shield aneurysm time of the aneurysm by IVUS, he couldn't recognize. He did a super high pressure, he puffed almost like the patient collapse. It's bad perforation because already like the shield aneurysm and making the bad. So those type is actually very difficult. We just have some idea, meaning angiographically looks like dissection but too much. And then when we look into the IVUS, already the artery is almost like 2 times large. Even we do the balloon angioplasty and making large, but 2 times large is almost impossible. So those are the type I see the bad type of the perforation.
I think, thank you. We have another, we had very interesting session, lot of messages saying that quality content is good. Many of the doctors are also standing. We request them to use. And we break for lunch now. And we'll immediately reassemble back at 1:30 p.m. And we'll have interesting things we started this year is deep dive sessions, I think, where the faculty will explain some of the newer techniques, hands-on and things on the stage.
Yeah, right?
I think, please join back immediately after lunch at 1:30 p.m. here. The other hall I had some structural and TAVR sessions, and that is also just finishing.
History is proof that great partnerships have sparked innovation and driven progress. Larry Page and Sergey Brin brought...
You can make it better, but if you low score, making the atherectomy doesn't affect at all. So really important, what type of the calcium you need additional treatment. Let's step back. Why I'm saying the angiographic appearance is important is based on this data. And we did the comparison between the IVUS and OCT and angio, how their appearance correlate each other. If you have the angiographic appearance, you see large calcium by IVUS or OCT. However, if you look in this segment, even though I see the large calcium, more than 270, some of the calcium, angiographic no appearance. What is this? This is a case example. You see the big calcium by IVUS, angiographically no calcium. We look into the OCT in the same case. You see the calcium is big, but those calcium is quite thin. Because of the thin calcium, total amount of the calcium is not so much. We couldn't see by angio. And we compare those two cohorts one by one. meaning we picking up the more than 180 of the calcium by IVUS, and we check the OCT. If angiographic non-visible, those calcium was seen, less than 0.5 millimeter thickness is the most, and total maximum thickness of also thinner. Then, ultimately, even though the large calcium, if not angiographic visible, their stent expansion is good. So those are the very important. Start with the angio. If you don't see, that's a good sign indicating the thin calcium. Then we make the calcium score because we have to see the entire picture, not only the arc, not only the length, but of the thickness. And finally, we develop thickness, arc, and length is important. But after publishing this paper, I thought I did a mistake. And because we're using the maximum thickness of calcium, that's actually a little bit mistake. And please consider this calcium score indicating any kind of calcium, including small arc of the calcium. And ultimately, this score worked well. If the score is high, poor stent expansion. But what we did a mistake is actually what is the most important predict calcium fracture is the thinnest calcium thickness. And this is a case cohort which include only the treated by balloon and stent, and we just based on the thickness of the calcium in the thinnest thickness. And if the thinnest thickness is thinner, they are most likely making the fracture without anything. But if the calcium thickness in the thinnest point is thicker, we cannot make the fracture. This is actually the most important. And there is different people talking the cutoff value, what type of the device can make the fracture. And if the thickness is thinner, we can make the fracture, even the balloon only. And a little bit thicker, we can make the fracture by cutting balloon. And the thickness is thicker, we can make the fracture only using the rotor or orbitally. So thickness does matter. And based on this, we make the new calcium score. And now thickness is the most important, more than 0.3 millimeter thickness. That's we think the most important. Those are the new score based on the OCT. Okay, so those are the evidence, but when we're talking the actual case, we have to be more detailed. So let's go through one case together, how to decide what type of the device and how to decide to end the procedure. So this is the 84-year-old female, and you see the chunk of the calcium in the LED. And we did the balloon rupture, 2-5 rupture, IVUS doesn't close, and then finally we did the rotor. And this is the IVUS after the rotor. You see the nice reverberation. This is new reverberation. How you can define the rotablator effect is at the site of the IVUS catheter, look for the new reverberation. If you see this type of reverberation, that's meaning you're polishing the surface. And then you have to look for how it looks like the other segment, because the calcium is not focal. Many times it's very heterogeneous. And this case, we see the nice polishment of the reverberation here and here, but we couldn't see any calcium fracture. So we have to do more. And then you have to decide the vessel size. At the site of the calcium by IVUS, looking for the vessel size is actually quite difficult because everything is shadowing. And look for adjacent segment. In this case, even though there is a calcium adjacent segment, we can measure the media to media. It was 3.0. And because of this, we decided the cutting balloon and using the 2.5. Because 3.0 round down, because of the cutting balloon, is semi-compliant. And this is after the cutting balloon, same segment. You see the nice fracture here, nice fracture here. And again, how you can identify the fracture, look for the outside. Once you start seeing the outside structure, there is no calcium on the top, so that's meaning the fracture. At the same time, sometimes blunt, sometimes wire, mimicking the picture of the fracture, which you have to differentiate. At the end, what is important, whenever you have the big calcium, you really have to confirm every calcium was nicely fractured, and we confirm. And next, you have to decide how big the size of the stent to cover the entire calcium. And after the additional treatment, many times vessel larger compared to the before, so we reanalyze of the vessel size, and distal portion was 3.4, middle is 3.7, and proximal is 4.0. We decide total stent should be longer, And then finally, we decided 48 millimeter stent and non-compliant balloon because this is very tapered artery. We're using the 3.5, 3.75 to expand entire segment. At the end, you have to confirm each calcium segment was well expanded, and you see the smallest area is 4.6, but compared to the distal, this is good, and this is the most calcified segment, now making good fracture and extend it, and finally everywhere is good stent expansion. So those type of the diffuse calcium, you have to step by step. Number one, how big the size, and then making the good fracture, and then at the end, where to where you treat, and everywhere is good stent expansion. Those are the process of the treatment of the diffuse calcified region. And this is final result. Okay, so those are the whole story, but there is some exception. I'm going to show the two different exceptions. This is a patient, 76-year-old male, and severe AS, and we thought this patient should have the very calcified because severe AS and old patient. But when we look into the angio, yes, there is a calcium, but not much impressive calcium by angio. And we took the IVUS, and this is the picture. And I'm very impressed this case because lesion was very negatively modeling and very eccentric calcium. And compared to the distal, it's much smaller. And this type of the eccentric calcium with negatively modeling, this is really the exception which we consider the treatment. Because if we treat this type of eccentric calcium, just balloon and stent, it's going to be underexpanded. So this is a very rare scenario. We may consider additional treatment, even though the calcium was not too big. And because of the IVUS catheter hitting the surface of the calcium, so we thought that doing the rotablator orbitally should be the good idea. And we perform. And because of the negative remodeling. And this is afterwards, you see the new reverberation after the orbitally at the site of the calcium. And then after stent, I'm so impressed. Even such eccentric calcium, we see the nice calcium fracture, making the good stent expansion at the end, which is 7.2. I don't think that's happened without some additional treatment. And to answer that question, we systematically look into the all region which having the less than 180 degree calcium. This is about 1,000 cases. And we found underexpansion is only 3.6%, which is very rare. However, if underexpansion occur, where most of the time that's mid-LED, and what we found is mid-LED is important, also the negative remodeling is important, and large concentric calcium is important. So if that is altogether, even less than 180 degree, that's causing the underexpansion up to 30%. So those we have to consider more carefully in terms of the calcium treatment. And this one is Ajay's case, also surprise. 64-year-old male and CKD, and I don't have the angio picture. You just see the very thick calcium in the proximal LED. And we are very exciting because we see the bunch of the calcium, and we thought this is a very big, important treatment. However, when we look into the IVUS, I'm very surprised because I don't see a bunch of the calcium. When you look into the surface, calcium is not too much. None of the place is more than 180. And I said, this is easy calcium. It's okay. This is mainly soft plaque. That's what we thought. And we balloon, but doesn't open well. And Ajay wanted the IVA, even I against. He did, but IVA doesn't work. And at the end, we balloon. At the end, okay expansion, but not impressive expansion. And this is a type of the case which typically difficult, eccentric surface is not too much, and we thought it's okay. We may have to do more. That's our learning point. To summarize, angiographic calcium visibility correlates with the total amount of the calcium. Therefore, non-angiographic visible calcium doesn't inhibit stent expansion. Start with the angiographic appearance is important. Number two, when you see the angiographic visible calcium, evaluation of the total amount of calcium, arc thickness length dictates necessity of the calcium modification. That's important. Thinnest calcium thickness is the most important to predict the calcium fracture. That is really the mechanism of the good stent expansion in the calcified region. And finally, even though that's rare, there are some exceptions, like I show. Very negatively modeling mid-LED eccentric calcium, we may need something more. And very deep thick calcium, we thought it's okay, but it's not okay, okay expansion, how to deal with, we have to work more. Thank you very much.
Kiko, thanks so much for that. I think that the biggest take home from not only this talk, but the talk that you gave in the last session is that you really have to think in the cath lab, and you also need to be flexible in your strategies. So, you know, it's not that there's many people at conferences, you see calcium, and then one month or 1 year they'll say, I need to rotoblade this. And then next year they say, I need to use IVL for this. And the reality is that you have to be adaptable in your strategy and titrate what you're going to do to what the IVUS and imaging shows you. So I think those are great examples of that. Any comments?
I think your presentation shows that most important thing is the thickness of the calcium. On that you depend what device you want to use. What about the long lesions with variable calcium thickness? How do you strategize this?
That's important. I think actually that's always, whenever you see the calcium, when you start looking at the imaging, it's always everywhere, right? And then everywhere looks different. And I think you have to consider what is the key segment among the entire segment. Key segment should be the circumferential calcium. Concentrate this segment and then go there, what is the thickness of circumferential calcium. And then treat them and then check again those circumferential calcium was fracture and then considering the next step. Important is many times we just focusing the stenosis. But many times when you put a stent, you try to stent normal to normal. And then adjacent moderate lumen stenosis, but actually significant calcium, we many times ignore. And then we ended up the under expansion, not at the stenosis side, but adjacent segment. So I think entire segment, but focusing the circumferential calcium is important. But in such sense, I think the Luteron 2 is very important. When you do the pullback, they co-register the circumferential calcium segment onto the angio. And then when you do the IVL, you can focus. This is most important. This is most important for the additional treatment.
Yeah, and that pullback after you do your prep work is super important because that's the only way you tell if you're going to get a fracture. People often ask, you know, you do 3 pullbacks, which is the most important one? Is it the post one or the pre one? It's actually the second one, I think, after you do your prep work to be sure that you've achieved a result before you put your stent in. So thanks so much, Akiko. That's great. Next, we're going to have Gary Mintz, who's going to talk to us about nodules and how, again, to adapt and be flexible in strategies to treat them. And if anybody has any questions, just come up or raise your hand because it's hard to see.
Yeah, so I was given the title, Calcific Nodules Breaking Barriers Through Flexible Strategies. I have no idea what that means.
Nervous to see what you're going to say, but we'll see.
No, it'll be a very boring talk. Those are my disclosures. So let's first talk about nodular calcium versus non-nodular calcium. The first clinical cases of calcified nodules were actually IVUS cases published now almost 30 years ago in a small paper in the American Heart Journal. And you can see this patient presented with acute coronary syndrome. We thought this was a thrombus. It didn't resolve with any of the typical maneuvers to make thrombus go away. And this is an old IVUS. It's not great, obviously. But you can see the leading edge is calcified, and this was a large calcified nodule. In terms of prevalence, if you have severely calcified lesions, the prevalence of a concomitant calcified nodule is relatively high. It ranges from about 30% to about 40 to 50%. But if the patient is on dialysis, the prevalence goes up to about 60%. And if you compare outcomes in severely calcified lesions, those with a calcified nodule, those without a calcified nodule, you can see that cardiac death is higher in those with a calcified nodule, as is target vesicular vascularization and stent thrombosis. The morphology of the calcified lesion is also important, and the worst outcomes are those with an eccentric calcified nodule or nodular calcium compared to the absence of a calcified nodule and just the presence of severe calcification. Now, calcified nodules come in two flavors: eruptive calcified nodules and non-eruptive nodular calcium. Eruptive calcified nodules are clustering of small calcium nodules with fibrous cap disruption, protrusion into the lumen, absence of endothelium, and overlying platelet and fibrin thrombosis, and is the third most common cause of an acute coronary syndrome, especially in older patients, with non-STEMI. Non-eruptive nodular calcium occurs within the plaque. It has an intact fibrous cap and does not involve contact of the calcium with the lumen. It's typically presented with stable angina rather than acute coronary syndrome. By OCT, this shows you an eruptive calcified nodule. You can see the spicules of calcium protruding into the lumen with shadowing indicating that there is fibrin and thrombus. While here is non-eruptive nodular calcium with an intact fibrous cap that's actually thick, and the reason you don't penetrate is because of the large amount of calcium. What about the prevalence in natural history? As I mentioned, in a patient presenting with acute coronary syndrome, an eruptive calcified nodule is the third most common cause, number one being plaque rupture, number two being erosions, and then you have a bunch of other things. If you follow the natural history of eruptive and non-eruptive nodular calcium, this is from the CLIMA registry by Francesco Prati, you can see that calcified nodules with disruption, the eruptive type, have worse outcomes than calcified nodules without disruption, the non-eruptive nodular calcium type. We have several series of acute coronary syndrome. This is one from now 7 years ago from Japan. You can see that there are three types of lesions causing acute coronary syndrome: plaque erosion, plaque rupture, and calcified nodule. And irrespective of the outcome modality, the patients with calcified nodules do the worst. More recently, the TAXIS registry, also from Japan, again the same three types of plaque morphologies. The eruptive calcified nodule type did the worst, with an event rate of 30 to 35% at 1 year of follow-up. What are the patient characteristics? Patients with calcified nodules are older, more often have non-STEMI presentation, more often have KILIP class 3 or 4 heart failure, and are more often on dialysis. And if you look at predictors of calcified nodules in tactics, again, in all patients, it's age, KILIP class, and hemodialysis. And if you're only looking at non-dialysis patients, it's age, KILIP class, and diabetes. We're starting to understand how these evolve, or how these are created. This is a case from Takeshi Kubo, one of our former fellows. The proximal right coronary artery, you can see by OCT calcification with an intact fibrous cap. At follow-up, there's now disruption of the fibrous cap with an eruptive calcified nodule. We actually have a series of these that's now in press in neurointervention, and we looked at 372 untreated calcified lesions with a median follow-up of 1.5 years, and new calcified nodules were observed in about 7%. These were calcium with attenuation, larger amounts of calcium, a hinge motion in the coronary artery, longer duration, distal left main bifurcation, and again, hemodialysis. So as I said, we're beginning to understand the underlying morphology that is associated with development of an eruptive calcified nodule. What about PCI outcomes. Well, they're uniformly bad. I don't have to say anything more, but I will show you the data. If you look at heavily calcified lesions treated with rotablator plus stenting, the event rate for calcified nodules is about twice as high compared to calcium without a calcified nodule. And this is a recent study that's just published from Professor Ochiai's group in Japan. And again, eruptive calcified nodules have worse outcomes compared to the absence of eruptive calcified nodule. And what's most important is that, as I will show you more data, the reason for recurrence is that the calcified nodule reprotrudes into the stent. So here's the calcified nodule pre-intervention, post-intervention, and follow-up when the patient presents with in-stent restenosis. You can see deformation of the stent with protrusion of the calcium into the stent. We compared outcomes in eruptive calcified nodules compared to non-eruptive nodular calcium. And it turns out you get a better acute result when stenting an eruptive calcified nodule because you can displace these little pieces of calcium. But if you have a non-eruptive nodular calcium with an intact fibrous cap, it's very hard to deform this or displace it, so you get worse acute stent expansion. Now, the reason that's important is this is one of the few circumstances in which a better acute result, better stent expansion, is associated with worse outcomes. We're typically taught that a good acute result means you get a better long-term result. That is not true with calcified nodules. The eruptive calcified nodules get a better acute result, but a worse long-term outcome. Now, in terms of predicting the ones that do badly, this is also a study from Japan that looked at the morphology associated with the calcified nodule, and they had this concept of dark calcified nodules. Attenuation behind the eruptive calcified nodule was associated with worse outcomes. And the assumption is, similar to what I showed you earlier, in untreated calcified nodules, this represents a deeper underlying lipidic plaque that contributes to a worse outcome at follow-up. So this is probably the only slide that addresses the actual title of the talk. This is unpublished data from St. Francis comparing IVL and orbital atherectomy in calcified nodules. And roughly the same number of patients in the two groups. Acute results are about the same in terms of final minimal stent area, and the outcomes are about the same. So we really have no great data on the best way to treat both eruptive and non-eruptive calcified nodules, because other than knowing that a good acute result is not a harbinger for good long-term outcome. What about in-stent restenosis and stent thrombosis? Here's an eruptive calcified nodule, here's non-eruptive nodular calcium, and here's a restenotic calcified nodule with reprotrusion of the calcified nodule into the stent. Most of the studies show that if you treat an eruptive calcified nodule and the patient presents with in-stent restenosis, the mechanism is almost guaranteed to be reintrusion of the calcified nodule into the stent. 80% in this series, 60% in this series, and 73% in this series. We also know that these happen early. So this is a study of ostial right coronary artery in-stent restenosis. And we looked at, or Akigo and the group looked at the time of presentation for in-stent restenosis after the stent was, after the lesion was treated. If you don't cover the ostium, they present very early. But a protruding calcified nodule occurs almost as early as if you missed the ostium. And then you get neointimal hyperplasia, stent fracture, neoatherosclerosis, and garden variety stent underexpansion. So not only are these recurrent calcified nodules inside the stent, but they happen relatively soon after the lesion is treated. And then stent thrombosis. This is something that surprised me. I did not realize that not only are in-stent calcified nodules associated with restenosis, but they're also associated with stent thrombosis. This from the real stent thrombosis registry, also from Japan. Okay, so you have a patient with a calcified nodule, you stent it, they come back with in-stent restenosis with recurrence of the calcified nodule. What's the best treatment? And the answer is I have no idea. So calcium compared to no calcium has a worse outcome. Calcium with a calcified nodule has a worse outcome compared to in-stent restenosis with smooth calcium and no calcific in-stent restenosis. So calcium does worse, and amongst the calcified in-stent restenosis, the presence of a calcified nodule has the worst outcome, and almost 100% recurrence rate at 4 years. Okay, so we're not going to restent them. We're going to use a drug-coated balloon, and the answer is drug-coated balloons do either as bad or as good, depending on your viewpoint, as restenting these. You can see that a repeat TLR is higher in the presence of calcified nodules, and if you compare drug-coated balloons to drug-eluting stents, the recurrence rate for calcified nodules is equally high. And here's a study comparing drug-coated balloons when treating in-stent restenosis with a calcified nodule with a recurrence rate of 85%. I'd like to finish with a simple case, maybe not so simple, a 45-year-old male who presented with diabetes, hypertension, smoking, and chronic renal failure on dialysis. Here's his right coronary artery, a focal lesion here, and you can see the calcified nodule protruding into the lumen associated with a lot of underlying calcium. The patient had stent implantation with a pretty good acute result, but stent expansion actually was pretty poor, only about 45%. 2 months later, the patient comes back, the lesion is back, and you see reintrusion of the calcified nodule into the stent. Treated with a drug-coated balloon, again, a pretty good acute result. Another 2 months later, and here's the good result by OCT. You see that the calcified nodule has been displaced and stent expansion has been restored, but another 2 months later, and it's back with reintrusion of the calcified nodule into the stent. Treated with another stent at this point in time with a good angiographic result and a really good OCT result. 1 month later, the patient is back again and eventually went to bypass surgery. So, kind of a depressing talk because these are becoming more common as our patients get older, and I think probably a contribution of chronic statin therapy, as well as specific anatomic locations such as the proximal right and the distal left main. But I think it's a reality-based talk, because that's what the data shows. Calcified nodules, particularly eruptive nodules, are becoming more common as our patient population ages and more patients are being treated with long-term statins. While the acute results are good, the long-term results are poor, regardless of devices used during PCI. I've heard talk about trying to treat these with covered stents, but I have seen neither a case example and certainly not a series. The mechanism of PCI failure is almost always reintrusion of the nodule into the stent, and treating in-stent restenosis caused by reintrusion of a calcified nodule also has poor long-term results. Thank you for your attention.
Gary, thanks so much for that. From the AV team, we have no feed on the monitors. I can't see anything on the monitors, so if you could fix that,
I
that
can
would
give
be
my
great.
talk again if you
Yeah,
want.
that's
He's
right.
in the
No.
audience.
The, I think that, in the morning opening case, there was a discussion about, it was an aortic stenosis case, about lifetime management and choice of selection and thinking in the future and what might happen. My feeling with these types of cases is that you have to think the same way. You really have to understand that the prognosis is not so good, so if there's disease on the opposite side, then maybe you favor cabbage earlier, and it's a different mindset rather than just feeling I can treat this and I'm going to have a great result.
I mean, the acute, this is one of the, as I said, one of the few circumstances where the quality of the acute result, I mean, and every company says, see, this is my device, this is my device. Use a cutting balloon, use a scoring balloon, use rotoblader, use OAS, use shockwave.
Yeah.
But long-term results are dismal.
No, and even the stent companies, my stent has more radial strength and it has different cells, but yeah, pretty much uniformly it's a problem. So, no. Any questions from anyone else? Otherwise, what we're going to do is we're going to go ahead, thank you, and start with a couple talks on rotoblader and orbital atherectomy, how to. And so this is something we want to be able to demonstrate exactly how to do the technique. Why don't we, can we bring up the model of the rotoblader, and then Sanjog can do it. Sanjog is going to do rotoblader. I'll talk a little bit about orbital, and then he's going to demonstrate that as well. I just want a quick show of hands from the audience. How many of you have done rotoblader in the last 2 weeks? In the last month? So there are people who use it, but there's a lot of people who have not used it recently, and so that's one of the reasons why we want to demonstrate the technique, and we have a model to be able to show that. How many have used orbital in the last 2 weeks? In the last month? So very similar types of numbers, low overall.
let's get the rota.
It's interesting, in the United States, atherectomy is not even available in a third of the hospitals in the United States. And despite what Gary said about the increasing prevalence of calcium, not just nodules, but in general, this becomes a challenge because we need strategies to treat it. Dr. Ruth, before he left, mentioned the lesion length being a key arbiter of success, because if the lesion length is long, the likelihood that you're going to be able to deliver NC balloons, cutting balloons, or IVL is much, much lower. And so really you need to know how to use these techniques. And if you do these techniques up front and quickly, the cases are much more efficient because you can quickly get through these vessels and then do imaging and whatever else prep you need to use after that fact. So with that, I think we seem to be almost ready.
Yeah, I think they're taking just a quick second to set this up. So maybe with this, we'll give you a little bit of orientation into what we're hoping to accomplish here. We recognize that there's a lot of meetings out there that tell you what to do, right? We had a discussion about calcified nodules where it told us whatever we do, it doesn't seem to matter, it's going to come back, right? But the idea of technical currency is what we tried to build into this meeting, where it's not just about what you do, but it's actually about how you physically do it. So the purpose of these practical sessions is to demonstrate not only the technology that we're using and how it's designed to be able to make it easier to use, but physically how to do it, so that there's little ambiguity on the actual procedure. And this is the time where I really encourage you to ask whatever questions you have, because the benefit is we have a room full of people who are either experienced with this or who are interested in learning it. And we have panels that are available that can help fill in the gaps. So you'll get an expert's approach to how to actually do these things. I wonder if maybe we can just start. Actually, I'll start on the RotoPro, and I'll just start by orienting things while they set this up.
I think that's fine.
Okay. Can everybody hear me through this lapel mic? Okay.
Yeah.
So, go ahead. Keep going. So this is the RotaPro system. Okay. The RotaPro system was an improvement on the previous system, largely focused on ease of use. And I think what you'll see, both with the RotaPro system and with the orbital system that we'll show next, is that the focus is entirely on ease of use, making it very simple to be able to do the procedure. The system itself is the same rota that we all know and love and understand, right? We have a console, instead of being behind the bed, is up in front of us that we can see at any point at roughly eye level, which is why this thing comes on an entire cart and is attached to a pole. There are 3 cords within this simplified sort of tethered single system. They all have different shapes. So they're all very easy to plug in because each cord only fits into one hole. At the back, you have the gas cylinder, which you see over here, that should have a minimum of 2.6 bar in it, should be able to input between 2.6 and 7.6 bar into the system. The RotaPro Advancer is a little bit different than the one that you're used to.
So can we fix the cameras? Because right now your camera is directly in line with the pole, so we can't see what's on his hand.
Right.
So you need to either take that off and move forward, or go to the other camera.
And just zoom in here so you can see this. Right? So the RotaPro Advancer is...
And then can you go to his camera feed, production-wise?
Thank you. We'll wait till that comes up. So we should... Gas is ready, Ron? Great, okay. Super. Okay, so the RotaPro Advancer is effectively everything that was on the pedal, all here. You're dripping there pretty aggressively, so you're going to want to stop that. So that everything you need is all here, right? You no longer have to go back and forth between your fluoro and your pedal. This button is the on-off button. That's effectively the same thing as the pedal you used to stand on. DynaGlide, which now allows you to do a lot of in and out with the burr without having a second operator, is located here on the Advancer column. It says Dyna on it. And interestingly, Dyna can be operated both by the same activation button as well as by this momentary Dyna button at the back. Okay? And what that allows you to do is turn Dyna on and off while you're holding the Advancer all with one hand. And you'll see why that's important in a minute. And then this is the brake defeat that used to be on the old console, or that used to be on the old Advancer. Right? So it's effectively taken all of the controls and just put them in your hand. Okay, so maybe we'll bring the camera here and we'll have you focus a little bit on what we're doing. The console, you can show that to the audience, and can you just focus here? The console is a stripped down console, so it's just as easy to use. The knob is a little bit more responsive, so rather than having to just tap it, you actually have to turn it to be able to make it change speeds.
Can you switch to the console, not his hands, to this camera here?
Okay. Can you wet this? I think we're gonna. There we go.
No, you need to be on his camera here, his feed.
And just straighten this out for me for a second. Okay.
Just wait.
Okay. So the console, you'll see sort of 0K RPM.
Yeah, they can't
there.
see it. Sanjog, they can't see it.
Still can't see it. This camera should be focused on that console.
No, his camera is focused. They just need to get his feed on the thing.
Yeah, your feed needs to be up there. So from here on in, I want you to keep his feed as the primary feed. We don't need to see those cameras right now. We still don't see his feed.
We still don't see his feed. So just hold.
Take a step back. Keep going. Okay, so we have now a feed here, but what I want you to show is that thing. There's no drip right here. I don't see it. Yeah. Not yet. Just let it sit down for a second, and we'll get it set up in a moment. Just once we get the camera set up. Apologies for the camera issues. So while you can see my hands, you see what the setup is like here. Isko yahan le aao. Okay, we'll get this out of the front way. Oh, okay. Okay, well, we're going to have to manage that. Okay, so you have your rota burr loaded on your wire, and you have the back end of your wire coming out the back end here, right? This is the same as the usual console that you're familiar with. So the idea of single operator rota operation, okay, isko unlock kar do, because there's no drip coming out here at all. Okay, the idea of single operator rota operation is to be able to leverage the components of this system that are designed to make your life easier, which is your dyna, your instantaneous dyna, and your brake defeat all on the same console. Okay? So I don't think your feed is going to work out, so let's just focus here. So just come this way and you can focus here. Okay? So in order to do usual rotablation, typically you have one operator holding a wire, and then the operator that's advancing the entire rota system into the body, right? So you need two people working in sync to be able to do this without wire movement. The way this is designed, it's meant to make this a little bit easier so that you don't have to do that. So this is how that's done. So let's say we've started with our burr loaded onto our wire. Okay, remember this wire torquer. It's going to become important in a moment. So the first thing that we do is D, draw, right? D is drip, so make sure that you have some sort of dripping coming out of the primer or the rota solution so that you have some lubricant. R is you rotate. So let's focus here now for a moment.
Yeah,
so
that camera's not working, so there's no... That's,
all right, okay. So we focus on the dyna button here. We push DynaGlide on, and then lifting this off of the towels, your gas is off. Your gas is off. You need to turn your gas on. Okay? So your gas cylinder is empty. Anyway, your DynaGlide will turn on. You can test that. Okay? Then when you're done, you turn DynaGlide off, and you can turn it on. Is that hooked in? Okay, so just advance that. Can you turn the knob, please? Turn the knob up. Turn it up to 160 or 180. Pick one. Just turn that up. Right, so this is how you advance the knob. You set your speed. Okay, keep going, keep going, keep going. Good, stop. That's fine. So you turn it off. Advance this one tick forward. Okay, and then once you've got it locked here, and your lock is a quarter turn on, quarter turn off. Okay. And you've confirmed that when you open it, your advancer will move back and forth. You turn DynaGlide on with the button. Click. You take your wire torquer, click it onto the back, and you bend this over so that it fits into this slot right on the top of the advancer. And you push. So your torquer locks into the back of the rota console.
And so the idea behind this is that whenever you spin, the brake actually activates and prevents the wire from moving.
Correct.
But what you want to do in this case is get it into the body, so it needs to move over the wire. So you need to defeat the brake, which is why that button is pressed in, so then the brake is no longer active.
Correct. And so with the brake defeated, it allows you to slide this. So you open your Y connector, and you slide this in just slightly. And you can even close the Y connector at this point. And then with Dyna on, with your brake defeated, and with this locked in place, all you have to do is turn this on, and you just shove your burr in, and your wire doesn't move. So now you don't have anybody else doing anything at all. You're just advancing your burr all the way to where you see it exit the guide, right? And unfortunately, the spot camera isn't working. Otherwise, we'd show you the model that we have here, and you can see that the wire is not moving at all, and we're just advancing the burr, okay? And once it comes out, you straighten this out. If you're at the tip of your guide, you then turn this off, and you're there. That's all there is to it.
a review of the steps is you hook into the back so that your brake defeat is locked. You make sure dyna is on. You slowly introduce the burr into the Y connector. You turn it on, and you just advance the burr. And what you'll see is your wire is controlled at the back. It creates a giant loop that is attached to the device. So you will neither get contaminated, nor will you kink. And then the process for going ahead and burring is just point, turn your dyna off, click, pull your wire torquer out of the lock, take your tension off, and shoot. And that's it. Okay?
So the advantage of this approach is that you can only have one assistant, and that assistant can do all the hookups of the console. And that person, once they're done, then you can do everything else yourself by putting it in. So it takes off the having to coordinate with multiple people during the case and to sort it out that way.
And when you're removing the burr, which makes life, it's the same thing, it's making life easier. You open your Y connector. This is where you turn dyna on, okay? And then this momentary dyna and brake defeat is what allows you to remove the burr easily. And that is just by pushing both of them together, right? And feeding the wire. And your burr will come right out.
We can't see your hands. Can you show his hands, whatever camera that is? His right hand?
So as you should,
there you go.
the RotaPro console is meant so that you can grab it here, right? So as you hold this, you open the Y connector, you push the momentary dyna with your index finger, your thumb on the brake defeat, push them both, and just feed the wire and walk it right out. And it will come right out. And you won't have any wire movement. It's wise to step on the fluoro to confirm that. But the key is that whoever your second op is, even your assistant, just make sure that they hold the Y connector open, or if it's one of these where it can lock open, it makes it easier for the burr to come out. It's very important that it is open, because if it's closed, it will hold the burr in place and you'll have trouble doing that. So all you have to do then is push these two buttons together while dyna is on, feed the wire, and it will literally push the burr right out. And when you're done, you take everything off, and you go ahead and do your PCI. On this particular wire, which is a Rota drive wire, it was designed to be able to do a PCI on. It was designed to be more torque responsive and a little bit more like a workhorse wire. Having said this, if it's a complex PCI of any sort, don't be a hero. Swap out the wire for a regular workhorse wire and get your case done. Any questions there?
So sorry for the cameras, but I think overall, Sanjay's great demonstration of how to do it. There are also videos on this online. You can look at it, and it's worth perusing those to sort out what's going on that way too.
Okay, thank you.
Yes, no. So
Great, we'll take this one off, and we'll bring the next one on while Ajay does his first few slides.
And I don't know if we should do it, frankly, because the camera's not working. So that's what we'll do. All right, so what we're going to do actually is we're going to move and talk a little bit about orbital. I'm not certain that the cameras are set up in a way such that this can happen. So what we'll do is while they're bringing it up, I'll give a brief overview of both Rota and orbital together so that it's more contiguous and it makes sense that way. And then what we can do is if the cameras are appropriate, then we can show you the model. If not, then we won't do it. So let me just open the slides. And what I'll do is I'm going to talk generally about both Rota and orbital. And if you can pull my slides up on the screen. Great, thank you. So I think the first thing is, and this is really to strike home the point that Akiko made in her talk before, is the most important premise of any calcification modification strategy is to create a fracture so that the vessel can expand. Most people think of calcium as problematic in terms of getting your stent to where it needs to get to. But the problem is not just that, it's that when you put the stent in, if you can't expand the vessel because it's calcified, because it's a rock, then when you put the stent in, you're just going to make the lumen smaller because it's constrained by the calcium. So as Akiko showed you pictures in IVUS, this is a picture in OCT showing that if you have a fracture, you will get a bigger MSA. And just as she showed you before, that thinnest part of the thickness of calcium determines if you're going to get a fracture with a standard balloon-based approach. When it comes to both Rota and orbital, the idea here is not just to debulk the calcium as you're going in, but to thin it such that it will then subsequently fracture when you balloon it later with an NC balloon or after you implant the stent. So the system, and I wish we had a slide like this for the Rota, but the Rota has many of these things and is more familiar, is basically one where there's a wire, there's a pump and the generator that actually spins the device, and then it's a device that's handheld. And what was nice about this, and this was mentioned in a prior talk, whenever you have competition, it's a good thing. And so actually Rota had existed the way it existed for a long time. When Orbital came around, that's when the pedal went away and everything became in a single hand-based approach. That's where the console got smaller and it could come into the room faster. And so it actually has made Rota better to have this sort of system around as well, which is, I think, a good thing. The wire that's used in this case is basically a nitinol-based wire. There have been iterations not just to this wire, there's also iterations to the RotaWire. Sanjog mentioned the RotaWire drive. So both of these wires are now much more torqueable than the old wires used to be. The initial Viper Wire Advanced that came out with the CSI system is a very, very stiff wire with a lot of wire bias. The one now that is used in almost all the coronary applications is the flex tip wire, which basically allows you to not have as much wire bias when you're going with orbital atherectomy. And as Sanjog mentioned, the tips of these are better so that you can sometimes even just primarily wire with this device. Now, most people think about rotablator as a front cutting drill that you go through and you want to make a hole. The mechanism of orbital is different. So there's no front cutting drill. What this is actually this weighted thing that will sort of sand the vessel in the inside and basically get a bigger lumen that way. Because it orbits, it's only a 125 device, but can get up to a 175 lumen. So you only need the single device. You don't need to use multiple devices in the coronary. There are bigger devices. Those devices are used in the periphery, but for coronary use, this is the only one that's needed at present. When you look at how this works in terms of mechanism of action, it's different from rotablator and it's different from things like IVL as well, because with rotablator, you're making a channel and the channel you get is the size of the burr. You then need balloons to do additional work. But if you thin the calcium sufficiently, then the balloons would work fine. With orbital, you not only get that channel, but you get a bigger channel because it's orbiting around as well. So there's not only the sanding, but there's forces against the wall that can have some effect as well. With IVL, you know it won't make the channel. It has to get through to where it needs to get, but then it can fracture in a bigger vessel as well. So there's a variety of differences between these techniques, and that's the reason why I think that you need to kind of know about all of them because they're complementary. So this is a slide that I've put together, and this was just published in Neurointervention, that compares and contrasts orbital with rotational atherectomy. The orbital system is a single device, just 125. It has 6 French compatibility, so you can actually put it through a guide extension as well, which is useful for radial operators. In general, when you do these ablations, because you'll see the speed of the flow is much faster, you tend to get less no reflow and problems like that. And then you can use a glide assist feature, which Sanjog will demonstrate. There's no gas setup with this. It's just all electrical and plugged in. For Rota, you can front cross. So that means that if you have an uncrossable lesion, it's very effective. If you're in the subintimal space, it's probably safer because it's not orbiting around. If there's severe angulation and bias because it's a straight shot, that's advantageous. And then if you need a very big burr, it has that option as well. And in terms of cost, the single device typically, at least in the United States, is cheaper than that of orbital. Now, but the key point is that either device can be used in most cases of severe calcification. And so I actually think it's better to have familiarity with both rather than just one. Now, a general rule of atherectomy, would you atherectomize this lesion? Because a lot of people are scared of atherectomy because of cases like this. But if you think about it, this lesion is so tortuous and so angulated that no atherectomy device is going to be safe to use in this particular circumstance. And the way I can show you that is with the wire end. I've now traced the wire. This is the course of the wire, but the vessel goes like this, up and down. You can't see my pointer, actually. Sorry about that. Now you can. Basically, the vessel goes up and down, and the wire goes like this. So what do you think is going to happen when a device comes this way? You're going to get a perforation. And that's exactly what happened, and that would happen with either orbital or rotational atherectomy. So you have to have good clinical judgment in using these technologies in the right way. So how do you treat serial lesions? And then I will go to the model because it looks like it's set up now. This is the case of a left main. This is a case where there's an OM lesion as well. And so the idea was with a single device to be able to treat this. And so the microcatheter wouldn't actually cross that distal lesion. So what I ended up doing is getting the microcatheter wedged to this point here. Let me drag this mouse over to this point here, and then free wired the rest of this with the Viper wire. So it's that type of wire that you can do. And then the idea is to use low and high speed at this left main area here, to then not ablate this segment here, so to glide assist through that, and then to ablate this segment here with only low speed, because high speed would potentially be too risky at that point. So low and high, glide assist, and then low. And this is what it looked like after we did our orbital atherectomy, better result. But the idea here is to just thin the calcium, debulk it so that then the balloon can do its work, and that's basically what we did. Pre-dilated, crack the calcium, and then after that, put in stents, and I'm not going to show you the stents or the IVUS at the end, but this was the final angiogram that's being done. So maybe, Sanjo, you want to demonstrate now what the system looks like. If we can get the camera zoomed in on him and then switch the feed to that, then we'll be in good shape. Right before he goes, I also want to just point out that at TCT this year, we'll be presenting a 2,000 patient trial of orbital atherectomy versus conventional balloon angioplasty, so stay tuned for that. So can we go to the feed where Sanjo can show his hands? I need to switch the camera to switch the camera so we can see what he's doing. Now, is it working now? Okay.
Okay. And I think is this microphone working now?
That's working.
Is that better?
Yeah. Yep. Okay. All right.
All right.
This is what it was supposed to look like. That's
right.
Great.
So, unfortunately, whereas the last device was working, this device is not working, so you're going to have to use a bit of your imaginations. So this is the orbital Diamondback 360 advancer, okay? You'll see that most of the atherectomy devices are moving towards an all the controls in your hand type of configuration to make life easier on the operator, because ultimately atherectomy is an easy therapy to do. It's just a matter of understanding the equipment and when you should and shouldn't use it, okay? Here is your advancer knob. When it's parallel to the track of advancement, it's locked. By turning it a quarter turn, where you can grab it, it's now unlocked. So you keep it locked, whereas with the Rota, it's a quarter turn. It's very similar that way. Here's your on-off knob. Differently, whereas the Rota has 125, 15, 175, 20, 215, 225, 238, and 250 burrs, this has one crown, but with multiple speeds, so that your atherectomy can be provided in vessels between 225 all the way up to 40. Here you see the low speed setting, okay? It's got the lower sort of trapezoid, and then the high speed setting. High speed gives you a higher arc of ablation. Low speed gives you a smaller arc of ablation. This is the brake. This is defeated. This is on. And here is the wire. Whereas here you don't have one of those special torquers to advance. Your brake is here. That has some advantages and disadvantages. It can make life easy in some respects with respect to managing the back end, but it also makes it a little bit more challenging to do single operator operation, though it is still possible. It's just a matter of coordinating with yourself, okay? So when doing single operator orbital atherectomy, your device will arrive like this, where you're loaded on the wire. Just come this way, right? And you'll see that there's dripping happening here as well, okay? So you've got your
But one thing to notice is that the flow rate is much faster than it is with Rota at rest, and when you turn it on, it goes up even faster than that. And that may be one reason why there's more flushing of the vessel and perhaps less slow flow.
Right. And so if you open up the brake, you turn this on, just focus on the advancer here. This is where you can test whether or not you have good knob movement, right? So here, you put the brake on, and do you see your crown is moving back and forth in concert or union with your advancer knob. So now you lock this again, okay? You open your brake defeat, And in this situation, you just slowly, once you've tested the device, advance it into your sheath, or in this case, your guide catheter. Because the brake is defeated, your advancer or your crown will move freely along the wire, and you shouldn't move your wire all that much. You might move it a millimeter or two, okay? Once that's done, this is where the difference is with Rota, where with Rota you have the dyna setting. Here you have something called glide assist.
Can you switch back to his...
Here, show me here, show here. So glide assist is like the low speed rotation lubrication of the system, where it allows movement of the crown easily along the wire, similar to Dynaglide for Rota. The way you activate that is by taking the low speed button and just holding it down until it flashes. Now your glide assist is active. And in fact, with glide assist active, it actually allows you, like Dyna, to move the wire back and forth and rewire if you need. So I'm going to turn that off for a second, okay? This is locked. So what I usually do in this situation is create a loop once it's just introduced into the system, so that, again, I have control, okay? Turn on your glide assist, and the moment you turn on the glide assist, it will start to orbit slowly within the guide. And now, with a single operator, you coordinate your movements. So you just advance, so show my fingers here and my hand here at the same time. So back away and show this hand and these fingers. So the way this is done, whereas with Dyna you can lock the wire at the back on the RotaPro and just advance, here you actually have to coordinate movements, but you coordinate with them with yourselves. So it's not so bad. Where you have your right hand on the wire, your left hand on the advancer, and as you advance in, you pull out. And what you'll see is that your wire doesn't move, and you very quickly can introduce your crown with glide assist on. Okay? And then here, once your crown is within the system, you take this loop out, you put the lock on, you turn glide assist off, okay? Take the tension out of the system the same way as you would with a rotoblader. Choose your atherectomy speed, your orbiting speed, and then you unlock, turn it on, and you advance. And when you advance slowly, about 1 millimeter per second. The slower you advance, the better arc of ablation or the better arc of atherectomy you will get. With this device, you get less slower flow. The downside is you have to go back and forth more often because it's a helical method of atherectomy, and so the slower you go, the better arc you get, but ultimately you need to go back and forth multiple times to be able to fully atherectomize the lesion that you're working in. The other difference with Rota is a front cutting tool. So for your ultra-tight lesions, you need a front cutting tool to be able to address the lesion. You need the diamonds right at the tip that can allow entry into the lesion. Whereas here, you have the added benefit of being able to atherectomize antegrade and then turn off right at the lesion if you have to, and turn back on and atherectomize retrograde. So you get the benefit of being able to atherectomize in both directions. And then on removal, once again you turn on glide assist, only this time you need someone to stand there as you open up your brake defeat and you walk out your device. Okay, and this you'll do on fluoro so that you can see your wire placement. But once again, it's only with one operator. You don't require two.
Perfect. So thanks, Sanjog, for that. And so hopefully for everybody, that was a reasonable demonstration of both. Sorry for the technical difficulties. In the booths, or the training villages, they'll have these models and such, so you can sort of play with it. But the idea is to get some familiarity with it. And if you do it repeately, or if you do it enough, then it becomes second nature, and it's quite straightforward, and it makes the case more efficient. So these are these atherectomy systems. We also have now time to talk about IVL and laser, so we'll move on to those next talks. And certainly Sanjog and I are available to talk after that. So if we can get Dr. Rajendra Kumar Jain up, we'll then talk about laser, when and how.
Good afternoon, everybody. Greetings to my teachers, mentors, my colleagues, and I thank my best friend Srinivas Kumar for giving me opportunity for this talk here. So my talk, I don't have a demo like Rota or Rota Pro and orbital ectomy. My talk is a simple one. This is a much simpler device when you compare to RotaPro, but I'll just go through how to use it and when to use it. I have some good experience on this therapy, and I found extremely useful in certain situations. Coming to just laser sign, what is laser? Is just light amplification by stimulated emission of radiation. These are the FDA currently approved indication for excimer laser coronary angioplasty. First one is very interestingly balloon uncrossable and undilatable lesions. So this is where I feel this therapy has a lot of value, and it has really bailed us out in many of the situations. So this, in fact, I feel it's very, very important area of therapy. Second is multifocal thrombotic saphenous vein grafts. This also is a very important situation. As you know that, especially in our country, a lot of bypasses were done 10 years back, and those patients are coming with acute coronary syndrome and SVG crack, acute MI. So this therapy, I think it's very useful in this situation. Chronic total occlusion, again, once you cross with the wire, when nothing crosses, this is very useful therapy, I feel, and probably you'll also feel like that. I'll show some couple of examples. Moderately calcified lesion, ostial lesion, eccentric lesions, more than 20 millimeters, they're all borderline indication. But instantaneous stenosis, especially when you feel is an under-expanded stent, and it's a very good therapy, I feel. So I'll just, these are the rare case reports of ALCA use also. When under-expanded, under-deployed stents are there, you can use it to expand the stent well, because this acts outside the stent area, and any calcific plaque, it breaks that plaque, and then you can expand the stent. And also in case of large thrombus burden also it can be used. And the second rare case reports modification of proximal cap of heavily calcified lesion when initial attempts to cross the rotablator wires were unsuccessful. This is also a very useful indication for use of a laser therapy, and we have a couple of examples. I'll show you that. How to use a laser? These are the 5 S of the laser success. Selection of the patient is very important. You should know when to use a laser. The morphology lesions you should know. Size of the catheter, the tighter the lesion, smaller the catheter should be. Settings is very important. You should know what is fluency and what is pulses. And saline flush is important. Always, until you do like a couple of dozens of lasers, you should only use saline. You should not use a contrast or a blood. So you should do flush 1 to 2 cc per second. That's very important. And the speed, you should advance very slowly, so 1 millibit per second, because you'll ablate the lesion when you pass the catheter. And very, again, important that the size of the catheter should not exceed more than 2/3 of the reference vessel diameter. And when you have more experience with laser, you can use a contrast, so the vapor bubble will be more powerful and more energy is delivered. And some people are doing with the blood, but I still feel, even though I've done 60 cases of laser, I'm still not doing any contrast laser or a blood laser. I'm just going saline still. A very important point, you should know what is fluency and rate. Fluency is the energy delivered and directly relation to the size of the vapor vessel. So if you use higher fluency, there's a larger bubble. So higher settings are definitely required in a patient of a calcium or a heavy thrombus burden is there. Second setting you should know is what is rate. The repeated rate of pulse is like jackhammer effect. So if you want to repeatedly hit, increase the rate. If you want to a slower hitting of the rate, you decrease the rate. And this is also, the increasing the rate doesn't increase the size of the vapor bubble. So if you want to have a calcified lesion, so you increase the rate to more. So how will you start doing laser? You start with a low fluency like 25 fluency and 25 rate. And then second pass you can increase the fluency and increase the rate. So you can start with 25 and increase to 45. And if you're more comfortable and the lesion is more calcified, make it 80 also. So that's how first pass should be with lower setting. Second pass increase the fluency and rate. And third pass you can increase both fluency and rate. So these settings you should understand how to increase these settings. I'll just show us a couple of examples. This is an 84-year-old male who came to us with an STEMI and cardiogenic shock. He was treated with cardiogenic shock with severe dysfunction. He came. He was advised a bypass surgery. Then patient said he refused for a bypass surgery. He had iron deficiency, anemia, and B12, which were corrected. He came for an angioplasty. So we planned for a rota PCI to LAD first, and then the RCA was CTO we wanted to do, 2 days later. We finished rota angioplasty to RCA. These are the pictures, and this was a regular case, and we stented with this stent, and we took him for angioplasty to RCA here. You can see the contralateral injection. You can see the total occlusion of RCA there, and antegradely it's a very bad tight lesion here. So we use a long sheath for a good power. We used a AL 0.75 for a good backup, and we used a crosshair probe for a support, and we used a Fielder XT2 probe and cannulate the crosshair probe, and we crossed with the Gaia 1. So everything we're very happy here. You can see the Gaia 1 parked there, and here nothing goes. No micro. My crosshair probe doesn't go. 0.75 millimeters. Alveolar balloon doesn't go, and then we put another wire and use an anchor technique, 2x12 anchor balloon. Nothing goes. So we cross the lesion with a Gaia wire, and here we have with a situation where nothing is crossing. So what you'll do? So see again, you can see both in lateral view, you can see my balloon is not crossing. The smallest balloon available and the best balloon available is not crossing. And my anchoring also is very good support, and have AL 0.75. Everything is good, but nothing is crossing. So we have a laser. We use 0.8, 80 fluency and pulsatility up to 80. And this is what I told you, but it did not cross the whole lesion. It makes a space for all the hardware to go. And you can see my laser catheter has not gone all the way the lesion. It made a way that even if you go half of the way, you can deliver all the devices what you want. So this is what we did. And after that, my crosshair pro could cross easily. I put a cyan blue wire, workhorse wire, and we did balloon dilation with 2x12 and 2.75x12, and then stented with 48 synergy, and this is a final result, and patient is doing fine 1 year later. So this is one indication I felt definitely, especially in centers where a lot of complex work is done, you need this also to be there in the shelf to bail out in this situation. This is a very nice, interesting case where we did a decay crush in a patient with a badly spontaneously dissected coronary artery. He's a 70-year-old male. He underwent a PCS stent in 2008, and he was fine. But now he is having recurrent postprandial angina, which has caused him lose 4 kilos weight loss. This is the left angiogram. The stent is fine, and these are two pictures. You can see the stent is fine. If you see the right, you can see this is a bad spontaneous dissection all the way from the right proximal RCA to the distal RCA. There's an angiogram, and we counsel the family that we can fix it with a decay crush. And we thought we might have difficulty in crossing the lesion here, because it's a badly dissected artery. You can go into false limb and you can close the arteries. But we wanted to be very sure that we'll park our wires in both the branches and start doing it. So we started doing it, and this is our first wire. We could cross easily into the PLVW, the bigger branch, and other branch we had a problem. We were stuck here, and we took a microcatheter support, crosshair pro, and we can cross the second lesion. So it means the first wire passed the channel. It is not allowing another wire to pass or any hardware to pass through it. So we thought we'll use a smaller balloon to dilate. Nothing crosses. Then we took a guide extension support, so that because it was a right Judkins catheter, but it doesn't go. 1 millimeter, 1.5 millimeter, the wire is not going, so nothing goes. So here we had again Elka catheter handy, 0.9 millimeters. We used a fluency of 80 and a rate of 80, and for 1.27 minutes, and that made the way. And then we could park we could dilate the wire, dilate the lesion. Then we could park the second wire in the second branch, and then we pre-dilate the lesion, and then we did a kissing balloon. There was small extravasation of the contrast, which we expected probably because it's a spontaneously dissected artery, and we use a laser there. And we used a Ultimaster 2.75 into 28 millimeter stand. We did all the double kiss and double cross and decay crush, the regular, all the steps were followed. And we implanted 3.5, 48, 3.5, 48 Zions expedition. And then this is the final result with the case, and this is a final angio. So just to start with this case, we never thought that we'll use a laser here, because spontaneously dissected. Our challenge was main to get the first wire. It went in easily, we were very happy, but the second wire were not able to cross because the lumen is so much. So we used laser here and that helped us. So these two situations where I said uncrossable lesion, undilatable lesion, this therapy really works for us, and we're happy with it. A second situation I was very happy with whatever little experience I have is a SVG thrombotic lesion, acute MI situation, what you do. This is a patient we operated in our hospital, our team, only 2009. We had Lima to LAD, SVG D1 and OM1 and RCA in 2009. He was admitted in February 2023, another hospital with cardiac shock, recurrent angina, LVF, and then he was shifted to our hospital with recurrent angina and LVF. So we did they did an angiogram, but it was not very good. So we did a re-CT angiogram, and we planned for a SVG, PCA to SVG to OM and diagonal. And if you can see this SVG angiogram, you can see it's very hugely thrombotic burden there. And this is SVG angiogram in other view also. You can see I'm crossing the wire. And we use a ELCA catheter here, 0.9 millimeters ELCA catheter, SVG to OM, and you use a fluency of 60 and repetitive rate of 60. And we put a stent, 4x38 onyx stent, and we used a filter here. Which I generally don't use, but a lot of people don't believe it. I don't feel much role of filter, even acute situation. And this is a final result. And this is TIMI 3 flow. And then after this, we did SVG to diagonal on the same setting. So it was both the lesion we wanted to finish. We didn't want patient to come back because he had recurrent angina, and this is also pretty bad. And here we just use ELCA laser, SVG to diagonal, and we didn't use a filter. We just wanted to show that even if you don't filter, some of these, not a randomized trial, but and pre-dilate 2 into 15 millimeters, and we used 2 stents, and this is a final result with a good flow in the diagonal, and this is a final result. So contraindications, yes, there are certain contraindications. Acute angulation, better don't use it because this can cause perforation. Coronary dissections, don't use it. Unprotected left main, don't use it. And if you have long subintimal course in a chronic total occlusion, I think you should not use this therapy. And we can have problems. I had one coronary perforation because it was a distal PLVW branch, huge branch. It was acutely angulated, acute MI, huge thrombus burden. I made a mistake there. So even though good experience, still mistakes can happen, and patient had a perforation. Take home message, laser atherectomy is a valuable tool for treating complex and resistant coronary lesions. I feel definitely it's one of the therapies you should have in your lab if you start doing more complex procedures, especially uncrossable lesion. Efficacy and safety are well established when patient applied appropriately, and you can get good results. We need definitely more data to routine use of ELCA in patient with instant restenosis and heavy thrombus burden. We don't have much data still. Make sure that you follow all the 5 S's of ELCA. When to use this lesion, what is the setting, saline flush, slow sizing of the catheter, slow advancement of the catheter. These are very, very important things when you use laser therapy. Thank you very much.
Thanks so much for that. That was a great talk, and I couldn't agree more with in terms of the indications for balloon uncrossable lesions. It actually can get you out of trouble. Sometimes you think it's going to work, it doesn't work, but as you said, if it even just makes a little bit of a channel, that often changes the compliance enough that it will then do what it needs to do. We used to use it more for underexpanded stents, but now with IVL we tend to use it less, but it's still an important thing to have around and in your lab. So with that, I think we're going to go to the last talk of the session, or one of the last talks of the session, which is on IVL, and we'll basically see how you manage your pulses and how you do your prep, and Dr. Reddy is going to speak.
Thank you. My apologies for my bad voice. Thank you, Srinivas. It's always a pleasure to be a part of TCT India. You just read through that. A line is made up of the lamps is digested. An interventionalist, by the calcium he has broken. Why we say that is because what starts off as the microtombs of the dying and the dead smooth muscle cells and macrophages coalesces into really unbelievable rocky mountains. And you can face the challenges only inside the arteries, and many a time the way it feels like you're playing golf in a rocky terrain, sometimes like driving a limousine in a tortuous rivulet. You have seen this, and then once you go through the challenges, then you understand the challenges we face. And here comes in my opinion, one of the greatest revolutionary innovations in cardiology, that is intravascular lithotripsy balloon. We know the three traps of calcific lesion plasty, the device crossability, the lesion crackability, and the bed carpetability. And the most important is to make sure that you are not landing up with the illusion of crackability. This is always a point. Many a time it appears like you are cracking the lesion with the balloon, NC balloon. Unless you do a cine, you will miss that it is not cracked in the real part. And unsafe crackability. This is what everyone should be aware of. If you don't have all the gadgets or expertise, unsafe crackability, don't do with the NC balloon. If the waste is there, it melon seeds and causes a bad dissection distally. In an uncracked lesion, it is a disaster. At the same time, the dog boning can cause dissection of the distal or proximal healthy zone if it is a short focal lesion, and then again a disaster. So make sure you're not landing up with that. We have superficial and deep calciums, and we have all the technologies we have discussed, and we are focusing now on D therapy, which is the most calcium-specific therapy. All others are not specific to the calcium. Atherectomies may to some extent are, but this is highly calcium specific. It doesn't abrade the tissues. It doesn't do any sanding or cuttings, but it causes calcium breaks within the location where it is without any extrusion of material. So no slow flows, no reflows are not there. You can use guide wires in the side lumens. There's no problem with additional wires, and it cracks both superficial and deep. The only thing is you have to be able to send it to the lesion. That is the only issue. So there are a lot of advantages there. We'll go through that. So you know that imaging is mandatory, and you know which lesions need a calcium modification. A circumferential calcium modification can be assessed even by a simple balloon boost. If you don't have any imaging modality with you, put an NC balloon before opening up the balloon. Try to see a stent boost, the so-called stent boost, with a plain balloon NC. You can see in two orthogonal views, and you know whether the calcium is all around, deep, and long, and you know you have to modify the lesion. It's a simple man's imaging technique. Why I say it is revolutionized, because I'll show you some examples. This is a technology which I always feel every cath lab in the country should have, everyone who is doing primary angioplasties, because nowadays we are coming across many primary MI STEMI scenarios with a lot of calcium and non-crackable with the usual lesions. And in a STEMI with a calcific thrombus and a calcium there, I think this is the only safest technology. You can't use atherectomies that easily and without much problems. Post-CABG, native CKD dialysis, elderly, and of course nowadays with the rampant use of statins, more calcium. Intense exercise is also known to increase the calcium, and warfarin patients, all these are calcium territories. You can see there, you can see the console which gives the power supply. You can charge it and keep it ready. And the connector cable is there, and this is the connector cable is plugged in, and then once you are charged there, the power is on. There are two buttons. One is the power. Both lights are on. The therapy one, you can put it on whenever you want it, and then put it off whenever you don't want. The connector cable is very easy. You put a sterile sleeve onto that, like with any other device. Okay. Yeah, you can shoot that. Then you can, this catheter, IVL catheter, comes in 2.5, 3.5 and 4 mm diameters. The end is a magnetic connection only, quite simple. And once it is all a sterile sleeve, you can, through the sterile sleeve, you just have to do the magnetic connection. It's very simple. And once it's connected, you know that the connection is on. The catheter is quite simple, the usual woven for wire. There's nothing new about the catheter except the preparation of the catheter is of paramount importance. This needs absolute de-airing. So you make a contrast, unlike the 50-50 or contrast what we make, our practice is to use 18 ml of contrast and 12 ml of saline. And that contrast should be used with a three-way, and then absolutely stringent de-airing has to be done, because any air bubble in the system might not only reduce the efficacy, but it can induce an IVL balloon rupture. So that is very important. And once you have done that, these balloons are all 12 mm in diameter, in length. And you can, I don't think, this I'll show you in the slide. At 12 mm length balloons, you can pass like in a routine RX system. And once it goes into the The profile is about 0.43 to 0.043 to 047. Little bit, almost slightly less than twice the usual balloon, so it might have a little bit of toughness in dealing with curves, and there are techniques to negotiate that as well. So once we connect the system, as you can show here, the 6 French guide is needed with a C2. Yeah, I think the slides should be on, please. Yeah. So this is the balloon I was talking, 12 mm between the two markers, balloon markers, but the emitters are placed eccentrically. The distal emitter is about, here you can see 4 mm gap, here it's only 2 mm gap. This is slightly important when you're trying to overlap the therapies. So at this point you should be aware. This is meant for easy negotiability. So once you connect the balloon and the balloon is placed in the appropriate lesion, making sure that you are centered around these areas, once the therapy button is on, first inflate the balloon to 4 atmospheres only. Lithotripsy delivery is done at 4 atmospheres. In a 1:1 sized selected balloon, you just have to get the balloon onto the wall or the plaque, whatever is there, and then start the pulses. The pulses are delivered. You can see the therapy on button, the second one, and the main therapy on is on in your hand, and then you direct it. Once you press it, it starts delivering 1 pulse every second for 10 seconds. So 10 pulses, and then it automatically cuts off. Once it cuts off, you have to increase the pressure in the balloon to 6 atmospheres. Wait till the therapy button goes off into green color again. Then you can deflate. This is a very important step. Don't go beyond 6. 4 is a therapy where you deliver the therapy at 4, go to 6 after the 10 pulses, wait till the button goes green, then you deflate, then the chances of IVL balloon rupture are very less. Then again, you can move the balloon distally. If you have gone down distally for the prox, and then you come back also, you can do that. The only thing is make sure when this area is there, the overlap has to be 2 mm for effective covering up of the lesion. RBP, as you see here, is 10. Most of the time, this is the difference between this and the other barotrauma-based balloon therapies like the NC balloons and the open NC balloon, ultra-high pressures, where you are absolutely relying on barotrauma. And it is the same barotromic pressure is acting on every part of the artery, including the normal vessel. Here, you don't have to go to higher pressures. It is the sonic waves which are causing the effect, and they can deal with simple pressure here. You can modify the lesion very well. Of course, there are therapies available in the peripheral arteries for transfemoral access. People are trying in any rare scenarios of calcifications as well. This is a setup. We told about the contrast. Connection is easy. Absolutely no air should be there. You've seen the markers there. Inflate 4, activate, deliver. There are 80 pulses in the C2, and the C2 plus has 120 pulses. You can use in the main lesion, probably you can go for 2 cycles of 10 each, and then accordingly use the therapies there. In the rare case you find a bubble, which is macro bubble seen in the contrast, probably you should de-air it in situ and then again do it. Because once an air bubble is there, it makes it ineffective, and many a time the balloon will rupture. The mechanism of action, how it cracks, is by multiple mechanisms. You can see what happens is here, I'll show you. I think I got out of this. Okay, the electrical impulses which come from the generator, they create a sonic wave, a micro bubble, which expands in a rapid compression and decompression wave. It is almost like a 50 atmospheres pressure is generated, and it goes back again, decompression at -5. This is the only therapy which not only expands and causes pressure, but also goes in and sucks in. It is almost like squeezing as well. So fractures, microfractures are rampantly produced both in the axial direction, in the longitudinal direction, and also the change in the compliance of the entire plaque is there. So it's one of the wonderful therapies which is very safe and highly effective. There is also an effect called spallation, where the calcium, the sonic waves are reflected from one end of the calcium to the other wall, opposite wall, and then keep on helping us. So we'll go back. So just to show tremendous calcific, I'll take 1 minute more. Ruptures can be made. Highly calcific vessels, you can see that. You can use a balloon boost here. This was a balloon boost showing the all-round deep calcium, crack, plain balloons rupture multiple times. You can see the IVL balloon. It can make beautiful compliance modifications, and you can get very good results. this case, post-CABG, tremendous, balloons don't cross, finally a 1.5 balloon crosses, and then we can't do any imaging as well. Multi-ruptures of the balloon, IVL does not go. This is the only scenario where you have to use a rota, is a rotatripsy, then again the results will be good. Nodular expansion we have discussed. A lot of issues with nodular lesions, but one should be aware that of the therapies available for an eccentric nodular calcium, still I personally think that this is a wonderful therapy. It is not as good as in non-nodular lesions, agreed, but among nodular calciums or calcific nodules which are non-eruptive, this is a therapy which is probably safe without any reliance on guide wire bias, and the chances of perforation are almost negligible. There are problems with the guide wire bias with rotablation, with orbital atherectomy as well, and if you see the disruptory calcified nodule data, you will be amazed that even in the calcific nodules, the results were as good as in non-calcific nodules. So the number of fractures it has produced in calcific nodules is probably slightly more than in non-calcific nodular lesions. It's a wonderful non-guide wire based, non-contact based, in situ technology which is highly specific for calcium. I had to end with this phenomenal innovation document done by Brett Esur from New York, where in a 6 mm vessel, under expanded stent, as you can see here, calcific nodule, 6 mm, the balloon IVL comes only 4 mm. You can put another NC balloon by the side, 2 mm balloon, you make it 6, and you can direct the therapy there, and they had achieved a good result. This balloon-assisted IVL, where you can increase the size of the IVL for bigger arteries, is a great innovation. Probably, even in a vessel which is only 4 with an eccentric nodule, you can use one IVL balloon of 2.5 or 3, and then another balloon. We're using the guide wire bias, putting the side branch wire into some other vessel so that the IVL balloon is directed toward the nodule, might work better. It opens up several new areas of thoughts. Shock topics can happen, they're inconsequential. Balloon ruptures IVL extremely rare if you avoid air in the balloon. Take home, one of the greatest innovations after rotablator for calcium is IVL, and it's going to stay, and everyone should have an IVL in their lab, especially in the scenario of primary PCIs in the elderly people. Thank you.
That was a very good. So that was a very good talk, and it's really a new innovation that has really changed how we manage calcium by and large, also along with the other therapies. The big thing with this thing is that it has to cross the lesion. The profile of the balloon is much larger, and it's not as flexible as the other devices. And once you are able to cross the lesion, technically the device is very simple to use. And the other thing with the rotablators, orbital and the rotablator as such, one thing I would like to remind everybody is to go slow and kind of daughter the lesions as you go back and forth, because if you push it too quickly, there are instances where it gets stuck in the calcium, and retrieving it is not that easy. Apart from that, I think both these devices are basically meant to change the compliance of the vessel and have a better outcome with your stents.
I think all of us sitting here must have faced this problem of calcium in one time or the other in our labs. I think we left adequate time for discussion. If any of you have any doubts in this regarding this, Ajay is here. We can feel free to talk. Please, can you pass on some mic? Somebody is raising hand, or can you come front, doctor? Please pass on the mic. As such, yeah.
So regarding IVL, in left main lesions, your comments about the ischemia time. Because if you want to crack calcium in left main or ostial LAD, and you have to inflate the balloon for a certain amount of time, the incurrent ischemia and the hemodynamic compromise.
No, see the pulses, once you press it, 10 pulses will come and it will automatically cut off, but you can stop even before as well. You can stop with 3 or 4 pulses as well, and 10 seconds usually it will be easy to modulate. And in especially the lesion which Ajay was showing, calcific lesions, tortuous bends, dense calcium in that area. It's almost impossible to use atherectomy devices. There, this is useful. There are scenarios where the calcium, the LMCA might be even 5 or 6 mm. But as I told, in the initial part, if you use a 4 mm, whatever is available is good enough. It will open up some amount. But the availability of this technique of balloon-assisted tracking, IVL, probably opens up better avenues.
Yeah, the only problem, I mean, that's a reasonable thing to think about. The challenge is the emitters might not be in the right place relative to the calcium. And the other problem is that the emitters, one is this way and the other one's this way. And so if that while technically you could make it a 6, I would say you're just better off using a peripheral balloon than using the coronary balloon in that way. So a lot of times these case reports, they sound better than they actually end up being. And in that case, it worked, which is great, but it doesn't always work that way. As far as the timing goes, the only thing that's a challenge is that once it's inflated, it's much harder to deliver. And so in general, if you can inflate it and deflate it, don't move it. Just leave it where it is instead of taking it back into the guide, because once you take it in the guide, it's much harder to get back into the vessel.
I think generally after the IVL inflation, it cracks, but you need to dilate with optimal NC balloon again. That's what is recommended?
Yeah, I mean, it's just hard, or guide extension, and guide extensions can be very useful for delivery. But that's, I think, you know, Vijay was asking me, have we seen the use of atherectomy go down in our lab after IVL? And in some cases, yes, as the default strategy. Certainly we saw laser for underexpanded go away pretty much. But we actually also see many cases where you need to use atherectomy first. And I would say don't open the IVL in that situation, because for years we've done atherectomy followed by NC balloons. And yes, rotatripsy sounds good and nice, and it may be safer a little bit, but for many years just using an NC balloon after atherectomy worked well. And so I would say don't open it, use your atherectomy, then use the NC, and then if that doesn't work, then go and use the IVL.
If the IVL balloon is expanding more than 70% of its diameter, I think then you need not use any extra NC balloons. Otherwise, you need to use an extra NC balloon as well, which is needed in some cases. Ajay, did you use any S4, the peripheral balloon, in the coronary?
I mean, we haven't had to thus far, but you know, and that's where Akiko's Laplace's law principle applies. Well, if you have a big vessel, like a 5.0 vessel, and you take a 5.0 NC balloon, you have so much force that you're exerting that it typically will crack. So I haven't had to use it in those circumstances. And just as you said, if you have a smaller balloon, you've done the cracking. Once you crack it, it'll expand with something else.
I think where do you place, for the sake of audience, where do you place this OP and high pressure balloon in the entire thing?
So, you know, I have to say it's available in the United States, but unfortunately the price point it doesn't make any sense. So we actually haven't brought it in. Now we kind of have it, but it's not something we typically would use. The one thing that is an interesting topic that we could probably talk about a little bit with IVL is that there may be cases where you can crack the calcium, and if you do so with minimal actual trauma, you may not be able to have to put in a stent afterwards. And so Akiko was with me the other day, and there was a left main LAD with a circ, and the circ had concentric calcification, but there wasn't really like anything else going on. So we cracked it and caused a fracture. It released, and we didn't use a DCB there, but we just left the circ alone and then did provisional into the LAD. We'll see how the patient does, but I think that there's a lot of things to think about in that way.
I think high pressure OP and balloon I was talking. Yeah. Basically, I think the lesions are somewhere in between, like not too deep, it's not getting done with it. That's where I think post-dilatation of stent, again, we have a lot of times used, because if you unknowingly didn't prepare the bed well, and nowadays stents are very trackable. You take the stent and you put it, that doesn't expand later totally optimally. That's where I think OP and balloon has definite role, but you sometimes need very high pressures. The regular indiflators do not work. You need to have that high pressure indiflator which comes with it. Sometimes that is really helpful, especially in after stenting the residual stenosis. That is where OPN also helps a lot. And OPN cost-wise, I think it is much less than IVL in our country.
Yeah, so I mean, we have a strange system. But I think the other thing, too, that it gives hesitancy is that for operators that don't do a lot of cases, to go up to 35, 40 atmospheres causes a lot of, concern.
So what you need to keep is the size has to be under control. You can go high pressure, but don't increase the diameter. Yeah. Suppose the vessel is 3, you feel, you can 2.5 and go to high pressures like 35, 40, but you can't err on to taking the bigger size. That's where the perforation or ruptures happen. So when you are doubt, you can keep it undersized and probably go to high pressures. But sometimes it takes about 40 atmospheres for the vessels to open up and crack, we have seen. But if the size under control, there is no worry of perforation or rupture. And previously we used to face these balloon ruptures of this also. Now they have improved the compliance with, again, 2-layered balloon of OPN. So the less ruptures are less common. That way also there is some advancement in that also. Any other doubts? Anyone?
No, and the other thing, we didn't talk much about scoring and cutting balloons and those devices, but you know, there's actually a randomized trial that we're doing in the US that's an imaging guided endpoint, cutting balloon versus IVL. And you know, because the problem right now is there's no comparative data. So everybody seems to think that certain things may be better or worse, but we don't know. So this is an image-guided trial, and there's an arm of atherectomy, there's an arm of non-atherectomy, and so we're enrolling kind of briskly in that trial. And you know, Akiko's been going to all these sites and showing them how to use the imaging to dictate what you do. And many times, but in that case too, if you're going to use a cutting balloon, you don't go 1-to-1. You downsize at 0.5, and then you go up to 18 to 20 atmospheres, not just 14 atmospheres. And, you know, we'll see what the results are of that strategy.
Akiko, madam, do you want to comment on that selection of through imaging? Can you pass on the mic?
Can we give a...
Can you pass on the mic to madam?
He's running over.
He's coming.
I'm sorry, what is your question?
Question is, what have you seen with cutting and scoring balloons?
Oh, okay. I think the cutting balloon or scoring balloon is something good for kind of moderate calcium. Meaning like the non-compliant balloon doesn't work, but cutting balloon may work. And I see more fracture using cutting balloon just compared to the non-compliant, because there is a blade. If that is more than 3.5 for blade, I see multiple fracture. And if you have multiple fracture, actually you have good like circumferential good stent expansion. So I think there is some place cutting balloon, scoring balloon work best rather than other non-compliant.
Yeah, the slide that you showed in your talk, which is sort of what the thickness needed to affect a fracture with various technologies, is a pretty interesting slide where the NC will do it at certain levels, then there's cutting and scoring, and then after that atherectomy or IVL. That's a pretty useful slide to think about.
I think osteal lesions also, the cutting balloons have some advantage over other things. I think they're supposed to be opening a circular these things and without dissection.
We have a hand over here, microphone to over there.
Please pass on.
Thank you, sir. My question is to Akiko, madam, about the stent fracture. This is related if the stent is fractured and below that there is a hematoma and it's a long-standing case. There is a calcium deposit. How do we treat that thing?
That's a tough one. So the question was, if you have a stent fracture with a calcified nodule and a potentially hematoma, how do you treat stent fractures in general? Probably that's the best.
Yeah,
one.
that's the best.
Can we get the microphone back to?
Yeah, ma'am.
I like calling her Akiko Madam. I call her Akiko Sensei, but Akiko Madam is good too.
By the way, I think this is very important. The predictor of the calcium fracture and predictor of the stent fracture is actually quite similar. Always happen at the hinge motion. So actually they can be together. But many times we couldn't diagnose of the stent fracture on top of the calcified nodule because everything is shadowing by calcified nodule. And in such, if you have the hematoma, actually, I don't think it's a big difference because if the hematoma and if you have the entry site, anyway you have to cover. So really doesn't change any treatment strategy, I think.
The idea why they asked is if the hematoma already, there's a worry that it could rupture.
Yeah, that's
so that's why they are asking.
Perforation can happen.
Perforation can happen. How to tackle that? That was the doubt they had.
Thank you, ma'am.
Any further questions?
One more small point is whenever you're using these calcium, dense calciums, use the pressure in the balloon, NC balloon, for a quite longer time than usual. Don't do for a short 20-second, 30-second. The spallation effect, like in the IVL, for this, the creep phenomenon happens only when you hold it for a long time. In fact, the reason why cutting and Wolverine's work is because the creep will allow that to crack. So you keep the balloon inflated for quite some time, it just gives way.
Acha, any further questions or comments? Otherwise, we'll break for coffee, and then we need to assemble back for two important live cases coming up. One is the impeller-guided calcific, similarly what we've discussed is shown by Miroslav Ferenc from Germany, and then in the end you will have Atizani performing a self-expanding valve TAVI case. So the other hall also closes at 3:34, and they'll all join back here for the international live cases. Thank you all, and have a quick coffee and come back by 4 o'clock in the hall. Request all to be here by 5 to 4 because interesting live case, we should all get benefited by it. Thank you.
Together is the start. Staying together is progress.
Others, Dr. Aman Salwan, Dr. Manoj Agarwal, Dr. Gokul Reddy, Dr. Jagdish Babu. Who is here? Please join back. It is an interesting chip case. I think Aman, Dr. Aman and Gokul and Manoj Agarwal, please join as a panel. Thank you. I think they are just about to ready. You can start some discussion and then in 2 minutes we'll connect them.
Oh, so they said they're ready in 2 minutes, they said? Thanks. That's great. So maybe we can start, I guess, in discussion. This sounds like it's a case with hemodynamic support. So what the landscape of support here in India right now, what percentage of cases is being used? Is it available? I mean, it's obviously super expensive. So what are the options most people have?
So expensive in our settings at least.
So, and how about like things like ECMO and IABP?
ECMO, we do have IABP, it's in regular use.
And those are much.
The Impella also, they are giving approvals for two set types of cases. One is elective way, other is in shock type of situations. All the hospitals, first they get into approval for the elective Impellas, then they go proceed further. Then we are allowed to use in acute MI shock scenarios also. I think now it is almost about to get established very well. Now they internationally took over, and locally also there is some change happened. I think Sanjog will demonstrate those step-by-step deep dive session tomorrow. They agreed to put their product and will help us to learn more about it tomorrow. I think if you are ready, can you correct it live? We understand that some chip type of cases could get into some minor issues, which are, I think I was told that it's tackled now. And is it ready? Can you connect them? Yeah. I think Farang, this is Dr. Srinivas Kumar here. Hello, can you hear us? We can see you
hi.
now. We can see and hear you. I initially briefed, there's no problem. Here we have Ajay Ketane.
Very good afternoon.
Yeah, Ajay,
Very good
Sanjog and others
afternoon.
are there. They will interact with you. Over to you, Ajay.
Yeah, dear friends, thank you for the invitation. We are really very honored to be live case center. And together with my colleague, Dr. Rahimi, Dr. Lufenhardt, we have Dr. Schmidt from ICU, and we have here Sandra and Susie as technical nurse staff. We are very happy to present you TAV case. We have here a small slides introduction. I think, can we go to slides? You can comment. Go back to the first, yeah. Can you see the slides?
We can. And good to see
Yeah,
you.
okay.
Although I always look
Yeah,
forward
hi.
to seeing you in person here. So on the screen is, it's great to see you doing a case, but we miss you in person.
Yeah. Next time. Okay, go ahead, Dr. Raimi.
Thank you very much. Also a warm welcome from my side. I would like to represent you our case. It's about an 86 years old woman without any severe pre-existing conditions. She is a former smoker and is complaining dyspnea regarded to physical activity since a couple of months, and she has also some edema in the peripheral. Next slide, please. Yeah, the echo showed us severely reduced LV function with an ejection fraction of about 15% and hyperkinesia of the anterior wall. And we decided to do an angiography, but first I would also like to mention one really important point. The CT angio we did after the coronary angio, it showed us moderate lesions of the inguinal vessels on both sides. Next slide, please. So I would like to represent you the coronary angiography. Here you can see the right coronary without any severe stenosis. Next slide, please. After that, on the left side, you can recognize severe calcified stenosis of the circumflex and also of the marginal branch. So we have got here slightly bifurcation stenosis. And on the right side, you can see the LAD, also with the severe calcified stenosis of the bifurcation. But to be on the secured side, we did also a hemodynamic measurement. Next slide, please. And here you can see the values. We had for the circumflex clearly pathological value was 0.85, and the LAD showed us on both branches pathological values. So we have to do both of that. Next slide, please. So what is our PCI strategy we had? Because of the low ejection fraction, because of the complexity of this intervention calcified lesion, and intention to do an rotablation, we decided for a protected PCI. So our first step would be the placement of the impeller CP. After that, we would like to go for the rotational atherectomy of the LAD with the burr 1.75. And if needed, we would go afterwards for an IVL2, but we would also try to decide that after an OCT evaluation. So imaging will be done by OCT. And after that, we would like to do the first bifurcation. This would be the LAD and the diagonal branch. Primary, we would do one stent. We would like to do a one stent treatment. And if necessary, we would go for a two stent strategy. And after that bifurcation, we wanted also to do the bifurcation of the L6, but here also just provisional stenting.
Yeah.
And after that, final imaging with OCT, and if possible, a weaning and replacement of the impeller.
It makes sense. A couple things of interest is that the degree of the cardiomyopathy with an EF of 15% seems a little out of proportion to the coronary disease. I mean, I think it's obviously a complicated case, but when you initially showed that, I was imagining CTOs and just horrible disease, and it doesn't look that bad. So is there something about the clinical picture that suggests a change in or an acuity portion of it recently with this new anterior hypokinesis, or is it just she's presenting de novo?
Yeah, we believe that's a combination, probably as you mentioned, myocardial problem and additional on top coronary problems. Yeah. So we, to be honest, why we are a bit late, we had angioplasty and we had diameter vessel in inguinal area. We had 5.3 millimeter, and it looks from angioplasty quite nice, but finally you can see it was definitely not possible to go through the iliac artery. You see a lot of calcium. That's not only in coronaries, everywhere we have here a lot of calcified plaques. And finally, we use it here. Our colleague from angiology department was helping us to use here finally 8.0 balloon with around 10 atmospheres. And then finally, next step, we could manage this curve, one more ballooning, and then finally we could go through the groin and through the iliac artery to the aorta. So the next step was quite easy. You see the crossing through the valve was quite easy. There was no aortic stenosis. This was clear from echo. And so the position is now good. We have support now 3.2 liter, and the pressure is not perfect. So our colleagues from ICU give us support as well by catecholamines. But this is, I think, at the moment, low dose support. So our
No, I was just going to say that the choice of the word support comes in. There's many ways of doing support. There's the hemodynamics, there's managing the vasculature, there's managing the sedation and everything else. And so for these patients to truly, get through these tough cases, you need kind of multiple levels of it. I personally don't like the term protected PCI because I think that it protects those people that really need it, but then other people, you're exposing them to vascular complications and bleeding risks. But the way you've managed it makes a lot of sense. There are other people who would use IVL of that iliac. It tends to probably be a little bit safer than a balloon, but this is a great way of proceeding. And one thing you don't want to do is you don't want to stent the iliac and then take the impella through that because a cage can get caught on it or otherwise. So this was well done.
Do you have any right heart cath numbers for us? I see you have a Swan-Ganz catheter up.
Yeah,
but
we
how,
have
how
it.
did you use the hemodynamics to make the decision of what type of support to choose and why?
This is very helpful. This is very helpful to make the right decision at the end. Can we go out with support, or should we continue support to the ICU? But we just check the pressure before, check the pressure, pulmonary pressure and diastolic pressure during the procedure. And we started now, I think, with LV-EDP was around 12, right? So patient is now in stable condition and compensated. So that's a good sign.
That's a good sign. I think one thing
we go now.
Keep going. Sorry.
Yeah.
Sorry.
Yeah. What we have to be a bit faster because we have just probably 1 hour slide. So I wanted to go direct with rotawire drive, but it was not really nicely working. That's why I use it now, a simple wire, floppy wire to bring micro catheter down. And we go now. It was difficult to cross even with a micro. It was fine cross. That's why we go now with rota drive and start direct rotablation. The question is, would you start with 1.75 or 1.5? That's a question.
Yeah, I mean, my preference with this angulation is to typically start with a 1.5, and
I think you may need bigger eventually, but I'd probably start with a 1.5 here because you're going to end up making yourself some room. Either way, you're going to have to address that bifurcation with a secondary balloon. Miroslav, I don't see your hemodynamics up. We don't see a pressure trace. We see what looks like the end of a pressure trace, but it's either zeroing or zeroed or not transmitting. I can't see a waveform.
So we have now pressure around 64, so the pressure is really not good.
Yeah.
Impeller give us support, so patient is fine. Oxygen.
I see that you've also got a lot of ventricular stuff going on. It's sort of runs at 4 or 5 beats. Is that the device too deep or
1.5?
No, we checked this by.
Looked good, but
by pigtail, but
sort of statistically the most
maybe
common
I'm
reason
just
for
going
these
a
runs.
bit. Yeah, that's a good point. Yeah, I think the position is, as you can see here,
looks a
I
bit
think
deep.
position is maybe a bit back.
And with the CP, when you turn it on and it sort
It
of
always
ramps
goes
and then goes in a little bit. So you have to be cautious with that. And the second thing that can happen, less so with the left, is you can get interaction of the guide with the device as well. So you have to be cognizant of that position. Because sometimes, honestly, with the VT, with a bad EF, or not even just ectopy, you can get the patient decompensating because of the ectopy. But that's why that right heart cath in the beginning is very helpful, because if the patient's compensated and then you turn it up, you're going to suck the LV dry. And so if the patient gets hypotensive, you might actually, in some cases, either need to give fluids or turn the flow rate down.
Yeah. I think on that note, I mean, we worked on an algorithm here, right, in India a few years ago that's in Asia Intervention now, that is a little bit more conservative than the algorithm that they use, I think, in the US when they make decisions on whom to implant and whom not. And hemodynamics are a critical component of that algorithm, and that was done intentionally so that people would actually get that information and learn to use it both up front as well as part of the weaning paradigm. We lost the case here. Can you bring that up on the monitor up front, please?
Can you maybe show the...
There we go. We have the pressure trace as well now. Let's go.
Mathieu, could you go to the table to show the rotablator?
Can you change the monitors? Can I see the case on the monitors? Right now I'm seeing slides.
I just see, we just see live case 3, just the program slide.
Mathieu, you can...
Yeah, so we see...
We can see you on the main screen, Miroslav.
Okay. So you see here our system, RotaPro system, which we have here in Germany, and put it here and make a test. So we test we go to 175. So we usually rotablate here with 175, a bit less, okay. And now Dinah, first Dinah.
So what you're seeing for the audience in real time is what Sanjog just demonstrated in the last session. So Miroslav, we just had a Rota demonstration literally like an hour ago. So this is perfect. Really nice to show it again.
So we go now with Dynaglide, and there is, you see, it's very smooth movement. And we check the wire in position, wire's perfect in position. And so, stop.
So see,
And,
single
what
operator,
I
nothing moved, everything was good. One caveat
exactly.
with that, though, is when you go into the TUI, you need to make sure that the wire loop is expanding. I actually had a case 2 weeks ago where that didn't happen because the brake was not fully defeated, and I ended up with a huge loop in the aorta. Luckily, I recognized it, but I had to restart again. So as long as the loop is expanding, you can just advance it all the way up, and now he's platforming and getting everything ready.
So we have already ACT over 250. We have now a pressure which is now around 120 to 80. There is heart rate is around 80, so we can start to rotablate. And if there will be some bradycardia, then we give on top atropine. So we don't have at the moment pacemaker.
And you should probably be okay because the right is big and it's open, so.
So short runs around 5 to 10 seconds, not longer, and give some time. We can check the flow. We have 7 French, EBU 3.5.
But I also like the guide position because, I mean, right now you've left it kind of disengaged, but that's good because the hemodynamics are not favorable. If you need it, you can put it in later. But these techniques are really important because even with support in the decompensated patients, you need to short runs, get the guide out, and let the patient breathe.
We discussed this concept of hemodynamic load, right? So every one of these cases has a hemodynamic load associated with it. How many balloons you put up, how long you hold them up, how long you do atherectomy, whether your guides are engaged for extended periods. If you're doing a CTO, is your retrograde guide disengaged for a period? Are you able to hemodynamically optimize them before the case? All these things that we can do to reduce hemodynamic load, I think, can inherently make the procedure safer. You know, with disengagement of the guide when you're not using it being one of them to prevent that aortoosteal stenosis that you introduced.
So you see, we tried a few times very gently. There was initially clear resistance, but finally with a packing technique, forward, backwards, so we could manage this this part quite nice. We go back again with glide assist, so you can see how we are doing this. Normally I'm a single operator. You just press and go back. And you see the wires perfect in position.
Stop.
Okay, I have it.
Stop.
Okay. So we would like to go now with OCT and wire diagonal branch.
I think that sounds great.
So maybe just to show how it looks, flow is okay.
And then you're going to swap that rotowire out for a workhorse, or are you going to work over the rotowire?
No, we just remove. We place standard extra support floppy wires. So you become a run through, Samurai and Grand Slam. I think we need here definitely good support, good backup. We wire now the diagonal branch, which is not so small and should be kept open, definitely.
Do you have the wiggle wire there? Is that something you have access to?
No, we don't.
No, we don't have it.
It's a very old anchor wire for the audience here with an exposed coil tip that sort of bends and undulates. It was made by Abbott many years ago. It has the body of basically a Grand Slam, but with an exposed coil tip that grabs the outside of the vessel where it is in the distal vessel and provides a beautiful anchor for just cases like these.
Yeah, okay.
But not one that you would typically use as a primary wire, right? You'd have to swap that out.
We go to epicranial position, try to get now wiring of the diagonal branch, and then put Grand Slam to. There's a quite large angle,
It's
application
a
angle. to
large
the
angle. It's a
diagonal
large
right.
diag that's very important to the patient. So
Yeah. Definitely.
I think
Okay, now Grand Slam.
that's the type
Grand
of
Slam
diag
is
that if it were to shut down, the patient might get very sick.
Was it? Okay, so we take now Grand Slam, and then if Grand Slam will be nice in position, then we remove rotor wire from the LED. And I think I wouldn't go with, let's see here. Kannst du das nass machen? Make it wet.
So there's some people who, what they'll do if they think they may need to upsize the burr, is they'll wire with a second workhorse wire and leave the rotor wire down, do some ballooning, do some imaging, and then if they need to, then they can go up with another burr. But in this case, you have to keep moving efficiently. You wired the diag already, so you're probably not going to rotor this LED again unless the OCT really looks terrible. So for this case, I think the way that you're doing it's right.
Exactly. I think in next step, if we need more debulking, more sufficient lesion preparation, I would go in majority of cases with IVL. So we have now at least for sure 1.5 channel talking.
Yeah.
And then we could go easy with
NC balloons and whatever.
Orbital, NC balloon and shockwave if needed. So I'm just trying to catch a good lumen.
And that's the Grand Slam?
That's
Grand Slam. If we have problems, then we remove, prepare micro, and then we. Okay, that's some problem. I don't like to.
No, it's very hard to wire primarily with the Grand Slam.
Yeah, it's not.
So
coated
we go
at the
now
tip,
with
right? So
micro
you feel everything.
over rotor wire and exchange to Grand Slam. I think it makes sense. Normally it's going. We know there's this patient is old, so we have to manage this problem by interventional cardiology. There is no option to go with surgery. I think this is what we discussed already here in heart team decision. Just to.
Speaking of that decision, so when you set this case up, do you get anesthesia involved early? Is the patient awake, or is the patient intubated?
Is awake. This is just simple sedation now. I think with now at the moment we have propofol, right? Okay, Dextor, and patient is now sleeping. So very nice condition. So we have in background ICU team. Taking care
Grand
for the
Slam hast du schon
patient.
rein, oder?
Grand Slam.
I ask because if you look at your aortic tracing, every fourth beat, your aortic amplitude drops, right? So that's probably when the patient's breathing in. And it's either severe LV dysfunction or more likely some degree of vasodilation from your sedation and less flow, right? And as an interventionalist doing this type of a case, which is a complex case where your head's going to be all about trying to rebuild the arteries, it's nice to have the help of your ICU physician or an anesthesiologist to manage the sedation and manage the hemodynamics around that, such that you're not getting stuck with suctional arms and such.
Absolutely. So we have to treat here very sick patients who are really sick in poor conditions. So that makes sense to have here good backup.
We're learning more and more that these are about team-based care models.
Exactly. So we just trap the micro, 18. Okay, so fine cross is now outside. So now we can go with imaging, negative. Okay. So, okay, so I think we have here Dr. Löffelhardt, who is in background now giving us support for imaging. So that's OCT. Creatinine is still okay, so we can do this. We can do one shot with contrast, one shot with saline, maybe one to compare how with the quality. You had today morning very nice session according imaging modalities.
That's right, and actually, and Akiko is on the panel as well,
Yes.
so it's great.
Yeah, fantastic lectures. Thank you. So we can cross. There's some resistance.
Nice.
Okay, but now we could cross. Fine. Okay. So did you flash here?
I already flashed.
Okay.
Du musst es. Ich hatte schon gespült, ja.
Did you flash? So it's take a look, and Akiko is in the panel.
She is.
Yep, she's right here.
Oh, great! She can make a comment.
I'm ready.
She's
Oh,
ready.
fine. Okay, so you start. Can we? Jetzt, ja? Maybe we were too deep, probably. Yeah, we were too distally. So distally, the vessel looks not so bad.
At least you know there's a long normal zone beyond your diagonal branch.
Yeah, yeah, okay, we have to.
We don't see the
Yeah,
lesion.
we were too
This
deep.
guy was super nice,
Okay.
normal.
So we go now.
That's a good place.
Yeah. We go a bit back and welche Länge hast du? Welchen Segment? 54?
Oh, jetzt ist er gut.
Probably now it's good. Okay, once more. So we are now in proximal part of the vessel. Can we go? Yeah, okay, flash. You tell me if I'm ready.
Yeah, that's nice.
Now it's better.
So starting the mid segment, that chat artifact, that's
Yes.
the calcium, and that's a nice rotability effect. Yeah, that's quick. Okay, so that's a very proximal left domain. It's clean. Go back to the region, and that just distal to the region. Coming back, that's calcium. It's not too bad. It's only 180. That's a place you see the 3 o'clock. That's a nice rotability effect, but that's dissection. And then coming
Ja.
more,
Du kannst uns mein Mikrofon.
yeah, just like the eccentric calcium.
But this is critical part here.
Yeah,
that,
so-
what do you believe? Are we here sufficiently prepared? Probably we need now. We have some.
Yeah, that's a
cracks
place.
and
Okay,
dissections.
okay. Yeah. So go back to a little bit distally. Come back.
Go to distal.
Distally. Here. Yeah, too quick.
Schau,
So
dann
go back
können
to
Sie,
the proximity.
Deine Kopfhörer ihm geben.
This is like
wenn Sie
3
im
or
Kopf
better,
haben.
media to media. Come back. It's only eccentric plaque. Come back more proximally.
Yeah, just Akiko, wait a second. We give the micro to Dr. Liffelhardt. So Nico, can you hear?
Oh, no, I don't hear anything.
So now, Akiko?
Yeah, yeah. So this is a distal segment. Its vessel size almost media to media is 3O and only eccentric calcium. Go back. That's still eccentric calcium. That's a place. Yeah, you see the calcium. This is just flap. I see very eccentric calcium here. That's perfect. Perfect. Here. You see, like the 3 o'clock, 6 o'clock. That's nice, polished by low tabulator. You see the very nice round shape. That's really the low tabulator polishing the surface. It seems to be protruding calcium. Probably this is non-eruptive calcified nodule, which you polish on the surface. But I do think the overall calcium was actually not too bad. This portion was only, I see the nice low tabulator effect. So I think the next step is just balloon, I guess.
NC balloon, yep.
Yep. Can we have a diameter distally, Nico? What is, I think it's around 2.5, 3.0?
Akiko thought it was media to media more like 3, but
yeah,
it's pretty.
I would suggest to take 3.0, quantum 320.
Yeah, because that's the lumen right
yeah,
there.
that's a lumen.
Mathieu, could you make OCT bigger as the first choice on the screen?
Yeah, that is much better to see.
Yeah,
Oh,
thank you.
Okay, I see much better. Yeah, I think close to 3.
Thanks.
So that's a lumen measurement. And lumen's area is 7.2. The lumen diameter means 3, so at least the vessel size should be larger. So if you use a lumen measurement to decide the balloon size, we are upgrading quarter size at least. So I think 3 non-compliant seems to be appropriate.
So we have already 3.0. So Farah is just going up to 12 atmospheres. This is now, I think, sufficient.
Yeah, it looks expanding nicely.
Opening. Negative. So I let balloon in position and make some gently test. Yeah. So maybe here again, so 8. Negative. Guiding is too deep. So I think we go again with OCT and check this by OCT, and probably hopefully it's fine. Then we can go ahead with the stenting.
What about the diag? Are you going to do the OCT for the diag, or?
Do you plan on imaging the diag?
We want to stop with proximal stenting. We will stop at the diagonal branch, at the septal branch. There's a septal branch, and I think we shouldn't go over septal branch. We can make now one more projection. I think it looks now much better. And the diagonal branch is still open, and I would stop. Maybe you can, Nico, can you show me on imaging that the lumen or by septal branch?
That's a septal on the 12 o'clock. I see the diag is actually 9 o'clock, which is super clean. That's one. That looks like the diag. Ostium of the diag is super clean, so it looks okay.
Which is great.
Simple provisional stent, hopefully.
I think in this case, we initially believed maybe double stenting will be good, but imagine this lady has a really poor LV function, and we know double stenting or LV function in general is a predictor for stent thrombosis.
Absolutely.
Particularly if you have 2 stents solutions. So we try to make it simple. I think that's a really provisional approach now. Only if needed, then we can convert to Dickey culotte or to TAP. I think this is, I hope you agree with this.
We all totally agree with you. And just for the audience, in terms of the OCT measurements that you're seeing, this is all lumen-based. And remember, you can do it 2 ways. You can do it lumen-based, or you can do it vessel-based. If you're going to do it vessel-based, media to media, that's more akin to IVUS. If you're going to do it this way, you have to then go up a size in terms of everything you do. If you don't, you're going to grossly undersize your stents.
Versus going down a size if you're doing it the IVUS way.
So the point is we have 2 options. We can start with 3.0, stand distally, and take then 4.0 to the proximal part, have some overlap, or we can go just with Onyx 3.0. 3.0 can go easily over 4.0 for this proximal parts.
That's exactly
right. I think this will be the best option. How long is the lesion from the septum to the healthy. I think I would go here with around 34. Do we have here onyx 3-0? 34. Okay, so we take onyx, and this is diameter according to the distal part, and of course, we could learn from Akiko's lecture today. In LAD will be approximately, of course, much larger from diameter, but we have now chosen a stent which, with a good radial forces, with a good access to the side branch, and we can postulate up to 4.5. Thank you. So we go now on the grand slam to the distal, to the LAD. There is still diagonal branch wired by a floppy wire, and for safety, this makes sense.
Makes a lot of sense.
The wire.
Indeed.
So I'm going now with a stand, which can cross very easy.
I mean, that's the difference between, atherectomy and not atherectomy. Is it
Exactly,
it
exactly.
goes.
Even if you have some tortuous vessels, it makes huge difference. So I would go now here. We start here. So we have around 8 millimeters to make final pot. Okay, 2, 4, 6, but very gently, stepwise. 2, 4, 6. So we don't crush immediately. The vessel wall, we stretch very gently. 6, 8, and 10. That's fine. I think stand opened quite nice. Of course, we have now negative malapposition proximally, but we will cover this with NC balloon. Okay, can we have now 8 millimeters 4.0 first? So we go now with a short NC balloon, 8 millimeters 4.0 to achieve hopefully sufficient pot maneuver. And then we will also go to the distal part to make distal optimization, dot and pot. Then finally,
No, I think that
finally, yeah.
So
I
this
think
is the sizing is perfect because
Sizing
this is 30 millimeter, and you remember distal was 3, and he chose the proximal is 4. That's perfect. It's 1 millimeter taper, and because of the big diagonal septal.
Yep. So, and then Miroslav, so time-wise, we have, I think, about 5 minutes left. So maybe the pot.
I see the pot, and then a and then another OCT run after we're done to check the...
Okay, yeah, sorry, it was really tough to place impeller, but, safety first.
And we can always come back,
Of course,
to your final,
this will be great. So sometimes we also use here this clear stand or stand boost option, 468. This is sometimes very, very helpful. You can see that's perfect position.
Very nice.
12, 14, 16, 1, 6. Okay, negative. So just safety check, but the flow should be fine. Yeah. Okay, so we go back and go now with OCT, and then we continue to work here, and later we just maybe have option to show you final result.
That's perfect.
Perfect location of that post-tilt balloon too, right? With the distal edge of the balloon right at the level of the bifurcation, so you get some of the strut bowing towards the diag in case it becomes an issue. It becomes easy to cross into. Optimizes the side cell size.
Okay, so we go now with OCT. And can we have BGA and ACT again? So we check ACT one more time. Yeah, between there was some drop with pressure, but finally we have now stable patient on the table. We can do our good interventional job.
And I think because this has been efficient, moving smoothly, et cetera, and the support is in, it makes sense to treat the circumflex in the same setting.
Yeah.
Yes.
Yes.
Many times, though, there's been this push to do everything at the same time. You really have to just know how much insult the patient has taken,
Exactly.
how long it's been, especially given her age. But this is moving very smoothly.
How do you measure that, Miroslava? How do you measure that? Anybody
It's a
on the panel?
feeling. It's kind of the more restless
That's
the
a
patient
feeling.
gets.
That's yes.
So one of the things
think-
that we worked on with Barbara Bashir was, especially on these Impella-associated PCIs, is the number of loss of pulsatility episodes.
Yeah, that's
so the more loss of pulsatility episodes you get, the longer you are likely to stay in the ICU. Where any more than 3, you dramatically increase the number of days in ICU, and your 30-day outcomes get worse. But what I have found is that the longer you end up doing the procedure, the more of a SIRS response they get.
Yeah.
So you start getting a rising PA saturation, and you end up with this weird bimodal shock picture where the heart's stunned, and so it can't augment contraction to deal with vasodilation,
get
and at the same time
vasoplegic
you're
too, yeah.
vasoplegic. So that's a sign to stop.
So the OCT show distal edge looks fine. And this is going to be, okay, distal edge we just, there is some haziness by angio, but there is some calcium. Stent expansion looks nice, and we don't see the proximal edge. But overall, for now, looks okay. Distal edge, okay, so that's a super distal. This is chat artifact, this is just artifact. This is artifact 9 o'clock, this is not dissection, this is artifact. Coming back more, still this is a lot of chat artifact. But I don't see any dissection yet. Coming back, that's really edge. So edge looks fine, and landed okay place, and then that's all.
But I think we have, do we see a sufficiently a proximal part of the stent?
No, we didn't.
No, we don't see. Yeah, so we have
don't
to
see it.
repeat this. We're just back, and can we start again? One more? Just a second, then we will be at least with the imaging ready. Okay, start.
Moment.
Just a second, we just load again. Okay. I can go now.
Wow.
Okay.
Now it's much better.
Looks nicely
Looks
apart.
very nice.
Yeah.
Lovely nice.
So I think there is not huge malapposition.
No, not at all. And
under
that's a
expansion.
nodule which
The
we
nodule
just
got
passed.
pushed aside.
And that's a diag. And proximal portion, that's port segment. And no edge
Yeah,
dissection.
looks great.
Looks good.
Beautiful, you're done there.
I think we see the diag segment here.
Oh.
That's the left main come back. That's proximal already. Go distally. Go. That's a proximal. Go. That's a proximal edge. Nothing.
Oh,
That's
that
a
looks
velar
nice.
pause. Go. And you see the diag soon. Go. That's
There.
the diag.
And it's
in the
wide open.
12 o'clock. 2 o'clock. It's good. And that's distal. I think you may want to dilate a little bit more distal. That segment, which nodule segment, which you didn't post dilatation yet. But overall, it's good.
Yeah, we will do this now as
Yeah.
next step, post-dilatation distally, and probably gentle kissing with a huge diagonal branch, and then we go to circ.
I personally wouldn't kiss. I think it looks, it's open by OCT.
Yeah.
The flow looks
Timmy
fine.
flow.
I would probably leave it.
And there's potential jeopardy for injury to that diag.
You're right.
Especially when there's no
and
disease on the...
And you deform the LED stent.
Yeah,
So-
there's no disease. You have stand to deform the stent. And if you end up bailing to the 2 stent, as you pointed out, there's jeopardy in that.
Yeah. But
that's correct.
You keep working. This is an amazing demonstration,
It's a really nice
especially
case.
right after this demo from last session. Great work, and we'll come back to you to see your final result. We're going to move on to the
Okay.
next case, and we're going to switch the panel as well.
Matthias, change the plane. Okay, so see you later. We
Take
just
care. Thank
continue
you.
to work.
Great
Nice
work.
case.
Ja, thank you. See you later. Okay, dann Quantum 3020 nochmal, frisch, oder Akkuforce. Akkuforce 3020.
Can you, Brian? Can you push me? Push my thing here. My goggles are kind of falling down. Can you?
I think after that interesting chip case, now we'll go into interesting other
That's good.
TAVR case
Thank you.
from
Perfect.
Cleveland University.
Thanks, Brian.
I think Dr. Artizani
Awesome.
is
Nice
ready
job.
to go live. Request Sushil and Rat sir and Juan Granada to come over.
By the way, Brian,
Other panelists.
markets not doing well. This week was inflamed.
My other colleague, Dr.
Say the least.
Doctors who are joined here are Dr. Anup Agarwal, please join, Dr. Anand Rao,
Say the least.
Harish Mehta, Srinivas Prasad, Brijesh, Dr. Brijesh Kumar I saw, Nagendra Bhupati and Neeraj Lagani. Whoever is here, please come onto the podium. And we'll go for the live case with self-expanding valve from Cleveland University, USA. Can you connect there?
Hey, hi, Guy, can you hear us?
Yes, we can hear you, Sushil.
Hi, how are you doing?
Doing good, doing good. How are you guys there?
Good. Yeah, very excited to have you with us.
Thank you, Artizani sir. We are here. I'm Dr. Srinivas Kumar. Your hall is full to watch your live case. And please go ahead and introduce the case. And Sushil, Juan, and Rat sir will follow up with you. Thank you.
I can hear Sushil very well. I cannot hear the other person that is speaking there very well.
I'm just talking much louder than them, and they're staying quiet.
Oh, okay. All right. Are we ready to present our case?
Yes, please, go right ahead.
Thank you. So thank you for the opportunity to be at TCT India. All of our friends from India. It's really a pleasure for our University Hospital to be once again doing another live case. I'd like to introduce the team. I'm here working with our cardiac surgeon, Dr. Rushing. Gregory Rushing is my partner here. We have Philippe Tayeb, our fellow from Israel. We have Katie, we have Nick here, we have Brian as well, the whole Medtronic team supporting the case as well as the camera crew. We have Pedro Teixeira, who is our fellow from Brazil, that's going to present the live case of Evolut FX Plus that we're going to do today. Pedro, with you.
Good afternoon, India. We come here today from Cleveland, Ohio, to present this case of FX Plus. It's a male, 77 years old, obese, COPD, hypertension, AFib, renal disease. The NIH, it was 2 on 5, and he has an aortic stenosis with a stroke volume of 48 in STS 4.3. His creatinine is 1.9, so clearance is 34. AFib on his AKG, you can see the curves from aortic stenosis with gradient median of 25 and a TT echo and 27 the ATT. He has some coronary disease, and the left main shows 40 to 50% on left main, and we did an IVUS, and it shows a mini linear of 9. His axis, we can see a narrow aneurysm on the right side, and so we're going to use as main axis on the left. His perimeter is 7.8, so it fits a 29 FX plus valve. The angle of coronary is a little bit higher, but the sinus shows 30 millimeters of length, and the SGA 32. The coronaries are high, 15 and 19, and we're using angles of 14 and 9 here.
So I'd like to interrupt Pedro. Thank you, Pedro, for presenting the case. So as Pedro presented, this case is, this patient has a very favorable anatomy for an Evolut FX plus 29. He doesn't have a lot of calcium. It's well distributed amongst the leaflets, although we predilate most of our valves here. As you guys, as we talked before in many conferences there in India, we tend to predilate around 70% of our valves, but in this case, we don't believe it's necessary to do so because it's a very well distributed calcium. I wanted to highlight one aspect that Pedro showed there, that the coronaries, the takeoff of the coronaries is 150 degrees apart, and we're going to use today the latest iteration of Evolut FX, which is the Evolut FX Plus, that has bigger windows in front of the coronary ostium. These windows are located 120 degrees apart of each other, which the goal of this is obviously to facilitate the access to the coronary. So this is the same valve, the same delivery system of Evolut FX with a plus, which is the bigger windows in front of the coronary ostium that are located, 120 degrees apart. Next slide. As you can see there, but in green, you can see the windows highlighted there. So it's 4 times bigger than
Can we see the slides?
the windows of Evolute FX.
We don't see the slides. We don't see the slides right now. Oh, there we go. Now we got it.
You see, go back, please. Go back to the... So can you see that slide, Sushil?
Yeah, now we see it. Yep.
Okay, so those are the windows in green, the bigger windows that are located in front of the coronary artery, with the goal, of course, of facilitating the access to the coronaries. Next. And for the first time, I'm going to share TCT Index, sharing the first time this paper that we're working on now. As you know, we published the cannulate TAVI on jack intervention some months ago, which showed that we were able to cannulate all of the coronaries that we attempted in consecutive patients with Evolute FX. And compared with Evolute FX now, the FX Plus, we were able to cannulate the right coronary artery quicker. So the time for cannulation was reduced with this device. Next. Although there was no difference in terms of selective cannulation, but reduced time for cannulation is a very important piece of the puzzle here. And even more so because not all of the interventionists that are going to do the cannulations are very experienced in doing this. So I think it makes it much more universal and reproducible, the cannulation of the coronaries. Next. Next. So I have just a quick example of a prior case that we have done with a CT post-TAVI. You can see that the coronary is actually 140 degrees apart. Next. But you can see the right coronary coming on that 3D picture. You can see the right coronary coming off of just of that big window. Next. And you can see also the left coronary coming from the bottom of the big window, which means that despite the coronaries are not 120 degrees apart, because the windows are so big, we have wiggle room to then have the ability to cannulate the coronaries and having them, coming off of the big window. I think that's our last slide. All right, so we're gonna move to the case here.
Can we ask a couple quick questions before we start?
Of course. Yes.
So one aspect of this is, besides the Evolute FX Plus, the gradients are low, and this sort of entity of low flow, low gradient AS. How do you reassure yourselves that it's severe, and what is the reason for low flow in this patient, and likelihood of benefit? What is the sort of the algorithm? Because I think oftentimes the AS, just for the audience here, gets unrecognized because the gradients are low and people assume it's not severe, but or vice versa, that the valve area calculates low, but it's not really severe. What is your algorithm in these type of patients?
Yeah, that's a good question, Sushil. So basically, we do several different things. For the paradoxical low flow, one tool that we use is the calcium score on the CT, right? The dimensions index of this patient is 0.25 as well, but we use the calcium score as our to-go tool. So every time we have a concern, and this is the calcium score, as you remember, there was a recent publication for patients with low ejection fraction that might not be applicable. And the same story for bicuspid valves. So we have to be careful because the calcium score is not universal. It's not for all patients with low gradients, right? We have a paper now, Sushil, under review on JACC imaging that we're trying to reconcile the 4 imaging modalities. It's the invasive gradient, CT calcium score, echo, and MRI. So we did MRI in a lot of patients prior to TAVI. And one very important tool is the valve area by the short axis on the MRI. That also helps a lot, and the paper is going to show it's a very good tool for us to determine if the aortic stenosis is severe. So we use basically these are the tools that we use to show.
What about the beta stress echo? What did you ask?
The EF is normal here, so there's not a role for medium stress.
EF is normal, is it?
Yeah.
Sushil, do you do anything different at Columbia?
No, same thing. It's sort of the visual appearance, calcium score, DVI. And in this person, if you look for reasons for low flow, and here it's maybe the AFib, but we're also seeing a lot of amyloid, and if the tissue Doppler on the echo is low, we look for amyloid and other reasons. How about the rest of the panel? Any thoughts?
And that's why, Sushil, the amyloid is, you're right. And in fact, of course, having the MRI is a great tool because we can also, look for amyloid on that. Obviously, I understand that the cost of the MRI is somehow prohibitive to apply for everybody, but we have been using this tool in situations that are kind of questionable, and this paper is going to show that it's a very good tool and very reliable.
So, Guy, this is Ramesh Dagubati. I completely agree with you that
this paradoxical low flow, low gradient aortic stenosis patients still do much better if their calcium score is higher than as compared to lower in terms of their outcomes or improvement in KCCQ scores and all of that. So, but MRI is a good tool, and I wanted to ask you, how frequently are you testing them for amyloid?
Not very frequently, Ramesh. These patients that I mentioned to you that we were doing MRI consecutively pre-TAVI, we don't do them anymore, right? This was just a part of like a study that we were doing. But we don't frequently do, unless we have like a high suspicion of amyloid, then obviously then we're gonna use the MRI, or if the calcium score is not that high, and then we have a question, the patient is very symptomatic, right? Then in this situation, then we would use the MRI, and but we don't routinely test for amyloid. Do you guys do anything different? Do you test routinely, Ramesh?
Yeah, we are trying to promote that actually. We have a heart failure team who we are trying to promote that actually amyloid in almost all patients with concentric LVH plus aortic stenosis, all of them like routinely trying to get a P2P scan or at least light chains, and we are checking that.
We did a study.
That's a nice suggestion, Ramesh. I think we're going to start doing this here too. Maybe we can do something together, huh?
Yeah.
Some project, huh?
So
that would be good.
Unless there are any other questions, if you want to keep moving forward, we don't want to hold you up, but just
yes.
it's interesting.
So what we have here, just to show you guys the setup, basically what we have. So we have a 14 French centron sheet on the left. As Pedro showed, we have an aneurysm on the right iliac, so we wanted to avoid, going on the right. So we still have the 6 French on the right, and then we have the 14 French centron sheet on the left. We're going to use the Safari extra support wire. The Safari extra support is similar to the Lunderquist. The stiffness of this wire is similar to the Lunderquist. And we usually use the extra small curve for every patient. We don't customize. We always use this extra small curve for every patient. As I mentioned, we're not going to pre-do. We already checked the valve under fluoroscopy, so we're good to go here. And in the end of the procedure, we're going to cannulate the coronaries to show you guys the cannulation of the coronary with Evolut FX+. So Greg is going to now put the wire in the LV. Guys, let's get another ACT. Give me an ACT syringe here, because we took an ACT, it was 351.
Do you pace off the wire, or do you put a separate pacer?
So Sushil, that's a very good question. We have a jugular pacer here. Why we do not pace off the wire? Because for several reasons. And I'm going to justify the reasons. Basically because, number one, we like to go in the very end of the procedure. We're not going to deploy the valve. You guys are going to see. I like to pace for the final deployment of the valve, right? And for that, I like to pull the wire back. I pull the wire back inside the nose cone. So if I have to pull the wire back and pace, it's incompatible. I cannot pace over the wire. We don't use the TAVI wire here. Oh, come on. Go ahead. Yep. The TAVI wire. Don't like that. Okay. That's bad. We don't use the TAVI wire because the TAVI wire is too expensive, and I really don't see too much value on that, honestly, right? And the risk of complication with a pacemaker is, with a balloon tip pacemaker, is extremely low, right? And we put all of our we put all of our pacers via the jugular vein, because patients go, if they have to go to the floor with a pacer in, which is unlikely, but when it happens, right? If they have to go to the floor with a pacer in, then it's in the jugular vein, they can mobilize earlier. So we don't pace with the wire because of that. I don't see really like significant value of doing it, because it's going to impair me to, pace in the end when I'm gonna finally deploy the valve, because I like to pull the wire. So we don't do it.
That makes sense.
What do you guys do? Do you pace over the wire all the time, Sushil?
We're starting to try it occasionally. We're not doing it routinely. In someone that has a pre-existing pacer or something, and we're doing a sapien, we've been doing it because they already have a pacer. So we're doing it for Sapiens intermittently right now. For Evolutes, we tend to use the wire for positioning and also tend to pull it back at deployment, final deployment. So that reason as well, we have not been
Pretty much the same rationale. I got it. Yeah. So guys, another thing we're doing, another thing we're doing here, we usually use the inline sheet, right? The exchange of the sheet to the 14 and going with the inline. Some people feel uncomfortable with this part of the procedure, which I don't. I think it's routinely fluoro. So we're keeping the flush port 3 o'clock. We can give 1 and 50 of sedation, please.
Very smooth.
So I'm keeping the flush port at 3 o'clock. Per our data with Evolute FX Plus, with Evolute FX, I should say, if we keep the flush port at 3 o'clock, 97% of the time we're going to have commissural alignment, which is greater than Evolute Pro. Can you adjust my goggles here, please?
I have to say...
So which is greater than Evolute Pro. So we're going to keep the flush port at 3 o'clock. Then we're going to confirm the commissural alignment, which again, in this patient is extremely important because he does have coronary disease, has a patent stent in the LED, and he has some disease in the left main, not severe per the IVUS. Sorry guys, I'm just fixing my goggles here. All right, that's good, thank you. All right, so we're gonna go LAO to cross the arch.
What is this advantage of this plus? Only the hole is bigger.
For the coronary access.
What is the question?
No, there was a question of what is the FX Plus. We were just talking about the coronary access windows. Yeah.
Let's go.
Ready? Coming up.
I'm going to cross the arch now. Always in LAO, obviously. Keeping the flush port at 3 o'clock.
Very smooth.
Perfect.
Stop there.
So the FX allows us, and again, the FX and the FX Plus, exactly the same delivery system, exactly the same thing. Just a valve that has bigger cells. So it crosses the arches very, very smoothly, even like more complex anatomies. What is the?
Yeah, I mean, so in India, both Evolute R and Pro are available. There's a cost difference, so there's a lot of Evolute R still used here. So that delivery system is obviously different with the two spines, and the behavior of the valve deployment is different. So it is worth sort of mentioning that this is not like the R.
All right, guys. So we switch our camera to cusp overlap. In LAO, we could see the head marker in the outer curvature of the aorta. Now in cusp overlap, we should see the head marker either to the left or facing us. And then the last check is going to be the golden markers, okay? So we're going to go now. 340 ACT check.
So if your hat marker isn't favorable and you don't think it's going to be commissural alignment, do you pull back into the descending thoracic aorta and rotate?
That depends on the patient I have on the table, Sushil. In this case, I would because he has coronary disease, right? So then I would do it.
Okay.
Even if I am a step ahead, right? If I am at 80% and I see the golden markers are not properly positioned, I would recapture and bring down to the descending. Because in this case, since he has coronary disease, if it's like a 95-year-old patient with no coronary disease, then I would just let go. But yes, in this case, I would, if I had to. Okay, buff there. So we're going to reposition the peak zero tangle there. Another aspect, you're going to see the difference. As Sushi was mentioning, you guys have Evolute Pro or R, or Pro Plus or R there. We're going to start, buff there. There you go. You are not in the right. Yeah. So there you go, buff. Perfect. You see, Greg is already an interventionalist. He's a percutaneous surgeon. Huh? Go hard. So look at what Greg's doing. So we're going to start here. As you can see, we're not doing anything wrong because with Evolute Pro and Evolute R, remember, you start halfway through the pigtail. The Evolute FX, because it's a more stable deployment, we're going to start closer to the bottom of the pigtail, almost in the bottom. So that's where we're going to start. I'm going to start rotating here fast, obviously, right? Because the valve is completely covered. Don't move, sir. Stay still. Shallow breaths, please. Pull. Shallow breaths. Stay still. Micro puff.
What is your goal?
So just so you guys know, we didn't take any pictures so far. 0 pictures. We didn't take an orthogram. No push. So we have not taken any pictures.
What is
so we're going very slow.
What is your
right?
goal depth here? You want it like 3 below or like at 0 on the?
No. So we're gonna aim at like at 0, as you know, right? If we go too high, we may pay a price, right?
Yeah.
Higher implants for, if we need, not this case, but in general, for TAVI and TAV, for example. So 3 is my kind of go-to. That's my goal here. 3, 4, I'm happy. Puff, micro puff, good. So are you guys happy so far?
Yeah, I mean, I think those dots
Okay,
on the bottom
good,
is one
right?
of the greatest
3 millimeters.
innovations.
So as you guys know, right? 3 millimeters. The golden markers are positioned at 3 millimeters. Pacemaker on, 140. Good. 150, puff. 160. Pacers. Our pacer is not helping us too much, puff. Don't move, sir. Stay still, please. Puff. Down. Nice. Seen it? Pacemaker at 120. Inject. All right. Going LAO. Fluoro. All right. Seen it? Inject. All right. Panel. Happiness or frustration?
It looks good.
You guys have, so basically what we did, right? We went RAO for the implant for cusp overlap. Then we moved the LAO to make sure we capture the left, right? So we capture everything. Now we're gonna, again, that's step of the procedure.
So can you show us
first position is gonna, go ahead.
Can you show us that RAO cine again, just to go over it for the audience real quick?
RAO picture. I'll show you, 1 sec. Here.
Yeah, it looked like
There you
2
go.
millimeters on the RAO.
Yeah, so,
maybe
yeah,
1.
and I think here again, you look, because this is the sort of the cusp overlap, but you have the 2 dots on the left side, it looks like you have commissural alignment, right?
That is correct, Sushil.
Because
in fact,
the 2 dots on the bottom are on the one side, so that's a good check for you right here, right?
Yeah, indeed. Sushil, and because we wanted to confirm that Medtronic was actually telling us the truth, right? That actually corresponds to commercial alignment. We did a study with CT post-TAVI that indeed when you have the position of the golden markers that way, in 97% of the patients you do have either mild misalignment or complete alignment. So that you can rely on those golden markers to understand if you have commercial alignment. That's a very good point. Fluoro, please. So now we're gonna deploy, and the deployment, I'm gonna pull the wire all the way inside the nose cone to centralize the nose cone. If you look at the screen there, the nose cone is centralized. I pull the wire all the way in, barely inside, not all the way back, because the connection between the catheter and the nose cone is very flimsy. So I pulled all the way just inside the nose cone. Greg is gonna do mild forward tension, and we want to have the systolic blood pressure around like 110. So pacemaker at 140, please. And I'm gonna go very slow. So I'm going very, very slow here to let the nitinol progressively expand.
I mean, you can wait at
Greg
this
is
position
doing
as long as
a
he
mild
wants.
forward tension. And I'm going extremely slow to let the nitinol expand very, very progressively so we have a stable deployment, right? That's the goal here. So you see how slow I'm going. This is how we deploy all of our valves, very slow. Yeah, pacemaker 150. So I'm letting now the valve expand. I'm not doing anything. I'm just letting the valve expand progressively. At this point, Greg is not pushing. He's just neutral. He's just letting things happen. Going very slow here. As you can see, the top of the valve comes out progressively. Don't move, sir, please. Hands still, don't move. As you can see, guys, our patient is, of course, awake. Mild sedation, but awake. We're talking to you. Are you okay there, Paul? Is he okay? All right, good. All right.
Still attached.
Still connected? Disconnected?
Ready? Coming back.
Careful. Spacer off. As you can see, I do not keep the wire in the LV, right? We pull the wire back, and we're gonna pull the pigtail. Also, some people have this concern of the pigtail, pull the pigtail prior to, no, nothing, you don't need it. So pigtail never pulls the valve out. If you're not, after you're done, just pull the pigtail back. We're gonna do echo now. Echo. And hemodynamics. So echo team is here. I hope we did a good job. Greg, in the meantime, is doing his fast track, trying to cross the valve before the echo shows up here. But the echo is here, so we don't have more time. You got it. You see? I told you guys, he's a percutaneous surgeon. He is better than an interventionalist, man. We worked together for so long. This is something in the United States, right, that we have, strong surgical partners. So it's very collegial. We work very well together, and this is really something that we appreciate.
It's really a great team.
Right, Greg? Huh?
Absolutely.
All right, 00, please. In the meantime, echo, you're good
So
to go. One second.
you saw as the valve finally released, it did cant, and that's in that anterior posterior, and typically it will drop. So sometimes we always worry that we're too high, and you'll get this motion. And that's what's a little bit unpredictable sometimes. But I think he showed, as long as you're anchored on the cusp overlap on the non, and you verify it by going LAO to the left, in general, we try to keep it at 3.
You saw him pushing the
I have one
pigtail.
comment to make about the canting.
You saw him
and
pushing the
movement
pigtail
to
into
show.
the valve. Is it the way you should do it?
You can do it with that or use a J-wire, either way.
Yeah.
One second. In terms of the canting, Sushil, the comment of the canting, I don't see the echo on the screen.
We can see the echo.
Can you see the echo?
Yeah.
We can.
All right, awesome. You see it, right?
Yes.
Beautiful, excellent. So Sushil, just a comment in terms of, so we go very slow to deploy the valve. One story is you have either ventricular or aortic movement or significant movement of the valve, right? The other one is the canting. The canting is normal to happen, and that's going to depend, obviously, right, on the distribution of calcium, how much of force. That canting, sometimes even when we're implanting balloon expandable valve, Sapien, or my valve I've never done, but Sapien, right? Sometimes you align the valve precise, and when you inflate, you see that the valve comes with parallax of the interaction between the valve and the native anatomy of the patient, right? I think what is important for us is the fact that the valve actually doesn't move. This movement, I don't really kind of buy that story, because as long as you deploy very slowly, which we did, we can take this one out and put the other side super fine. As long as we deploy slowly, I would say that 99% of the cases, we have a very, very stable position of the valve. Even the case that we implant, we are too high for whatever reason, right? So it is important, crucial, the 4 elements for the deployment: pulling the wire, gentle forward tension from the first operator, very slow deployment, and pacing. If you fulfill these 4 criteria, you're gonna be fine. Very rarely the valve is going to move, and therefore you're gonna have a very stable deployment in the end. So that's, I'm sorry, I could not see the echo while I was talking to the team. How are you looking, the echo? Looking good?
Echo looks very good. There are no PVR.
Okay.
I think gradient is, I think, what, 5-4?
Excellent. And we're going to do now, have invasive. Can we zero the blood pressures, please, guys? We are inside the ventricle. We have the pigtail through, so if you have a little central eye, it's normal, okay? The pigtail is through the valve, just so you guys know. Let's see there. All right, nice job, eh? All right. How much time do you still have, Sushil?
Oh, we have plenty of time. So
plenty of time, good. Because what I'm gonna do now, we're gonna close the left. That's what we do routinely, so we don't do anything different for live case. We're gonna close the left very briefly, and I'm gonna cannulate the right and the left coronary, okay?
Okay.
Because I don't like to leave the large bore on the other side while I'm cannulating the cords, right? So that's all. We're gonna be briefly in the closure. Since we're talking about closure, how about we discuss this? I think one of the things that's being people talk a lot about is, oh, we only use one proglide for the 14 French sheath. What do you do, Sushil, Ramesh? What do you guys do? Do you do only one proglide, two proglides, and why?
So I switched to one proglide, and if at all there is a need, after giving protamine, I'll go for an angioseal. Otherwise, actually one proglide and manual pressure is working quite well for us.
How about Columbia,
Yeah,
Sushil?
same thing. I mean, we're using one proglide, it doesn't hold, then we add a plug on top of it.
I still do too. I mean, unless it's depending on the size of the vessel, but I think that, part of it is the sheets in and out can disrupt, in an obese patient, sometimes disrupt the knots, and it's not that, it's just there's a safety net of the second, but, because I don't see the issue of pinching in the artery, and I haven't been concerned about it, but maybe I should be.
If you allow me to say, I agree 100% with Sushil, because we use two proglides because it's a more consistent hemostasis, right? As you can see, guys, there, just before we talk about this, hemodynamics looks great, right? So EDP.
Can we make them big? Can we make the hemodynamics big? We can't. It's really small right now.
Oh, okay. Sorry, 1 second. Let me show you. Can you see hemodynamics now?
Yeah. Yep. Now we see it.
All right. Beautiful. Let me take this pigtail out of the way here. All right, pulling back.
So no peak-to-peak gradients on bike.
Yeah, no, and the EDP, so it's important, the hemodynamics, when we do only TTE, let's go close the ground, go to the left side there, please. When we do TTE, we don't do TE, we always rely a lot on the hemodynamics because, as you know, right, the TTE may miss PVL. So therefore, the hemodynamics is very important for us because we're going to rely, obviously, on the echo and the hemodynamics. As you notice, we didn't do aortogram, and we almost never do. Why? Because the aortogram does not add too much additional information. In this case, trivial PVL, the EDP is the same or lower. There's no need to do an aortogram. Why am I going to inject 20 cc's more of contrast just to make me feel better? There's no need for it. And remember, his kidney function is not pristine, so we want to avoid that.
Yeah, I completely agree with you. I don't think that there should be a routine anything in patients like these. I mean, if the diastolic pressures are good, above 60, I don't even worry about anything else, not even post-dilating anymore.
And another thing you can see, we are closing the groin here with, we didn't put the sheet back in, right? Because we removed the wire, we don't have to do that. Buried, right? Is it buried? Okay, coming out to the delivery system. Just 1 second, guys. Let me just focus here 1 second, okay?
Yeah, sure.
Okay, I got it.
I think meanwhile, Sushil, do you give protamine regularly?
We do, we do, every patient. However, we're not giving here because I'm going to cannulate the coronary, so I'm going to give the protamine after, okay?
After, yeah. So the only time actually, it was a very funny situation where we were doing under TEE and the sapien valve was implanted, ready to get out everything and gave protamine. And the TE person was just still showing, looking at the valve. And suddenly there was a clot on the valve.
Oh, yeah?
There was a clot on the sapien valve. So I went back with the 8 French guide and actually sucked it out. Luckily, it came out. I don't know how it came out.
Yeah, an acute clot on the valve?
We give protamine for everybody.
I know.
In the end.
Yeah, I pretty routinely give it occasionally don't, but more often than not give it.
Yeah, so
just because there's a little bit of ooze all the time.
I started underdosing, 30 of protamine.
Yeah, we give half dose. That's what we give.
Dose,
we give half dose, yeah.
So guys, just one I want to show you guys here. So there is still some minimum bleeding, but as we talked about, right, this should be okay for us to do manual compression. So we're gonna remove the wire. We're gonna lock the proglide. We only lock after we take the wire out. And then we're going to finish with manual compression, okay? So we don't need to put an additional closure device here. The stick is mid-femoral head, so it's a good stick. So we're going to finish with manual compression. Well, let me go in. So I'm going to close the whole of the wire one more time and lock the proglide, always in a coaxial fashion here. So Pedro is going to do... Let me go. Pedro's gonna do the
manual compression.
Okay, hold. So Pedro is going to hold the groin while we cannulate the course. All right, so let's cannulate the course now. All right. So you guys know, I'm going to describe the design of our study. I need 5 volume and flow there, please. So the design of the cannulate TAVI, and we're doing this the same with Evolut FX Plus, is basically we cannulate, we go with the JL 3.5 and a JR 4 for every patient. Meaning, I do not use the information from the CT to choose my catheter because I did not want to be a biased study, right? So I'm getting, give me a flush, please. Thank you. I didn't want to use the CT information to bias me, right? So basically what I do, we go with the 3.5 JL, and I'm allowed, thank you, I'm allowed to switch if I don't think that's appropriate catheter. Okay, so going up here, so I need to say this, sorry. So there's no drama here to cannulate the coronary. Go LAO, so you have to go LAO, which Mag one up.
So first he's making sure the wire's inside the core valve frame.
That is a very, very important indeed,
right.
Yes.
And then, you know, he's LAO like we normally do with cannulating the left coronary, and trying to find the large hole. And this catheter may be a little small, but
that is correct, Shu. Maybe a little too small. But I have to follow the protocol of the study. That's why I made it through.
He went through, yeah.
All right.
I mean, oftentimes, you know, it is the JL35, especially with the Evolutes, because you've sort of narrowed the route with the frame, and so you don't have, the 4 is too long for back wall support, so it ends up being a 3.5. But this is a big valve, right? This is a 34?
Yeah.
Was it 34 or 29?
Again. All right, guys, we're there. All right, so cannulated left coronary. Of course, this is what we call in our study. In our study, give me the stiff part. So now I'm gonna take the JL out. I use the stiff part of the 035 wire. I want you to show you this movement. Because if you do this, of course I'm not gonna put it out of the catheter, but when you push the stiff part, look at what's gonna happen with the catheter. It's very, very elegant. You remove without trouble, like that. So then I go with the other one. And remember, we took this picture. We used the same definition for coronary cannulation of the Tarantini and Barbanti's paper, which is this. So we took this picture now. We were in front of the ostium of the coronary. This was not a selective picture, but per the definition of our study, we would take whatever happens first. And this can be considered a non-selective because we're right in front of the ostium, okay? So this is important, right? We took both definitions as non-selective or selective, and whatever happens first, we take it. Now we're gonna go with the JR. In our initial study for Evolut FX, we were able to cannulate the right coronary 100% with the JR4 and 80% with the JL 3.5, the rest JL4. Okay, timer. Timer up. Good. All right, so now same process with the JR. So he has also a stent in the RCA. Another, once again, re-emphasizing the importance of having access to the coronary. This happens, these are actually something that happens quite often. Depends on the anatomy of the aorta. When I'm rotating the JR catheter, sometimes you see that the catheter goes to the LV. Not infrequent to see. In this case, what I tend to do, I tend to start, you see, I just try to rotate, the catheter already falls down. So when this happens, I try to start a little higher than I would normally do.
So by aligning the commissural dots, you could open up the window as well. Do you ever do that to sort of help you, or is that?
I don't, Sushil. I do not open, because I got so used, to be honest with you, I got so used to cannulating with Evolut FX that I don't know that I see like a huge value on it. Puff. Right, pressure is good. Puff. All right, we're there. Timer off. Okay, so both coronaries cannulated in seconds or minutes. The right here was very quick, so was the left. Again,
how do you,
we do not.
How do you use this information? So do you put it in the report? Like, for example, if this patient came back for a coronary angiogram, probably a JL4 would be a better catheter, right? Because you were a little bit short with that, it seemed like. Would you put that in the report so it's available if the guy came in the middle of the night? Is this something that we should be considering so when people do come back, or that we understand what the anatomy is to cannulate?
Sushil, I think you were having access to my IRB proposal. I think so. I think you have some spies here in the university hospitals. No, I'm just joking, Sushil, because this is exactly how we were able to sell the concept of the study to our IRB, meaning, oh yeah, we're doing this, there is a purpose of doing this, right? And the main purpose is exactly that one, that we have documented that 3.5 JL, JR4, we were able to cannulate the coronaries, and if in the middle of the night this is required, there is at least some piece of information to whomever is gonna do that, right? So yes, you're right, and that's the way we're able to basically make it happen. Okay guys, 5-0 of protamine, please.
So
we're all done here.
So I guess the question is, and one of the challenges is that if they come to your center with a STEMI, you understand, and you've done with a lot of valves. And here in India, more valves coming in, but the STEMI centers are everywhere. And people present with a STEMI, and they have a valve in place. How do we educate? Like, what do we do? Like, in the middle of the night, how is someone going to handle it? What are the resources? And are the companies providing resources and some training? Like, if somebody comes in, can somebody call Medtronic and say, how do I do this? Or maybe some comments here from.
Yeah, so sure, that's a very important
I know a
aspect.
person, cardiologist, who has never done a TAVI. He had a patient with acute MI who had already a TAVI done. So he took it and just did it as he had acute MI, infraval MI, cannulated and did it. I saw the picture. So his beginner's luck could be, but there is no definite way of telling how to do it, but it's so infrequent. We don't have any guideline on this. So people try in the same way like they do in acute MI, and it goes trial and error method.
So Sushil, that's a very important. That's a very important comment.
Teaching center and others also is a good
idea.
Yeah, I mean,
so
I think
Sushil,
sorry, go ahead, Guy.
Can I just make a comment? I just would like to make a comment on your question. So this is a conversation that of course I've had with Medtronic, right? That our job is we're actually building the blocks here. So starting, right? To start, we need to show that this is doable, right? We can cannulate the coronaries, it's feasible. This is one story. The other one, so which we did, right? Then the next story, can we give him like 50 of fentanyl, please? Thank you. So the other story, Sushil, is to make it reproducible, because one story is that I cannulated 99% of the coronaries here, so it's a single operator procedure, right? So we need to make sure that this is actually reproducible, right? Which is now what we're doing. We have another center in Japan. My friend and colleague Yohei Ono, he's cannulating the coronaries via radial. So we have radial and transfemoral. So we have to be, it needs to be doable, needs to be reproducible, right? That's what you're doing. And the next step, Sushil, is exactly what you said, which is educating our colleagues, right? Because people do have to feel comfortable, right? Having a STEMI in the middle of the night and knowing what to do, right? And honestly, I think that Evolut FX Plus with a bigger window it's already kind of emotionally, I don't know if that's the right word, but when you go in, or whomever is the interventionist that is not using to doing this, he's going to feel more comfortable. I have a bigger window, 4 times bigger than the other valves. I'm going to make it, right? And I think this is our job. We have to do that, and we have to engage the company, and we have to engage all of the stakeholders necessary for that. Because as you know, right, people talk about a lot the fact that, patients who have the incidence of the requirement, the need for intervention post-TAVI is low. But those data come from, patients that are older, moderate or high-risk patients. As we know, treating lower-risk patients, we're gonna need to have more access to the coronaries. And not only that, right? When we talk about TAV in TAV, it's another discussion here. That's why it's our job, and we were talking about the depth of the implantation, right? We were amongst the centers that were all, happy and implanting valves high, but we know when the pacemaker, high pacemaker rates was a big issue, right? Today, however, we try to customize in a different way. We try to implant actually the valve like 3, 4, sometimes, even deeper. Depends, right? Because we want to make sure that the patient can get a TAV in the future. That's going to be based on the amount of oversizing, the anatomy of the patient. It's going to be based on, prior conduction. There are multiple things. I say that today we are in the era of the customized TAVI, right? We have to customize for that patient. What are we going to do? Are we going to recapture if we have misalignment of the commissure? Are we going to implant? What is the depth? So we need to take all of these factors into account to be able to deliver the best to our patients. That's our philosophy here, and I think that's what we have to try to do.
That's great. It's interesting you talk about, lifetime management issues in valve, and, with Evolute FX Plus, potentially you could do another Evolute even because you could cut the leaflets and maybe the windows open up, maybe there's less metal in front of the coronary. Eberhard, you've been here from the beginning and...
Yeah, I think, Guillermo, this is Eberhard. Congratulations. I've not seen the whole procedure, but this was excellent. And obviously, the result is perfect. As far as the coronaries are concerned, I think what is important that you're patient. In order to do that, you can't really rush in. Usually, I don't take the GR4. I take the GR3.5 to get the bend a little bit more, but that's obviously personal preference. On the left side also, so usually I don't take the same that I'm using to intubate the coronaries with. I take one size down, but it's beautifully done, Guillermo. Congratulations from my side here. Perfect.
Eberhard, thank you for your comments. Coming from you is always an honor for us, right?
I just came
really
in when you deployed the valve, and it always makes me really happy that somebody is not rushing it. And what you just said, first of all, the depth was perfect, the cusp overlap, and then you were patient releasing the valve. That was the intent when we started this, and you showed this with your team beautifully. And look at the result; it's just perfect. Congratulations again. Excellent.
Thank you very much. Thank you, Eberhard. Thank you, Sushil. Thank you, Ramesh, all of the friends from India. I'm looking forward to meeting you guys soon in September. So if you have any other questions, any other comments, Sushil, Ramesh, all of the other colleagues, I don't know who else is in the panel there.
Well, no, thank you so much. I know, I don't know what time you had to get started. I know at our institution to start live case at 7:30 for a TAVR would have been very difficult, so I appreciate your team. I don't know if you had to come in earlier or that's your normal start time, but appreciate everybody coming in early and for a wonderful demonstration. So thank you to you and your team.
Yeah. Thank you, guys. Really nice. We're very honored to be part of this, and we're looking forward to next year. Thank you. Bye-bye.
Thanks.
Thank you. I think, can we connect for 5 minutes to the German Center? They requested just to come back.
Yeah, we're going to go back to the coronary case.
The final result we'll see.
Just to see the final result here for a minute, if we can connect back.
Now, dann hat keinen Bock mehr nicht. Elias, wir brauchen deinen Ratschlag hier. Wahrscheinlich musst du hier kurz was stenten.
Hello, good evening, Dr. Ferenc. I'm Dr. Srinivas Kumar here from Hyderabad.
Nee, die ist noch drin.
Can you hear me? Hello.
Wenn ich die rausziehe, dann...
Hello, I am Dr.
Yes,
Srinivas
sir.
Kumar calling from Hyderabad, sir. Can you hear me? Hello.
I don't think
Not
he's- Hello?
connected. Yeah, we can hear you, sir. I was told that you wanted to show the final result. We are back with you for 5 minutes from Hyderabad.
Yeah, should we go live and present our final result?
Yes, sir. We can see and hear you well. Go ahead and show the final result.
We don't hear you really good, to be honest.
There is not,
There's an echo.
Mathieu, we don't have really good connection.
Please go ahead and show, sir. We can hear you well and see your pictures.
Okay, we should go ahead and sit.
Okay. So we stop at our case when we just were ready with LAD. The next step was, can you see the pictures?
Yes.
Okay, wonderful. So this was final result for the LAD. Then we wired, this was LAD. And we have done the steps like suggested, distal optimization, proximal optimization, diagonal branch, still TIMI3 flow. So we leave it like this, then wired circ, both branches, predilated with 2.5 and C balloon. And finally, we had in OCT run quite a very acceptable result, no huge dissection. So finally, this was OCT, finally we went to use, there was some spasm in this obtuse marginal branch. Finally, we went to use drug-coated balloon for this distal circ. And we have done this. This is 2.530 prevail with 14 atmospheres for 45 seconds. Finally, we had very acceptable result. And again, here in caudal position projection. So finally, we performed one run more from obtuse marginal branch to left main, and this was very acceptable, no flow limiting dissection. So we leave it like this, so we could finally manage this case with one stent and one drug-coated balloon. So both bifurcation are, we believe, definitely sufficient treated. And the next step was to remove impella, place the IMA in the iliac artery, and we could go back with impella support. So we checked pressure, wedge pressure was 21 between during the procedure, and now again 20, so we can be quite sure patient is now stable with a pressure of around 110. Yes, so it's really a sufficient situation. And we have now to remove the pump, and you can see the guiding or sheath is still in iliac artery, but we have some dissection, and that's why we ask now angiology guy Dr. Nori to check this angiographic result for iliac artery with us. Maybe to leave it like this, maybe to stand. I don't know what we will approach now, but by coronaries, we are now absolutely stable. Impella is now outside, patient stable, and we have just to check the situation with iliac artery. And it was initially extremely difficult to go through iliac artery because of tortuosity.
What is your decision here? You're going to try to wire it, or are you going to watch and see, or?
No, we have already wired, so the wire is now from distal, as you can see here live. And if I just inject one more time.
Yeah, can you pull the sheet back a little bit more, Miroslav? This is Ramesh. So when you do the injection.
Hi, Ramesh.
Hi, yeah, pull back the sheath more, yeah, so that we can see. Yeah.
I think there's probably the need for stenting.
Yeah.
So we have here Dr. Nora in the room. I think that's very clear. We have to go ahead with one stent more.
I think they'll stent that and
yeah, I think this has to be ballooned or got the vascular surgeon in the room.
Yeah,
I think this is very important to establish
exactly.
flow.
We have it here balloon. So can you have?
Can
So we go now with that balloon. Admiral. Dr. Nori, our angiologist, what do you believe?
Miraslo, this is Dr. Srinivas Kumar here. I think you can work in peace. I think depending upon situation, you balloon it and then put a stent later. But excellent demonstration of coronary intervention. And these problems happen, I think you'll be able to tackle it well. We need to break with you, and congratulations for an excellent demonstration of a cheap impella case. Can you hear us? Thank you very much. I think a big round of applause for Miraslo. As the hall is full, everybody appreciated you also. Thank you. You can break that connection. And now we have another interesting symposium coming, Simplify the Complex Symposium, which is basically designed highlighting the role of imaging and physiology. I think request a good friend, Dr. Ajay Swami, senior consultant cardiologist from KIMS, to come over and conduct this symposium.
Good evening, everybody. And before I begin, my salutations to my teachers, some of whom I see in the audience and some of whom are not. I request our other chairpersons, Dr. Rath, Dr. Kirtane, Dr. Ramesh is already here, Dr. Jain, Dr. Ravi Kumar, to please join us on stage. So, without further ado, we'll not stand between you and the speakers. We have 4 talks in this session. And the first one is OCT, the game changer in managing complex PCI. Dr. Ramesh. Thank you.
So good evening, everyone. Great pleasure to be here. Thanks to Dr. Srinivas Kumar and TCT for inviting me. So I have no disclosures. So when we talk about complex PCI or high-risk PCI, probably you saw the patient that Dr. Frank has done. These are the people who have high-risk clinical and lesion characteristics, including diabetes, acute coronary syndromes, or long lesions. Bifurcations are the most important, as we saw moderate to severe calcium, and chronic total occlusions or instant restenosis. All of these make these patients complex PCI. So when we talk about imaging, actually it's still class 2A indication for left main intermediate or ambiguous stenosis to use intravascular ultrasound, and it is a class 2AC for optical coherence tomography. So the best practice summary for using intracoronary imaging is done in only about 18% of the PCIs in the United States still, as per NCDR, that National Cardiovascular Data Registry 21 to 22. And about pre-intervention assessment is 25%, and the post-assessment is also still 25%. So the intracoronary imaging will help us to actually plan what size of the stent to be done, what sort of plaque modification that we have to do, and based on the plaque characteristics and the length of the stent and the size of the stent, and also to look at actually malapposition is there or not, and under expansion, and any complications such as edge dissections, and ruling out the geographic miss. So where is the evidence? The Renovate Complex PCI trial looked at actually 1,620 patients with complex coronary artery lesions undergoing PCI, which are defined as true bifurcations. As I mentioned earlier, I think it's long lesions, CTOs, bifurcations, multi-vessel PCI, and all these types of lesions. Imaging guided versus angiography guided PCI. So it looked at actually true bifurcation lesions that's seen in about 22% in both. And a number of vessels treated, 3 vessel disease are treated in about 30% of these patients actually. So, and so that's one important thing. The next one is Illumin 4 looked at actually a randomization of 2,487 patients into OCT guided versus angiography guided PCI, and about 1,230 patients had a follow-up. In these patients, unfortunately, I'm sorry about something happened. So there's no final post-PCI minimal stent area by OCT. Square millimeters is 5.72, is slightly higher, which is statistically significant though, but compared to angio-guided, which is 5.36. The OCT-guided PCI appears to be numerically better than angiography-guided PCI in a target vessel failure. However, it was not statistically significant, but it definitely is non-inferior or slightly superior numerically to with the angiography-guided PCI. So in October trial, again, the stable angina and unstable angina or non-ST elevation MI, true bifurcation lesions were randomized on OCT guided versus angiography guided, and the primary endpoint of MACE at median 2 years. And that actually the primary endpoint of death from a cardiac cause, target lesion MI, or ischemia-driven target lesion revascularization is superior compared to angiography-guided PCI with an absolute risk reduction of 4% in the MACE rates. So this is actually a smaller trial compared to the previous ones, but still is very strongly positive in this one. So how does, in my experience, 54-year-old male patient with non-STEMI referred for CABG for left main lesion following angiography, and I think here you look at it, it's probably that the area itself is 9.04, and there is some calcification plaque, but this patient, if he had been underwent bypass surgery, that lima would not have been open because lumen area is large. And so this type of patient, we defer CABG, and actually we offer PCI in case if this patient is ACS as in this patient. So we definitely will treat it with the PCI in this patient. So and as you can see that there is a lot of atherosclerosis here, as well as plaque with the thin cap fibroatheroma in the ramus intermedius. So in a different patient with the diabetes here, this is a patient that we are trying to do bifurcation stenting, and then we are not able to expand the balloon in the side branch. As you can see, there is a waste that actually will look at it. Where is the problem? Actually in the OCT actually showed that we were entering the proximal cell, and we are not able to expand that cell properly, and using the bifurcation mode. So the proximal strut was the one that was crossed with the guide wire, and hence we removed the wire back and knuckled it, and then re-entered again into the distal one, and that actually led into the better expansion in this patient with the side branch apposition. And so this one was repeated again, OCT actually now compared to proximal cell cross and the distal cell cross. After rewiring, we got a much better lumen area, as well as actually you can see visually that the cell side branch cell opening is the strut opening is much better. So it helped in this patient with the side branch optimization, and OCT was very useful in such a patient. So yeah, as you can see here in the drive-through, actually that side branch is much larger than we would have thought of. Okay. So the bifurcation mode is clearly, I think, game-changing in my opinion for using optical coherence tomography in these patients and in bifurcation lesions. The next one is moderate to severe calcification. We know that calcified lesions are really bad as they increase the major adverse cardiac events. And the degree of calcium it can be assessed by OCT, where arc of calcium, calcium thickness, and as well as the length of calcium. And you can give a point 0 to 4, and actually anybody with the 3 and 4 should always have a debulking techniques for those patients. And here you can see that calcium thickness is measured at 1.3 millimeters on the left side, and the arc of calcium is high. So this patient, obviously, you cannot get a better expansion without trying to, with a straightforward PTCA and stent. So direct stenting or PTCA with stent may not be the best one. So lesion preparation is important, and atherectomy will reduce the thickness. What type of atherectomy is up to your availability, whether it is rotational or orbital atherectomy, and if it is large, probably left main, we might go for orbital atherectomy, or sometimes calcified nodules, we might go with the orbital atherectomy. But at least some sort of atherectomy followed by the cutting balloon or further fracturing these may be important, or NC balloons might also be helpful. And as you can see, the area went from 2.06 to 9.38 millimeters following the proper techniques in such a patient. So here is such one example of a diffuse mid-LAD disease, 72-year-old female, stable angina and multiple risk factors. And so this patient had OCT, and we could have just gone and directly put a stent, but I think that the point I'm trying to make is this is game-changing to see that there's such a severely, heavily calcified calcium and more than 180-degree off arc of calcium and very thick, more than 5 millimeters, and long lesions. So it meets a lot of criteria. And so these patients, actually, we need to prepare the lesion properly. And here we used IVL and the lesion preparation with IVL. As you can see, after the fourth cycle or session, we were able to dilate the lesion much better. So, and then we went ahead further with after delivering all the 8, at that time only 8 cycles were available, and we did see repeat OCT showed expanded lesions with some dissections, which is not unusual, and so further expansion was performed with the non-compliant balloons, and then there was no obvious dissections around the calcifications, and further additional pre-dilations, as we said. And following that, there is you can now go ahead and almost stent-like result, but obviously a stent was placed here in this patient, and ultimately the result was excellent. And so the diagonal has some disease. If somebody wants to go after it, yes, that could be done, or at that point, or a staged procedure can be also done. So this patient, the OCT shows here that absolutely well expanded stent, and circular round shape stent is seen, and optimal stent position also is very visible. So here's the baseline, and as you can see, very heavily calcified vessel, and OCT, IVL results were very good, but still there were some dissections, and whereas with the final stent result is optimal lesion preparation was achieved, and optimal stent deployment was achieved. So how do you do optimal lesion preparation, whether you use rota, laser, cutting, OPN, or a shock wave, or orbital atherectomy, as I mentioned, that depends, but at least doing OCT will help you in making a decision. Such algorithms can be used based on OCT, whether we can actually, what type of balloons or atherectomy devices should be used. So in my take-home message, and for me, especially OCT helps to assess the lesions much better, and algorithmic approach simplifies the complexity of lesions and prevent complications with proper patient selection and device selections. And I think some people think that with OCT we will add more time, but that's okay. Do not rush. This is not the time that you want to rush and do and have a suboptimal result. It should take a little bit longer time, even if it takes another 20 seconds or 2 minutes, but get the best results that you can give to the patient. With that, I'll stop here. I'll be happy to take any questions. Thank you.
Thank you, Ramesh, for an excellent lecture. I think with a lot of data coming in, when do you think that imaging is going to be a class 1 indication in complex lesions specifically? Because October trial and all these things. Other area where the imaging is getting more importance is in use of DCB. Now a lot of people using DCB, around 5 to 10% patients are in hybrid procedure or DCB alone. Their imaging is playing a major role. So that's the area where it's growing now.
I think, obviously, I wish Illumin 4 was more strongly positive. That would have bumped it towards class 1. But that said, I think it is still valuable for us to keep pushing, even though it is 2A. intravascular imaging should be performed in all our patients. Trying to train our fellows is important. I never trained on imaging actually as much as my fellows do. Now at our center, we almost do 100%. I'm the only one who probably brings it down to 90% because I don't do imaging on all PCIs, but I do it on all complex PCIs. At least it's 100, it should be 100%. Left main bifurcations, long lesions, and all these patients that we talked about. That's what we can change the plan by trying to educate all the fellows.
Dr. Ramesh,
Dr.
excellent
Jain.
lecture. The sub-study of Element 5 published in JACC, the sub-study of Element 5 which is published in JACC has shown that imaging and IVUS in a complex patients, area achieved is good, stent position is good, but there is no change in target vessel failure. So you think with this, will you get a better class 2 or class 1B indication?
So the new generation stents are really very good, right? So I think that's why if you increase the sample size, it will become positive. Because the small, the endpoints are so small, and I think target vessel failure is below 10% nowadays, and we want to achieve, we are able to achieve good results with the current generation stents. But this difference in small differences, if you want to magnify that, it only can be done, statistical significance will be achieved by increasing the sample size. Thank you.
Dr. Ravi, you have anything to say? Yeah, I totally agree with Dr. Ramesh. These days, it's clearly, when imaging is in the complex lesion subsets, definitely it's mandatory, I feel. Because as Ramesh said, even we were not trained during our course for the imaging, but nowadays almost 80 to 90% of complex cases we have been doing it. I mean, and we feel very satisfied giving the result. Actually, I mean, we were doing it earlier also, but we were doing it, but now we know that we are definitely achieving the best outcome there. And how much it is translating to target vessel failure, we have to see.
Yeah. Thank you.
Thank you for that excellent lecture. Our next talk is choosing the right patient for calcium management, Rota versus orbital. My experience, Dr. Sridhar Kasturi.
Yeah, good evening, all of you. So before we proceed with any procedure, always you should be familiar with the device. So orbital atherectomy, new device, new entrant into the market. So this is very useful actually. Compared to Rota, easy to learn, and advantages are it has a forward cutting and backward cutting, and eccentrically mounted. Only single device you can increasing the speed of the crown. You can get better luminal area. That's very important. Right? Suppose the vessel size is 4 mm, you can go with a 1,20,000. If it is smaller, like a 3.5, you can go with 80,000. So the wide is also very important. It's more trackable. That is the advantage of the orbital atherectomy. Only thing is you have to move it very slowly. That is 1 mm per second while moving forward and backward, because it moves along the periphery of the orbital motion. So central portion, central lumen of the blood vessel is available for purging. So continuous flow is maintained so that the debris clearance is much better. The debris what we generate is 2 microns versus 7 to 8 microns with a Rota. So Rota, it requires definitely the learning curve is more compared to orbital atherectomy. But it's a wonderful device, particularly when patient is having a balloon uncrossable, very tight, very critical lesions, okay, ostial lesions, distal lesions, less than 2.5 mm, you can nicely use it. But only disadvantage, if you are, suppose the tapered vessel is there, proximally it's a big vessel is there, distally the lumen is small, particularly diffusely calcified lesion, you may have to upsize the Rota. So if you are going with more than 1.75, if you are using 6 French, you may have to upsize the guide catheter. These are the disadvantages. If you don't use it properly, if you don't handle it properly, there is a chance of complications like a stuck burr, burr stall, and burr. These are less with orbital. Why? Because even if crosses the tightest lesion, you can do the backward cutting. That is the advantage with because the debris generated is very, very large compared to orbital. The slow flow, no flow less, and at the same time, the heat generation is more, thrombosis formation is more likely. So I will narrate with some cases. You can see the LAD very, very tightly stenosed. It's a calcified lesion. So the always assess with the imaging, whether use IVUS or OCT, you see the calcium expansion index and where exactly the severe calcium is there, target that lesion to be more precise and more cost effective. That is very important. So always when you do the rota or orbital, aim for achieving the fractures. You can see the very thick calcium, more than 1 mm in certain areas. You can see the very thick calcium with the proximal LAD. So that with high calcium expansion index. So after orbital atherectomy, you can see very clearly the calcium fractures and areas of dissection you can see. When you see the calcium fractures, when you see the gain in luminal area, that means you have adequately ablated. Otherwise, you have to upsize, or you can additional adjunct device like using the IVL or some other device you can, like an open NCR, additional cutting device, you have to use it. So this is the, after orbital, the advantage of this, like a single bar, crown, single crown, you can increase the ablation area by increasing the speed, and the learning curve is very, very fast, and the complication rate is very low compared to the rotablation. So this is after stenting. You can see the always document that stent expanded very well. Luminal area is good. So your edge reaction is not there, and there is no geographical miss. That is very important. So this is the final angio. See, very good luminal areas, and absolutely very good plaque modification with orbital atherectomy. You can see that there is slow flow, calcified lesion, and patient present with interval MI and LSEC thrombus, late arrival, almost 1 week duration. Then we treated with anticoagulant subsequently. You can see the proximal LAD, we ablated with orbital atherectomy. When you manage such cases, always prepare mentally yourself to have a, you are going to face the slow flow, no flow. That time you keep all inotropes and all the cocktail, whatever you wanted to inject into the coronary system. So this is the assessment after stenting, after rotablation, after orbital atherectomy. There is a nice luminal gain. So stent expansion is very good, and based upon that you can, so always take the total run. You see distally, despite using orbital, despite using the multiple devices, there is the under expansion. Many times angiogram may not show. That's the reason. You see area, distal edge is almost 2.8. The stent area, the expansion is there 70%. Then we have upside, and again it was post-dilated. Now we have proved that it expanded well with the OCT. So always the expansion is very, very important. So as have you got the max criteria fulfilled or not? Otherwise, the MACE rate is going to happen. This is a right corner. You can see very, very severely calcified, concentric, superficial, and deep calcium. You can see here, right corner is having ostial lesion, top to bottom disease from proximal to distal, and ostial right coronary you can ablate. Left main coronary also you can do with orbital atherectomy. Only thing is avoid very tight stenotic lesions. See, this is after orbital atherectomy. Proximally we did 1,20,000. Most of the time the studies recommend that avoid more than 80,000, but only if straight vessel, if it is a main left main vessel, you can go ahead with 1,20,000. So after orbital atherectomy, again, evidence of fractures and dissections. You can see nice fractures. And after that, the post, again prepared with angioscull. Most of the time nowadays we use angioscull for cutting balloon and or high pressure NCs, and prepare the bed well and expand it. And even PDA was stented. And this is the stent expansion, OCT views, 3D imaging, everything. So it's a very nice to see that stent is expanded very well, opposed very well, and without any edge dissections, these geographical miss. These are all important to provide the better long-term results. So otherwise what happens, patient, you can see the classic ostial left main disease, isolated left main lesion. Sometimes we may think it's a lipid plaque, fibrous plaque, but always evaluate the OCT. I was showed a very tight eccentric calcific lesion, eccentric calcium lesion involving the left main ostium. So what we did, then orbital atherectomy was taken, and we pushed orbital atherectomy, reverse cutting, again forward cutting, entire left main ostium was ablated with almost 1,20,000 revolutions were used. And when you use rota, always see that the alignment is proper. Suppose rota floppy you are using, you go with extra support wire to align with the otherwise what happens, it may dissect. Otherwise, sometimes if it is not allowing, you can take the angiosculp and dilate the ostium and then use the rota. That is a very useful technique. And this is the another case where you can see very classic case. The a patient underwent stenting of the LAD and LCX, but left main distal disease or LCX ostium disease and proximal diffuse disease. If you see the IVUS of the LAD and LCX, diffuse disease of the LAD as well as calcium, neoarthrosis, calcification. Then we did the orbital atherectomy. Always we assess the where different areas of the each segment you study well, where there is a tightest lesion, where the expansion index is high, there you concentrate more. And orbital atherectomy, entire LAD was done and L6 was done. You can see the movement of the, but you have to be very, very slow when you use the orbital atherectomy. 1 mm per second during forward motion and backward motion. That is very important while doing. And IVUS shows areas of calcific nodules which are less amenable to the, you can see the areas of neoarthrosis in the left circumflex. And this is the, again, angiosculp preparation of the LCX as well as the LAD. Again, we use the classic DK crush, all the steps like LAD was stented and stent extending from the LCX and crushed with all classical steps, first kissing balloon, and this is the final angiography result. So this case was attempted outside. You see the very calcified vessel, very tortuous is there. What we thought, let us try with the orbital. But in such case, never try with the orbital. It was uncrossable lesion. So you see the only proximal segment, we were repeatedly trying, but never force. If you force it, it can lead to spiral dissection, no flow, slow flow, and patient can suddenly crash. You have to be very careful while dealing such cases. So then what we did, we took 1.25 burr and ablated the entire LAD, and subsequently we took the, again repeated the orbital atherectomy. You can see the orbital atherectomy. Now it's moving very well, and distally there is a calcium nodule, and you see the entire LAD was, both rota plus orbital atherectomy was done. You see the final angiography. Nicely flowing LAD, LCX, and beautifully ablated. So effective modification of the block is very important to achieve wonderful result. You can see the LCX calcific nodule. You can see the LCX calcific nodule when severely calcified. It's very difficult to cross the lesion. So sometimes even with the difficult, even with the guideline also difficult to cross. But when there is very tight lesion is there, calcific lesion, definitely the rota is the best choice. But here we tried with orbital atherectomy, so always calcium assessment. So when you choose the device for calcium nodule, is it very tight and occupying the entire lumen, then rota works very well. Wire bias are there, rota works well. Suppose if it is a large lumen with eccentric nodule, only you have to use the orbital atherectomy. So otherwise, it may not ablate very properly. Otherwise, take the help of the wire and guide wire bias. Then this is the orbital atherectomy. Then finally, you can see very nice fractures with orbital atherectomy and shaved calcium nodule of the left circumflex ostium and left main. So there is a significant gain in the left main area. So then it was stented, kissing was done. So you can see the final view. Very well expanded stents. Left main is very good, and left main area we got 19 square mm. So sometimes we come across a very diffuse long lesion, severely calcified, uncrossable lesions. You can see the rota was done. So rota, if you see the OCT, there is a calcium nodule. When calcium nodule away from the lumen, sometimes it may not ablate well. That time you have to use the high pressure NCR. In such case, if you use the orbital, it can ablate the calcium nodule very well. So this is the final angio. That time we used, this was done about 9 years back. Even today it's absolutely fine with a long-term follow-up. So that is the reason adequate preparation of the bed makes a difference. So as of now, I have done my personal experience, 2014 rotas and IVL 128 patient, orbital atherectomy 26 patient. To conclude, the balloon uncrossed full lesions, rota is the first choice. No matter what, you can't travel unless it paves the path. So orbital is a cost effective. Why? Because one device can work for both the, suppose if the left main is bigger like a 4 and LED, distal is, middle is about 2.5. One device is enough. You can use the 80,000 distally and proximally you can go with a 120,000, 120,000. And superficial, it can act on superficial, deep, eccentric calcium nodule. Range is wide and large lumen area with eccentric nodules. It acts very well. And severe superficial cancer, any critical lesion, any tight lesion, uncrossable lesion, rota is the first choice. But if very critical uncrossable lesion, if you use the orbital atherectomy, sometimes it can move around the periphery. It can cause the spiral dissection that can lead to the problem. A majority of the patients can be performed, all the procedures can be performed to the 6 French transradial because orbital atherectomy requires 6 French compatible, whereas the rota requires, if you want to use the bigger bar, you have to go. Though you can use the slender sheath, we can do, but the tortuous anatomy there, in such cases like a bigger bar, 2 mm, you have to go with a much more bigger catheter, which is not possible. It is not as simple as balloon based, it is an art. One has to learn. You have to be very familiar with how to use. Most of the problems are because of the bad usage of, because of the poor technique and poor operator, not because of the device. It is safe as long as you handle it with care. Thank you, Vanada, for paying the attention. Thank you, Vanada.
Thank you, Dr. Sridhar, for an excellent talk. Dr. Rath, you have anything to add?
Very nicely, this orbital atherectomy spoke. I think basic difference is, orbital atherectomy is very simple, user-friendly, and it's very good in large vessel, but in tight lesions and small vessels, I think we still have to use rota. So I think this is a new tool which is not only user-friendly and less complications.
Yeah.
So I think it's a very good tool for calcific management, and we are getting more and more calcific lesions. And thank you very much for this. Ramesh, you have something?
No, I think it also needs a lot of patience, as you mentioned, Dr. Kasturi mentioned, 1 millimeter per second. So that's actually, just imagine 28 millimeters. So you go very slowly, and long lesions, you might have to spend a lot of time.
Yeah, for 1 centimeter, it's like 10 seconds.
Dr. Sridhar, we noticed that you used both rota as well as IVL in one particular case.
Yeah.
So for our younger colleagues, is there any particular situation where you would recommend
Usually
that?
when we use rota or orbital, always we take the OCT run again, particularly if the calcium thickness is more than 0.5 mm. If no evidence of fractures, luminal gain is not there, definitely the whatever balloon you are going to do, it will not expand. Always you give the additional adjunctive device, like go with IVL or bigger bar, then break it and get the luminal area, then only stent will expand.
Fantastic. I think that's a great message. We'll go to the next talk. See simply, act decisively with the latest OCT software. Dr. Jabir.
It's almost 50 years. I think it's close to half a century since the introduction of PTCA by Andreas Grunzing in 1977. It's an incredible trajectory. And now we have landed upon an era of precision PCI where imaging is crucial. Dr. Dagabati has given an excellent account of the imaging, but I was interested in his last slide and the last sentence, do not rush. That's where every operator is stuck, especially in a busy cath lab. When you have large number of cases, will you do an imaging in every case? And if you are not doing an imaging in every case, what is the reason? Though it has been proven that imaging-guided PCI gives a precision, we will be able to do a precision PCI or a perfect PCI with the imaging-guided. So OCT is an excellent tool to perform a precision PCI. Perhaps it gives a better shorter and long-term outcome There was a discussion here also, whether there is real data which shows that it improves the long-term outcome. Right now, we don't have a conclusive data, but there are signals which shows that it will improve outcome. Logically, because of the statistical issue, we may not get a positive data because right now the post-PCI event rates are very low. And hence the comparison will be difficult to get a statistical difference. We need a large sample size. But there is every signal that if you do a better job, the result and the outcome should be better. So this is the OCT workflow, which is accepted worldwide. That is the MLD Max. And this OCT workflow is there right now with all the softwares we are using. And now Abbott is introducing the new software, the Ultron 2, on which I am talking. So what is the reason for the operator not picking up in imaging? Maybe in India, the most important thing is the cost. But in tier 3 cities, in major cath labs, there is provision for imaging in all cases. But even then, the operator may not use it in every case because he thinks that it's too long. It's not possible for me to do every case with a PCR imaging, because sometimes it is cumbersome. It may take a long time. And also for beginners, the expertise or interpretation skills are also important. So the Ultron 2 software, this is MLD Max compatible. 2 phases of it. The first one is the preparatory phase, where you are strategizing. You look at the morphology, you look at the sizing, and the length and diameter of the stent. Right now, we have to manually do it. Look for the calcium. The previous 2 speakers were dealing with the calcium, and Dr. Sridhar Kasturi was telling about the calcium. But before strategizing or before deciding what is the exact strategy for the calcium modification, we need to know what type of calcium it is. Is it only a superficial calcium? Is it a deep calcium? It's a mixture of superficial and deep calcium. Is it a balloon strategy? Is it an ablative strategy? Or is it a combination strategy? So it all can be decided based on the morphology of calcium. So this software immediately gives, without our assessment, the AI can give what is the depth of the calcium, the arc of the calcium, the thickness of the calcium, and the length of the calcium. And it can measure and tell us what is the length of the stent you need, what is the diameter of the stent you need. And once you put in the stent, you look for the review, where it is the max, the medial dissection, apposition, and the expansion. That also the AI can automatically tell you. So the morphology, length, and the diameter, that is the MLD. In the currently available system, the AptiView in many places, large majority of the softwares are Aptiv, and the Optron 1 is available in some of the places in India. You can see you measure it, you look for the morphology, you measure the length, you measure the diameter. It takes at least 2 minutes. This is for this is for an experienced operator. It takes at least 2 minutes or 1.5 minutes, and for a newcomer, it may take more time, and it all depends upon the technician or the team you are associated with. But if you have the AI mediated, the new Aptreon system, it takes hardly 25 seconds. Immediately it gives. You can see the orange thing that is rotating around. So this orange is the calcium. So it can give the arc of the calcium. And in the longitudinal view, you can see the orange spots that indicates the calcium. And the white arrow, you can see some at places the white arrow comes, that tells us what is the depth or the thickness of the calcium, where is the thickness maximum. And in the lower panel, you see the white dots. You can see the white dots. That white dots tells where exactly is the EL. If the white dot arc is more than 180 degrees, that means a good amount of IVL you can visualize, or you can assess the IVL, and you can find out the excellent or the optimal landing zones for the proximal and the distal part of the stent. Hardly take 25 seconds. So you can really rush. So the morphology, length, and the diameter, the AI-enabled calcium detection can tell all these things. So this helps to determine the vessel preparation strategy within a short span of time. And it also gives us the optimal stent size, the optimal stent landing zone. We have two modes. One is the guided mode and the flexible mode. The guided mode is for a beginner. The guided mode systematically takes you through the entire MLD, and in the second half, after the stent placement, to the max. And for an experienced operator, you have the flexible mode, where one is the preparation, and the second one is the review mode. The first one is for taking the decision regarding the strategy of stent placement, the strategy of calcium management, the vessel preparation and all. The second one is look at the stent, how it is placed, whether further optimization is needed or not. And the Optrion 2 is equipped with a 3D bifurcation view, which was not there in the Optrion 1. Another new addition is the flexible mode, which has a dynamic angio-synchronization. You have the angio coregistration along with the live angios also side by side. So this also gives a lot of flexibility and a lot of visual synchronization with the images and the angiography which your eyes are more tuned with for the operator. And the flexible mode review, you can see the stent is placed. Here the color coding has changed from the previous one. The orange tells us the expansion. So if it is, that all depends upon what expansion limit you have set in the machine. If it is 90%, if it is anywhere there is less than 90% expansion, it will show the orange spot. You can see here the minimal expansion was 76%, and you can find out the spot where there is the least expansion. If the expansion is more than 90% throughout the standard segment, there won't be any orange spot. And if there is a apposition problem, if there is a malapposition, depending upon the threshold you have kept, if it is 400, anywhere there is more than 400 micron meter malapposition, it will show an orange point. It will show an yellow spot. And the 3D bifurcation view, you can see that there is a difference. You can see it's a distal cross, but it is reverse than that in the Aptiv software we are using. The proximal is on the left side, and the distal is on the right side, just opposite to that what we are using right now. That, I think, is the only one which we have to get acquainted with, because we are used to the previous view. The 3D bifurcation view can get side by side, the stent without the wire and the vessel, and the stent with the wire in, and also the angiography at that particular point. Then checking the expansion, I've already mentioned about checking the expansion. And you can see the yellow spots. Yellow spots here indicates malapposed area. So it all depends. Here the apposition limit was 300 micron meter. So the areas where there is more than 300 micrometer malapposition, it shows the yellow spots. And those which is the area where it is set above the set threshold is shown in the yellow. So what are the differences between the current Aptiv software and the Ultrion software? The apposition is highlighted in the yellow, the struts only in the expanded lumen profile. The rendered views, the rendered stent is not there in the new software. You have the lumen profile only. And the expansion options, you can see the plaque modification depends upon the calcium that is well detected by the AI, and the exact information what we needed is given in 25 seconds time. The fly-through is available, 3D bifurcation is available, and the coregistration is there. You'll have the minimal stent area. You'll have the one problem is the stent patterns cannot be recognized. The currently available system, and a seasoned operator can tell exactly which stent is put. If whatever stents he has been regularly putting, you can find out which company's stent is that. That is not possible in the new software. And the orientation is different. The proximal will be left and the distal will be right. That is totally different from the current system. And the automatic EEL detection, which is quite useful for the operator, and the lumen diameter values also can be there. So this is one OCT-guided PCI in a calcified lesion, the angiography after rotablation, then after the stent optimization. Angiographically, the excellent result. So to get this result, we needed the OCT-guided PCI. And you can see the OCT which is the pre-procedural OCT where we do all the planning. What is the calcium? How much calcium? Is it a deep calcium? Is it a superficial calcium? What is the length and arc of the calcium, and what is the depth of the calcium? Where, in which area you can see the EL well, where should be the proximal landing zone, where should be the distal landing zone, so what is the total stent length required. All these can be made out even now, but it takes a long time. You can see that it may take at least 1.5 minutes for all these measurements. So you can see how cumbersome it is and why in a busy lab, many operators sometimes, when they are too busy, when there is time constraint, they avoid doing an OCT-guided PCI. So you have to move the cursor, put it in the area where this maximum, the maximum diameter stenosis, find out the area where the EL is well visible, and then decide on the landing zone, then the stent length. You can see we are trying to calculate the stent length, try to find out the area where the landing zone should be an optimal landing zone. So all these things are, even now it's calculable, but it takes a long time. And this is the post-PCI. The post-PCI optimization. Here, the color coding is different. You can see the entire stent area, which is white. Had there been any malapposition, it would have been red. Areas of malapposition will be red. Right now, in the current system, we don't have any color coding for the expansion index or the expansion. So under expansion, you have to make it visually, but no color coding. So there is no guidance for it. Here also, you have to look at the expansion by using the standard usage with the Illumin 4 criteria. So this also is taking time. But if you go with this Aptrion, you can see quickly, within a fraction of maybe around 20 seconds, this is the post-PCI, it gives the entire thing. You can see some amount of orange spot. That orange spot in the luminal, that is the longitudinal view. That orange spot means some area of under expansion, and that under expansion is 81%. 81% is acceptable, but 90% will be a better thing. And you can see the yellow spots. There is a massive malapposition in the left main. So this is in a much faster way. Actually, the machine is, in fact, rushing. But we get the actual data, whatever data we require. So imaging seems to be an excellent tool for a precision PCI. There are certain factors which prevents the operator from doing PCI, and these limitations can be minimized with the use of the new Aptrion software. So these are the final questions I may ask myself. Are you really impressed with the Ultrion 2? I'm impressed with the Ultrion 2, sorry. Will it help to do more OCT-guided PCI? It should, because the time constraints when be taken away, it's easy, and sometimes the interpretation is maybe much better than a human interpretation. AI can do a better job in some cases. Will this application improve the patient care? If we can provide more precision PCI, it must improve the outcome. And will it be of a real help to a beginner in OCT? It must be a real help to a beginner in OCT. Thank you. Thank you for your patient listening.
What? You have not shown the newer version of OCT, the pre-imaging. Post only you have shown.
The pre-imaging is there. Somehow I am not able to hold it whenever I
Yeah, but it's excellent. It's a very nice presentation, and you really come out the differences, and it's very impressive. Very, very good presentation.
Thank you. Thank you, Dr.
Thank you. I think in view of time, we'll go to the next talk by Dr. Ajay Swami, who's the moderator. Role of FFR and RFR in bifurcation left main lesion.
So before I begin, again, my salutations to my teachers, some of whom are in the audience and some of whom are not. This is going to be a most deglamorized presentation after the previous beautiful images that you have seen. But it's a little bit more practical. LMPCI, what role for physiology? These are my disclosures. We know that the angiogram is not always very accurate when we look at severity. And we know that FFR relates very well to long-term outcome as far as adverse cardiovascular events are concerned. We know that FFR-guided PCI gives better outcome. That is, if we use FFR to decide whether we need to or we do not need to address ischemic burden in this particular patient. And the concept of FFR-guided revasc is based on well-structured and consistent randomized controlled trial-derived evidence and firm clinical outcome data. Now let's look at some post-PCI FFR. Let's look at some cases. This is a 78-year-old female, non-diabetic, hypertensive dyslipidemia with crescendo angina for 4 weeks. She was all of 38 kgs in weight and 150 centimeters in height. This is what her angiogram was like. I'll just allow it to play out. This is just the left system that you can see. You can see a heavily calcified left main bifurcation with disease in the proximal, left anterior descending and the circumflex, as well as the circumflex and the left main, and this is what the RCA injection is like. So we had a discussion, and both the surgeon and the patient didn't want to look at each other because the surgeon said she's too small and the patient said the surgeon is too big, the procedure is too big. So she was sent to us for a staged procedure. First we did the RCA. It was heavily calcified, proximal to distal, diffuse, eccentric. This is a rota plus a cutting balloon and an OPN. And you can see where we've used, this is a cutting balloon followed by a stent, followed by an OPN to get good expansion. And that's what the RCA was like. So we've got good distal targets, but there's a lot of calcium in the proximal part, and we did rotablation to the LED. I've left the LCX wiring on purpose to show you how difficult and how tortuous this was. And the microcatheter wouldn't follow the wire, even once we had got the wire down. So we had to do a small balloon, then put the microcatheter, then put in the rota. The wire was stuck here, so we did it in bursts of 10 millimeters each. And finally, we were able to get the rotablation burr down all the way down to the distal circumflex. Thereafter, an OPN was used to open up the proximal segments, and a decay crush was done after a cutting balloon for the circumflex. This is our decay crush. I'm not going through all the steps. This is not part of what we want to show. And this is the first part, the KISS, the second part. This is our final result. Now, this is when we start doing our work. A post-PCI physiology is done, an FFR and RFR to the LED, 0.95 and an RFR of 0.95 with a pullback, which is not at all unsatisfactory to the LED. And the circumflex RFR is 1 with an FFR of 0.97 in the circumflex. The second case, a 72-year-old class 3, CCS class 3 angina, angiogram done outside, advised PTCA to the mid-RCA and to the LED. And this is what the left disease is like. You can see a mid-LED eccentric tubular lesion and some doubtful lesion in the proximal LED, which we really aren't able to make out. So the RCA was fixed, and then after that, the left was worked on. So the plan was to do a mid-LED PCI and then reevaluate the osteo LED. That's what was done. This is the mid-LED being done. We'll not go through all the steps. I'm just quickly trying to go through so that we have some time for discussion at the end. This is a provisional, and a KISS pot is done for the LED and the diagonal. Now, what about the osteo LED? So we float in an FFR wire, and you see the RFR straight off baseline is 0.78. Now, is this because of that osteo LED lesion or it's somewhere distal? So we then do an RFR pullback. And what do you find? You find that all the step up is actually at the osteo LED. So then the significant stenosis of the osteo LED and LM LED is done with a provisional strategy, and then we'll remeasure the physiology. That's what is done. We do a nice LM LED crossover stent, do a proper pot with an LM, do a pot, KISS, and a repot, and then do a post-PCI FFR and RFR, and we get a 0.91 in the LED and an RFR of 9.7. Remember, this was 7.8 in the beginning. This is what our final angiogram was like, and she's absolutely fine, angina-free at the end. This is the third case, a 72-year-old lady, again, class 3 effort angina. She's got an ostial LED disease, and the disease seems to be extending into the mid-LED as well. There's some distal LED disease, but nobody's going to touch that. It's about 50-60% with a bend, so it can most likely be left alone. The LED is pre-dilated, cut with a cutting balloon. There's some calcium there, but we get good expansion, so we decide not to do anything further. A stent is placed, and then a pot is done. And this is what the angiogram is after the pot. The ostial circumflex looks a little hazy. Lots of people will say, let's leave it alone. We don't need to do anything. Patient is fine. There's no dissection. It's flowing TIMI3. But we decided to do a physiology. and you find that the RFR is 0.85 at the ostial circumflex, and the pullback, as you see the arrow, is just at the ostial circumflex. So a pot kiss and a repot is done, and then we measure the RFR back again, and you get a 9.8 and a 9.92 measurements. And then we also remeasure the LED because we have disturbed the stent in the LED. So we want to know whether the LED has been given a good enough result, and that's what happens. We find that the FFR to the LED is 0.97. This is our final angiogram. This is another case. This is just to show you that this benefit is not restricted to chronic stable angina alone. This is a 62-year-old patient, dyslipidemic hypertensive, comes with an anterowall MI with post-MI angina, day 1 Phillips class 2. He's got ongoing chest discomfort, and we can all see that there is a subtotal occlusion in the mid-LED with a large diagonal coming off, and he undergoes a fairly straightforward angioplasty to that segment. A nice post-dilatation is done. This is the result. And if you noticed in the initial angiogram, there was also some doubtful disease in the circumflex. If we can get this to play, right. So this patient was part of a study that we were doing in which we had a hypothesis that we were undersizing the stents when we did them in the primary, and we would bring them back to the table whenever they had an intermediate lesion in the other vessels. We didn't measure physiology at the acute situation because we weren't sure whether it was reliable. So we'd bring them back to the table, do an imaging to see whether we've appropriately sized the stent in the infarct-related vessel, and measure the physiology in the other vessels to see what kind of a result we got. So he was brought back to the table after about a week for an OCT assessment for the size of the LED. This is what it looks like. First, the OM, FFR and RFR to the OM were done, which were negative. As expected, it looks like a 60% lesion. We measured both because this was part of our study. Since we had the wire, we floated it down the LED, and we found that this RFR was positive, right? Now, FFR, immediately after a week after MI, you'd scratch your head and say, maybe not great, but a resting physiology sometimes throws up surprises. And when we did a putback, we found that the pullback was actually at the edge of the stent. So we went ahead and did an OCT, and you'll see when we run this OCT that there is a significant edge dissection where the previous stent had been placed. And I'm just going to run that repeatedly, and you can see that. This is what we got, a circumferential dissection at the distal edge of the stent. So we measured the landing zone, put in another stent, distal to the first stent, and then did an RFR again, and this time it's 9.7. And this is the FFR post first stent. This was also part of our study, was 9.2. And this is the OCT after the second stent has been placed, which looks absolutely fine. This is perfect. There's no problem at all, no edge dissection. We've got good expansion, etc., etc. This is our final angiographic result. Now, post-PCI FFR is one of the most underutilized tools in the cath lab. This is an old study from the bare metal stent era, and it shows us that the restenosis frequency, in those days, target vessel revascularization was measured 6 months after follow-up. When the FFR was 0.75 to 0.8 post-stenting was 29.5%. And when it was more than 0.96, restenosis frequency was 4.9. And this shows you the power of physiology in estimating whether we have done a good job in the vessels in which we are intervening or not. Post-PCI and FFR and prognosis, they are directly related to long-term events, as has been shown from large data. If you divide them into quartiles, patients who have the lowest post-PCI FFR consistently show a worse outcome. This is registry-based data, but what about interventional data? Prophet FFR was a study presented in EuroPCR 2022, wherein they looked at 1,300 patients approximately, divided them into 3 groups. One control, one group 1 who had at least one lesion with an angio-guided PCI, and a second group who had a post-PCI assessment that was driven by FFR, guided by FFR. And they looked at the second group, post-PCI improvement in FFR post-PCI. 12% required a further optimization based on the post-PCI FFR. And this group had a significant difference as far as target vessel revascularization is concerned and target vessel failure was concerned. This was reduced in the physiologically guided group versus the angio-guided group, almost halved. And there was no significant difference in MI and death, but target vessel revasc was half the rate when we used post-PCI FFR. Thus, it's an excellent marker of adequate relief of ischemia. The residual FFR is related to outcomes in several studies. This is possibly a stronger outcome than imaging, but it needs a little validation. The quality of the data is excellent, and that's what we're going to try to do. In summary, physiology today is meant for diagnosis, to rule in ischemia. Do we need to do the lesion or do we need to defer it? We have excellent data to suggest that we have the best answer to this question with physiology. Do we need to do more? The side branch FFR often tells us whether we have an ischemic burden in that area, not an atheroma burden, but an ischemic burden, which is absolutely well validated as an outcome measure. Now, have we done a complete job? The post-PCI FFR and RFR are powerful tools to answer this question. We are doing a small study called Pulmaris, in which all left main bifurcation angioplasties are subjected to post-PCI FFR into both. We're going to follow up and report. Watch this space. Next year, we'll have something for you. Thank you for your attention, and I've left some time for discussion if there are any questions to be answered.
Fantastic talk, Dr. Jeswami. What do you think of the barriers? Is it the wire that makes us not use post-PCI FFR because it gets damaged? And do you work on the wire, or do you exchange that wire for a workhorse wire and use it again? What would your recommendations be?
No, I think the barrier is more in the mind. The quality of the wire available now is absolutely amenable to being used in all segments of the coronary, even after the stent has been placed. The fear that the wire is going to cause a dissection is mostly artificial, unless we are dealing with a diffuse disease downstream, in which case the FFR is not a great idea in any case, because you're not going to really look at the distal circulation if you have got a distal lesion beyond where your stent has landed. I think the barrier is in the mind. Even with all the data that we have, people are not using FFR in intermediate lesions more than 10% of the time in places where it's not mandated. I know there are some geographies in the world wherein you cannot perform an intermediate lesion angioplasty unless it is proven to be ischemic by an invasive, that means an FFR measure, or by a non-invasive, that means by some kind of functional testing, which I think is the way forward. But in places where this is not mandated, cardiologists worldwide, practice worldwide has not met up to the standard that we are supposed to document the presence of ischemia before we address it. Once we cross that barrier, the next barrier is, are we doing a good enough job? And I think FFR physiology offers a great way to answer that question.
Yeah, thank you.
I think for the last question we asked, Illumin 5 sub-study, target visual failure was no difference. But here, the target visual failure also is a difference. So
It's
probably
half.
FFR is a better than
half.
IVUS and OCT because we already have a data. So still, FFR is not used.
Yeah, definitely. I think one of my issues had been always the wire gets a little bit more damaged in using it, you know. So, but
No,
definitely second wire will cost us more, you know.
Yeah, so you mean using the FFR wire for the procedure itself?
Yes, yeah.
So that was really a concern with the earlier generation of wires. The new generation of wires, it can still be used, but for the sake of our study, we are not using the FFR for the intervention. We are floating the FFR wire at the end of the procedure after having finished it to say that we have done a complete job.
Yeah. No, I mean, but truly, as you said, FFR definitely has much higher value. And there's no question about it post-PCI. And we recommend using that.
I just want to know the cost of FFR versus OCT in US.
So
Same?
$675 roughly for all.
Oh, for all?
Yeah.
For FFR also?
Yeah.
Oh, but in India, the cost is huge. It's a 3 times. Imaging is 2 times, IVUS is 2 times, OCT is 3 to 4 times when compared to FFR.
Yeah, it's the same. Thank you very much, Dr. Jeswami. And we conclude this session. Fantastic talks by everyone. Thank you.
सब मजा कर रहे हैं आप
History is proof that great partnerships have sparked innovation and driven progress. Larry Page and Sergey Brin brought the internet to our fingertips. Leander Paes and Mahesh Bhupathi elevated India to global prominence in the world of tennis. James Watson and Francis Crick illuminated the structure of life. Together, the heart team of cardiac surgeons and cardiologists have brought brighter outcomes and results to patients. Cardiovascular Research Foundation, USA, and FACTS Foundation have forged an incredibly successful partnership in interventional cardiovascular medicine. This decade-long synergetic collaboration
Yeah, hope you like that video. We are just doing the stage arrangements. Another 2 minutes, we'll start the inaugural function, and then we'll have a good cultural program too. Then after the inaugural function, the doctors can have some time to interact with Marty, Alex, and other CRF staff here. So I request you all to become comfortable. All those who are standing outside can come inside and sit, please. There are a lot of chairs in the front. And there'll be some interesting thing which for you to watch with Marty around. So I request all of you to become yourself comfortable, please. We'll start in just 2 minutes. Good evening, everybody. Welcome to this year's edition of TCT Plus India. And since morning, all of you have enjoyed the discussions, and everybody has appreciated the lectures and the live cases. We have interesting cases and lectures. And this year, we also started this deep dive session, which were practical demonstration of the RotaPro orbital atherectomy techniques involved, are all demonstrated, highly appreciated. Thank you all for joining, and then we expect more number of 1,200 plus registrations happened. I think there are more to join on Saturday. And we're very fortunate this year to have, it was my wish and desire to have Dr. Martin Million here in person. I'm very thankful to you, sir, for joining here. And then for making this possible to all of us, and should be extremely thankful to Dr. Sushil Kodali and Dr. Ajay Kirtane, who is the link between FACTS Foundation in India and the Cardiovascular Research Foundation. And again, extreme thankful to all the colleagues across the country who wish and participate in this meeting with a lot of enthusiasm. So now I request Sushil to come over, and we'll also start with we'll welcome all the dignitaries onto the dais now. We request Dr. Martin Villion to come over to the dais, and Sushil will escort him onto the stage. Dr. Ajay Kirtane, Dr. Van Ganada, welcome, madam. We request our Joint Managing Director, Apollo Hospitals, Sangeeta madam, to join onto the dais. Always great, enthusiastic supporter for any of the activities which we do. Thank you very much, madam. Please join. As you all understand, in India, it's customary for us to start any program, though we start in the morning, but we generally do inauguration in the evening. We start with lighting of the lamp. Request Dr. Marty and then Sangeeta madam, all others to join, and the lighting of the program. Can you have music and get there? We'll all light the lamp. Our Fax Foundation in India, that Sushil and we do it together. So I request Sushil to say a few words of welcoming to all of you. Then on CRF side, Juan will speak. Sushil.
Thanks, Srinivas, and thanks everyone. I know it's a long day, and there was a lot of people in the room today and great engagement, and it's really quite exciting. This has been more than 10 years that on and off that we've done some version of this meeting, and it's really enjoyable. I think a lot of it is the two-way exchange of ideas, information. I learn so much every time I come. I mean, the cases that are done here, the techniques, and sort of the engagement from everyone is really what makes this really enjoyable. There's obviously always challenges to running meetings, but the most important thing is to have the fundamental goal is critical. It's a transfer of knowledge. It's critical thought process, and sort of teaching all of us to how to think critically and make the right decision for our patients. And I think people's willingness to participate and engage is really what's key. But one of the, from me, Ajay, and others coming from New York and other places in the U.S. and all the international faculty we had, it's really quite. It's an important part of what we do. Being from Andhra and being from this region, it's really an important. It's really important to me to come back here, and it means a lot to me that my colleagues are participating, that you're participating, and really the CRF really helping us to come and participate in this meeting has been an important component, right? There's so much knowledge at CRF, and the fundamental goal of CRF is education, and not just in the U.S. but globally. And having Juan and the entire CRF team being here and participating and being engaged has been important to help grow the mission of education. And I want to thank Juan for coming, and I want to thank him for all of his engagement and his team's engagement. I'd like him to say a few words and on behalf of CRF and all of that. So thank you.
Thank you, Sushil, and I promise I'm going to be brief. First of all, thank you for allowing us to participate in such a beautiful ceremony. Let's actually give a round of applause to all the organizers, because we know how difficult it is to organize a meeting like this, and today was an outstanding beginning of this meeting. On behalf of CRF, all my colleagues, and all the faculty coming from the U.S., I really want to say, thank you. This is a collaboration that has been going on for over a decade, right? And initially started with the FACS Foundation. Then we started to support the meeting as TCT India. And this year we started a special program that we call TCT Plus. And this is an initiative that we have to support our international meetings in using a very hands-on but collaborative approach. And we opened TCT India for the first time in Saudi Arabia in January. And this year is not actually the first time in India. It's perhaps 11th or 12th time that we do it. But this is actually the inaugural version of what we call TCT India, which actually aims to identify emerging faculty, to support the region, and to support all the academic and research efforts that you may have. So thank you again for all your support, your friendship, for allowing us to be here with you. And you know that you actually have a very good group of friends with CRF, and you can reach out to us in case you actually need anything in the future. We hope to see you, again, obviously the rest of the meeting, but in multiple years ahead of us. Thank you again.
We always wish to hear some words of wisdom from Dr. Martin Leon. So we request him to say a few words of wisdom and advice to youngsters and regarding our collaboration too. You can sit. Come. You want to come here?
Srinivas, thank you so much. I must tell you, it's a little bit emotional coming back to TCT India. Yes, it's been more than a decade, and I have to give so much credit to Sushil Kodali and to Srinivas Kumar for their efforts in putting this together. So we really should thank them, because I know how much work it takes to be able to deliver a meeting of this caliber. So I just want to thank them personally and sincerely. I also want to say that I know Srinivas has been asking me each year, please, can you come in person? There have been a variety of circumstances that made that more difficult. But for me, I had a dual purpose for wanting to come this year to TCT Plus India. As Juan said, this was an inaugural beginning of a new form of the meeting that would bring, at least we hope, even more physician training, more collaboration, and be able to bring both CRF and TCT closer together as partners as we adventure into the future of where intervention is going to be. So I wanted to participate in that activity. I have so many friends in India, and I've only appreciated over the past several days how important it is to maintain those friendships in person, by expressing your appreciation for the collaboration. The second reason why I wanted to come was, I must tell you that I've been to India many times, but my wife has never been to India. And she has always wanted to go to India. So I felt very strongly that this opportunity was critical. So we had the extraordinary experience to visit Agra and the Taj. We were in Delhi, we were in Surat, and by virtue of some magic, we suddenly got here on time for this opening session in Hyderabad, which for me is a very familiar and important place. So I want to thank Linda for encouraging me to come this year. I think during this time, we may have helped to enrich the economy of India in a variety of ways, which we're also excited about. We founded TCT more than 35 years ago. And it was not ambitious. It was very humble. And I think the humility of the effort continues, even though it may appear to be more grandiose. And we founded this meeting for a variety of reasons. But I tell you that not being here personally at TCT India, for me, has been frustrating. I haven't been here in more than a half decade, and during that period of time, we've all, in our personal ways, have experienced the pandemic. During that period of time, the population of India now has surpassed China and is now the most populous country in the world. During that period of time, there are now more PCIs done in India than in the United States. And during that period of time, I think we've seen the emergence of some extraordinary leadership within the India community of interventionalists from the standpoint of expertise, commitment to academic excellence, and we're seeing this rise of a new community of leadership that adds to the already existing very senior leadership that we've enjoyed working with in the past. The principles of TCT have not changed from the very beginning. We believe strongly that we need to provide an educational platform. Part of that education is expressed through live cases or pre-recorded cases to learn from those experiences. We believe that more so now than before, even, that hands-on training is critical in order to gain the experiences for operators to have confidence, to develop more advanced skills, to provide better care for their patients. We believe strongly in the academic mission, and that is largely expressed in evidence-based medicine. So we'd like to discuss clinical research. We'd like to argue about what would be the best therapy for our patients. And we do it in a reasonably narrative and informal way, but I think it educates all of us. We believe very strongly in this concept of innovation. So we do our best to portray everything that's new and different. Sometimes it may work, sometimes not, but still it makes us think. It helps us to be creative. And that innovation piece of TCT, I think, has always been important. And finally, we believe in this concept of a global, multidisciplinary collaboration that brings us all together. Only by having people that think differently, that think out of the box, that get out of their sweet spot and do things differently, do you learn, do you grow, do you become better at what you do? And that's never better expressed than when you go to different parts of the world where things may be different for a variety of reasons, socioeconomic reasons, geographic reasons, cultural reasons. So we learn from that experience, and we really do enjoy the notion that TCT can have this global imprint and we could be expressing it in different ways. So for me to see TCT plus the India version of it is very powerful, because I see that you really have embraced the original concept of what TCT is. So we hope that you're going to have a successful 2 days, that you'll come away feeling invigorated, excited. You'll learn something, you'll make new friendships, you'll network more effectively, you'll become better at what you do in the interest of treating your patients better and advancing the field. So I'm delighted to be here, and we'll do our best to continue to be good partners this year and in all years in the future. So thank you very much.
Thank you, Dr. Matilian, for the words of advice and support and encouragement which is always rendered to Indian fraternity. And more good things will come, be it in form of research, collaboration, for training for youngsters, many other things to follow. Thank you. And now we request our Sangeeta Madam, Managing Director of Apollo Hospitals, to come and address the gathering. She was very busy, had many other commitments, but still I requested her to be here with a few minutes. Thank you, Madam.
Good evening and namaste. What a pleasure it is to be amongst all of you and to see the energy and a lot of the admiration still patent in the room after a very long day. Professor Leon, Professor Vyon, definitely Dr. Kodali, who's guiding hand through the many years of putting this together. And of course, Dr. Srinivas Kumar, who has held this together for so many years with a great passion, but also Dr. Venkatram, Dr. Rath, and every single one of you in the audience. Let me specially acknowledge each one of you and say that your presence here is a testimony to your dedication to bringing the best care to patients. And therefore, in that journey, I wish you the very best and commit on behalf of our organization to do whatever we can to be with you. I must begin by telling Dr. Leon that one of the highlights of his speech was, of course, acknowledging how nice it was to bring Mrs. Leon to India. And I think that when you do that, you transform this from a great medical education program to bonds of family friendship that will continue to tie you stronger and stronger, and therefore I truly appreciate, I welcome, and I hope you've had a wonderful time. I think in the field of cardiothoracic surgery and interventional cardiology, all of us are very clear of the non-communicable disease. Cardiac is still the #1 killer. As technology grows and evolves, as all of you have become, as cardiologists, more and more invasive, and your cardiothoracic surgeons responded by becoming minimally invasive, and we just kept on evolving. And yet, it remains the #1 killer. It contributes to 28% of all deaths in India. And the fact is that there are so many methodologies, technologies, treatments, lifestyle behavior modifications, early warning symptoms that could bring down these numbers. So it is important for us to continue to strive and pursue an altogether, as beautifully said, multidisciplinary innovation lens towards keeping people healthy and happy, towards preventing heart disease, towards minimizing, reducing, or completely eliminating premature deaths due to cardiac problems. We've seen it very often. It is the reason that Apollo Hospitals began, for those of you who do not know, that Dr. Reddy, who was a practicing cardiologist, used to refer his patients to Dr. Denton Cooley. One day he lost a young man before they had enough time to get their visa to go to the US and to raise $100,000 required for that treatment. That day he committed that we must find a way to bring the global talent, create the infrastructure, and cure people in India itself. That was 1983, many, many years ago, many decades ago. And today, you know, almost 73 hospitals, over 300,000 angioplasty procedures, millions of patients. But whatever are the numbers, our clinics, our pharmacies, our procedures, the cath labs, whatever it is, I think the energy and the momentum and the commitment to stay young, to stay innovative, and to continue to pursue this beautiful thing called life, and say life is precious, it means something to a family. So everything that you can do to save that life and to keep that life in its fullest form is truly what all of you are dedicated to. I also do want to say that so much of our thought process on technology has been towards more and more treatments. So whether it was the quality of the lens, the beauty of the picture, the speed of when you moved to bipolar and then you went in more and more invasively. In parallel, the biochemical aspect or the medication aspect continued to grow. But one of the beautiful things about physicians, rather than just the manufacturers or etc., is the fact that the education and the learning aspect continues to be paramount in your mind. And for that, I especially congratulate every doctor who has committed himself to share the knowledge that he has. And in this regard and at this point, please give yourselves a very, very big hand. The Indian government has just finished their budget proclamation. And of the 7 major pillars, one of the most important pillars was education and skilling. And one of the drivers of that is the fact that number 1, we need more healthcare workers. Number 2, technology is expanding. Number 3, there's a global shortage. And number 4, that unless we're able to teach, we will continue to have a gap between the science that we know and the medicine that is practiced. So in the pursuit of reducing that gap, whether it's education, innovation, more technology, artificial intelligence, robotics, yesterday we were doing a beautiful discussion on the combination of virtual reality in a learning mode, AI, and then a training platform. So can we enhance or reduce the learning curve and enhance the pace of adoption of some of the latest technologies, because we are transforming the teaching methodologies. And in the pursuit of all that, I think it was about 10 days ago that we had a very special day in India. You acknowledged the lighting of the lamp, but we had a day called Guru Purnima, which is on this full moon day, we revere our teachers. And so the combination of bringing the greatest teachers. In today's conference, you probably have 300, 400 people. Imagine if you're online, and you probably are online, so you change that number to 1,000, 2,000 teachers. But imagine if we recorded this and then put AI in it and brought AI just in time at the point of decision making, so that a larger number of people benefited the knowledge that all of you have in this room. So I'm just bringing this not because you do not know it, because you all know this, you know more. And you are following what I think is the most powerful idiom, and that is the best way to predict the future is to create it. So I wanted to acknowledge the fact that through your work, you are creating the future of a healthier population. You are creating the future of more skilled clinicians. And in that pursuit of creating this future, I once again dedicate Apollo Hospital's time, energy, resources, and anything that we need. And I congratulate Dr. Srinivas Kumar for your continued commitment to this, and all your other colleagues. I see Dr. Rath here, I'm sure there are many others. All the other colleagues from Apollo and across the country and across the world. I congratulate you for your commitment. I thank you for this opportunity to share some time, because every time that we are together, we get more committed to doing more for the medical fraternity. And in sports, as the Olympics begin, people celebrate the excellence, the achievement, and it's number 1, 2, 3 who are celebrated. It is the beauty of medicine and science that everyone who cares is celebrated. And whether they're celebrated on a platform like this, let me be very clear to all of you, you are celebrated in the patient and the family members' hearts. And that is truly the biggest acknowledgement that humanity can give you. So thank you all for your greatness. Namaste.
Thank you, madam, for the respect. You have a pleasant duty on behalf of all Indians and Apollo hospitals. We request Sangeeta madam to felicitate Dr. Mati. And this occasion, as Dr. Martilian said, we also have Madam Linda, Madam Leon, please come onto the dais. And it's a pleasant duty to felicitate you both. And then, please come. Yeah.
To the members of the media, we were planning to have an interactive session with Professor Leon. Because of the busy day, I think that was not possible. But please do send your questions, because I received many. Why are younger people getting heart disease? What was the role that COVID played? What is TCT? Is this the better methodology? WHO is stated to have said that the life expectancy has gone up in that critical category 25% because of this procedure. But public wants to know these things. So if you have a series of questions, please feel free, and we will ensure that a panel responds to them and that we get Dr. Martin Leon's feedback, because it's important for general public to understand the science and utilize the skill set and the capability. Thank you.
Thank you, madam. And I think now coming to the end of the inaugural function, it's my pleasant duty to thank all of those involved. As already said, CRF has been a great support of Martin Leon, Vanganada, Ajay, Sushi, and but more than anything, Apollo Hospitals management, Sangeeta madam and others, and my other fellow colleagues, Dr. Rath, Dr. Gokul Reddy, and all others. Been great. We are doing this meeting because my colleagues takes help and responsibility. The heart team approach we truly follow. That's how we are able to do all this together. And we're extremely thankful to all the CRF faculty. And this year I should especially also thank Dr. Sanjog Kalra. He's here, I think, for taking special interest and designing the program. A lot of tough hours, long hours he has spent. The deep dive sessions again were coming through his brainchild. And Ajay's association with Sanjog made it possible. Thankful to us and all other colleagues from abroad. And some of them, like I don't know whether Indians or in US, like Ramesh, and many of them will be a great help. And I can't go on taking names because a lot of time it takes. And all the sponsors, and like I call them as academic partners, because they help us in mobilizing support, not only financially, but getting the meeting across to all people, and get the colleagues across. And finally, thanking all the colleagues across the country who participate in this meeting with lots of enthusiasm. I'm not a very great or senior cardiologist, but still all your enthusiasm gives a lot of support and encouragement for me to conduct such many more programs. And I'm extremely thankful finally for ongoing support of Dr. Martin Leon at this age and the commitment he has still. We should all youngsters should learn, I feel. And it's a great motivation for all of us. So thank you again for your ongoing friendship. And with this, I think we can now close this inaugural function. And as Madam has to leave, she will go. But we will have another interesting thing to be presented to Dr. Martin Leon. So I request them to come off the dais, and you can sit there and watch. I think they're just setting up, sir. It will be better visible if you sit there in front of the chair. You'll be able to watch the screen better. Hope you like it. Hope all of you are able to see the screen better. I request all of you to please sit because you will really enjoy this. Hope Dr. Marty also likes this. They thought to do something different. First, I don't know whether he remembers when he came initially, we did through laser. Now, he's an incredible man, Mr. Kant. He does a lot of good things in sand. So we thought we would describe Dr. Leon in this way. Yeah. Life is a journey. That's what he's trying to depict. As legend say, life is a mystery as well. As human grew in the sands of time, he witnessed many, many miracles. Today, we also witness while a story being unfolded in front of our own eyes. Ladies and gentlemen, put your hands together to welcome Dr. Martin B. Leon. That is our Hyderabad, which is a mark of our India, and Hyderabad welcoming Dr. Leon. We all live on earth, but which part of the world defines who we are? We live and dwell in Fountainhead of the South, that is the Hyderabad. Hyderabad welcomes Dr. Martin B. Leon. We have million things acquired in our life, but as depicted, utmost important thing in human life, apart from it, everything is health, and precisely the heart, the cardiac health, as what is depicted here. We are all proud as a cardiologist. We think heart is the best and most important, and something very important contribution happened to this from Dr. Martin B. Leon. Apart from talking about cardiac health, today we are going to embark upon a journey of an individual who is a pioneer in medical profession in the field of cardiovascular medicine. As some of you might know, he was born to Israeli mother in USA. and to fulfill his mother's wish to give something back to our motherland, Israel. He holds the position of Professor of Medicine at Columbia University Medical Center. Previously served as the Director of Columbia Interventional Cardiovascular Care until recently. Presently fulfills the role of Chief Innovation Officer and the Director of Cardiovascular Data Science Center for Division of Cardiology. He is the founder and Chairman Emeritus of Cardiovascular Research Foundation and Director as well as the founder of the main meeting, which is Transcatheter Cardiovascular Therapeutics. I thought some of the press and media are also here, that's why I'm telling about these basics. The cardiology colleagues should excuse me for this. The TCT is what is his brainchild. When we were students, actually it was our wish and desire that to go and attend it. But God is kind enough, and it has happened through colleagues Sushil, Ajay and all other friends that we are able to sit and conduct that program in our country too for the benefit of our Indian audience. Thank you for this association and for making us possible for the TCT this year as TCT Plus India. He conducted in this arena, I think many of you know him for his lot of multi-center clinical trials and many other things, over 50 of them, with an impressive portfolio of contributions. And he has authored over more than 1550 publications and has performed more than 10,000 interventional procedures. And this is all a great tribute for all the patients who got benefited. But some of the procedures which we brought to interventional cardiology, be it with stenting or regulating stents and now the TAVI. He is supposed to be Everest-like in cardiology with all his contributions. He is visionary, his leadership and innovative mindset have solidified his standing as a thought leader in the expanding subspecialty of interventional cardiovascular device and drug therapies. What is depicted here is through his vision, not only the US patients of cardiovascular disease, but across the world, a lot of benefits happen. And all of us are extremely thankful for all what he has done for the patient care. He thought it is only injections, but we also do interventions with catheters. So wish we could do that. As a doctor, generally people think it is injections, but a lot of interventional procedures without cutting has happened in the cath lab arena through his participation, cooperation and innovation. He has innumerable achievements to depict. You know about bare metal stents, DES, and now of late complex high-risk interventional procedures, chip type of procedures, TAVI. I think these are revolutionized and saved a lot of sick patients who have were dying early because of lack of treatment. One more great thing which Sushil always mentioned, and I also liked about it, is he likes terms like collaboration, working together, and then encouraging all juniors and everybody to help each other. That's how we developed this important high-risk procedures and developed this concept of heart team, and all of us together can do more good to these patients. He inspired many millions of younger doctors, cardiologists. I'm happy to say that I'm also one of them, along with many of the colleagues in the country and the world across. And CRF also works with one motto to defeat heart disease and how to prevent this, and then that's how we all are attached to this. And as he said already, all the friends, ladies and gentlemen, put your big hands while the inspirational life of Dr. Leon continues further as we are unveiling his painting as a portrait here. Thank you. Okay. He used the same sand to get that painting on, I was told. So, and we request Dr. Leon to come onto stage to receive this portrait. As they remove this, I thought any of the colleagues sitting here who have any thought process, doubts, or whatever you want to share with Dr. Leon, he has agreed to spend some time with us further, and feel free to discuss, ask any question, he will not mind, be it personal or professional. That's why we called it as open heart discussion with Dr. Leon. I feel thankful for this opportunity again, for he being here personally. So any of the colleagues who want to ask anything? It's unexpected for you. I think Dr. Sushil, Dr. Ajay, working with him, I think they get time to talk to him also. But if you want to ask or share anything towards him, then I'll also ask and then conclude. Anything you want to say, Sushil or Ajay? give one mic to sir there.
Yeah, no, I mean, first of all, that was from that artist. I can't remember his name, but that was amazing. The fact that he can do that with his hands. He should be an interventional cardiologist or a cardiac surgeon because his hands are amazing, is what I would say. But first, you know, to Marty, I mean, I think it symbolizes this meeting, and I think one thing I just want to highlight, and that everyone in the front row, the international faculty are all here. Because we all sort of believe the same as, you know, one of the things that Marty has always done is developed careers. There are a lot of people that can take, you know, do things and take credit, but, you know, where I am now is because of his support. And I think, and he's always sort of encouraged that. And so because he supports people, and the people that he supports support other people. And I think that's the attitude that we sort of all have to take. Because, you know, there's always opportunities to take a moment to help someone else get ahead in their career. And that will serve you well, and that will serve that person well. And I think that's what I've learned over the, I guess, I've been with Marty for, I think it's been 20 years now. And that's been an important component, and that means a lot to me. And I think that's sort of what we believe in. And I think to Eberhard, Alex, you know, Juan, Pradeep, Ajay, Gary, Kiko's here, and others, so many others. We come because we're part of that same tree. And I think we all, you know, attitude, I think it's better for everyone. And so that's just, you know, one small comment to make, and I would encourage all of you to sort of look at it that way, and that, you know, that there's always growth by helping someone else move further in their careers as well.
Thank you, Sushil. I think whatever questions we were asking, we are also keeping reserve because he has 2 keynote addresses tomorrow. Actually, the future of structural heart interventions and what is there for us in pipeline. And heart failure, again, his passion of late, his cases are increasing. So requested him to share his. I think if no further questions, I think we'll have more discussion and interaction after you to enjoy the cultural program which is going to follow, and then Promotional. And if there are no further questions, we'll close. But I think singer and composer, Kiravani, Kiravani and all that troupe members are also with him. So request all of you to stay back till the stage is set for 10 minutes and enjoy the dinner after this cultural program. Thank you. The consultant wants to ask something.
I want to congratulate Leon and Mrs. Dr. Srinivas Kumar. My sister, stand up. Come on.
Thank you, Anita, and for both my kids. They say a lot of their personal time is given to this meeting, but I'm extremely thankful for the personal cooperation, and always, you need anything to do, always better. Very loving, and fortunately, they're also loving medicine and cardiology. Thank you.